Happy morning to all IOCCONians. Yes, happy morning to all International Oral Cancer Congress participants. Dr. Srividya, are you there? Could you please unmute?
Yes, she is online, but she didn't respond.
Yeah.
Hello.
Yeah, Dr. Srividya. Good morning.
Hello.
Yeah, you are audible.
Am I audible?
Yeah,
Good morning, sir. Okay. So shall I start with the introduction then, or should I wait?
No, you should start because it's at 10:20. So you can start. Our first speaker is Dr. Asim Mishra.
Okay. Okay, sir. Okay.
He is there in the meeting room. You just give his formal introduction, and we can start the day for today. Yeah. Okay.
Okay, sir. Okay. Good morning, everyone. In this morning, I invite everyone for their dedication in listening for the past 4 days. And today we will be culminating our national international congress on cancer. So the first speaker for the meeting will be Dr. Asim Mishra. He is associate professor and head in charge currently in the Department of Head and Neck Services in Homi Baba Cancer Hospital and Tata Memorial Center, Varanasi. He has more than 11 years of experience in the field of head and neck oncology. He is involved in various randomized control trials, community based screening programs, as well as national programs for the control and awareness of cancer. He has many peer reviewed publications under his name. He is actively involved in training future resident surgeons as well as otolaryngologists in devising future methodology for controlling as well as surgical methods for treating cancers in oncology. His area of interest include head and neck surgery, skull-based oncology, cancer screening and control program, as well as cancer awareness. Over to you, sir.
So thank you for the invitation, and I thank the organizers for giving me this opportunity. Is my screen visible?
Yes, it's visible, sir.
So I'll be discussing on the principles of management of the thyroid cancers. Now, why thyroid cancers in an oral oncology meeting is very important, because all the oral cancer surgeons, they definitely come across a lot of thyroid cancer patients as well. And it is very important that they understand this small concept, that how they are going to at least recommend treatment to those patients or refer those patients as and when needed. So now when we talk about principles of thyroid cancers, it is based on the management principles and then key surgical aspects. So now we'll be only discussing the management principles, that how we are coming to the diagnosis and how we are going to manage them in an appropriate manner. And the reason is there are several myths that are associated with thyroid cancers. Like all thyroid cancers, they require an aggressive treatment, just like a oral cancer or any other cancer. So all thyroid cancers are not as aggressive as a squamous cell carcinoma or an adenocarcinoma or even an adenoid cystic carcinoma. These are benign diseases. These are not benign. These are indolent diseases, and they have a very good survival. And therefore, it is very important that we manage these patients appropriately and avoid complications in all cases possible. Now, whenever we talk about oral cancers, we are thinking about doing a surgery of the primary and also the surgery of the neck. However, all thyroid cancers, they don't need a central or a lateral neck dissection, and that is also very important. Similarly, oral cancers, they are associated with adjuvant treatment. But in thyroid cancers, this is done by radioactive iodine treatment. However, all thyroid cancers will not require radioiodine treatment. It will be only very, very selective group of patients. So we have to break down these myths, understand, and so that we are able to counsel our patients appropriately. And the problem that we are having is because of the very, very dominant preconceived myths and beliefs that we are having, that this is aggressive treatment, it is cancer, cancer must be treated aggressively, it may recur, it may spread, it may metastasize, everything. And we have to break those myths. And there are several long-standing institutional and personal philosophies also, that I manage it in this manner and therefore this is the best treatment. Or I am from so and so, and that is why this is the treatment that I'm going to give. However, the evidence-based practices are very important to offer the best treatment. And these practices, many of them are unnecessary. And unnecessary big operations are leading to complications. And therefore, it is very important that we optimize the treatment and offer the best treatment possible. And the reason now we are talking about is incidentaloma. Now, when we talk about thyroid cancers, most of the thyroid cancers, almost 8 to 40% of them in several scenarios, are incidentaloma or incidentally detected. They were not supposed to be worked up. If went unnoticed, the patient may have died with an old age with that disease or thyroid malignancy. However, some investigation was done for the patient, like a PET scan or a USG scan for a neck swelling or something, and then a thyroid nodule was detected. So these are the incidentalomas. So majority of the thyroid cancers, they are detected incidentally. Now, when we detect something incidentally, that means we have to be very, very careful in working them up as well. And when we talk about the rates of the malignancy, it is also not very high. It's less than 5% in those incidentalomas. So first thing is, almost less than 10% of the people are going to have the incidentalomas. And out of those 10%, just 5% of the entire number is going to be malignant. And a lot of CT scans, a lot of PET scans that are done, they'll show some swelling or uptake in the thyroid nodule. And then the patient will become worried that this is something. And if the doctor also becomes worried about that, yeah, you have some thyroid nodule, you must go and get it worked up. And that is why patients become very, very fearful. And we have to avoid making the patients fearful. We have to avoid getting them into that fear. And once they are in that enigma, they undergo surgery, they undergo so many treatments. And that is what we are supposed to avoid. And the incidentalomas, whether they are malignant or non-malignant, that also depends whether it's a focal uptake or a diffuse uptake. So all uptake on a PET scan or all nodules that are diagnosed on a CT scan done for any cancer of the body does not mean that they are going to have malignancies, and all incidentally detected tumors need not be treated. Now, why we are talking about this? Because when we have reviewed several databases across the world, there are several studies as well. These incidentally detected thyroid cancers, they do not harbor any malignancy, and almost 56% of the thyroid surgeries are unnecessary, almost 68% for that matter in Bethesda category 4, and 21% of the surgeries in Bethesda category 5 nodules also are unnecessary surgeries. So more than half of the patients with Bethesda 3 and 4 nodules that are diagnosed on FNA, they're undergoing an unnecessary surgery. And that is what we have to focus upon avoiding. When we talk about oral cancers, there are age-associated risk factors. And as the age increases, somewhere around 55 to 65 and 65 plus, the incidence in the lower age group is crossing over a period of in the last decade. However, when we see the trend in thyroid cancers, we see that somewhere in the age of 40 to 50, where the patient is most active in the span of their life, when they're getting workup done, when they're getting health checkups done, and they are getting a detection of a thyroid nodule. And that is what is building up the maximum number of thyroid surgeries at that age, and a lot of them are unnecessary. So what is the priority principle that we need to acknowledge is that what and how we are going to address the primary tumor, whether or not we are going to do a neck dissection for them, and how are we going to handle if the nerve is involved. Because the involvement of the nerve is very important when we are managing a thyroid cancers. And second, the most important thing is identifying and preserving the parathyroid glands. Because this surgery may look very easy, but the long-term complications are going to be very, very gruesome. And a lot of these patients, almost all of them, 100% of the patients are going to survive, and they're going to live with that complication. So first thing, which thyroid nodule are we supposed to evaluate? So if an incidentally detected thyroid nodule is there, and if it is of size more than 1 centimeter, with some features of malignancy, like microcalcifications taller than wider, with peripheral vascularization, those nodules need to be FNAC'd. So you do not have to FNAC all the nodules. You can directly ask them to observe if it's a benign looking nodule which is incidentally detected and which is less than 1 centimeter of size. Now, in very, very specific scenarios like high risk features where there is a family history of thyroid cancer, where there is family history of cancer, or the patient has been treated for some other cancer previously, in those scenarios, or the patient has been exposed to radiation, or in a high risk radiation areas, only those patients with a thyroid nodule of less than 1 centimeter, they need to be FNAC'd. So we have to be very, very clear which thyroid nodules need to be FNAC'd to get a diagnosis. So what are the high risk features? It is extremes of age. If it's in the less than 15 years of age or more than 55 years of age, you are detecting a thyroid nodule. There is a prior radiation history. There is a family history of thyroid cancers or association of any thyroid cancer syndromes like familial adenomatosis, polyposis, Cowden's disease, Carney's complex, or Werner's syndrome. If there is a rapid increase in the size of the nodule, if there are associated features like hoarseness of the voice, difficulty in swallowing, or any signs of breathlessness, in those cases, you have to work up the thyroid nodule and consider treatment. Now, another common myth that if there are multifocal papillary thyroid cancers or multifocal nodules, they are going to have a bad outcome. That is just a myth. Oncological outcomes in both, whether it's a unifocal disease or a multifocal disease, is comparable, and therefore they do not require an aggressive treatment. Now, a lot of patients, they have undergone a lobectomy or a hemithyroidectomy, even in a unifocal or a multifocal disease. We have found that the survival is comparable in unifocal as well as multifocal disease. So there is no difference in disease-specific survival. The survival, whether it's a recurrence-free survival or a disease-specific survival, it's 100% in both these groups. So whether you do when you do a lobectomy in a unifocal or a multifocal disease, lobectomy offers a very good survival. And when we compare with lobectomy versus total thyroidectomy, even then, the local recurrence, the neck recurrence, the distant recurrence-free survival, it is similar. Therefore, there is no need to push patients for a total thyroidectomy, even if it's a malignant nodule. Now, the second important thing when we consider doing an FNAC is the USG neg or sonography. The sonography is very important because the sonographic characteristics are going to decide whether we are going to work up that nodule or whether we are going to observe that nodule. So reading a sonology report is very important. So how do we do that? We have certain features like the microcalcification, the heterogeneous ecotexture, the increased peripheral vascularity, irregular margins taller than wider, and any absence of halos in the cortex. Those lesions need to be FNAC'd and worked up. If they are coming as benign, even after that, then you are going to observe them. You do not have to treat all the thyroid nodules which are shown up on a sonography. Now, when we manage them, we also need to have a very, very important risk stratification system so that we know that yes, these nodules need to be FNAC'd, these need to be observed. Now, these are certain ATA risk stratification characteristics of high suspicion, intermediate suspicion, low and very low suspicion, and when it's benign. And this is very important for everyone to know, because what happens is if just you are aware of these things, just by reading the report, you can definitely tell the patient that yes, you do not need to worry. You do not even need to get a biopsy or FNAC done. You can just go home. There is nothing to worry about. And that features has led to the formation of thyroid stratification system. And this thyroid stratification system is for thyroid imaging. So when a thyroid is imaged using a sonography, these features will help us tell whether it's a high suspicious, low suspicious, or a benign nodule. And a radiologist, they very well report these features and then they give a TI-RADS rating. So based on that also, we can counsel our patients whether we are going to treat them or going to observe them. So these are the ACR TI-RADS stratification. I would recommend everybody that they should be reading it and assessing it so that they're able to counsel and discuss with their patients. So when we do a sonography, we not only look for the target nodule, we also look for if there are presence of any the additional nodules there. What is the status of the other lobes? Suppose there is a nodule in right side of the thyroid gland, and the other lobe also have some nodules which may be malignant, which may have characteristics. Definitely, you would require to do a total thyroidectomy in such a scenario. However, if there is the status of the other lobe is clear, there is no nodule seen. There is no cervical lymphadenopathy that is associated with the thyroid nodule. We do not have to work up, or we do not have to treat, or we may just observe. So that is very important in a thyroid cancer. Once again, FNAC, it's a very simple and a reliable technique. Do not go ahead for any treatment of a thyroid nodule based on the imaging alone. You have to get an FNAC done. It is very easy to done. It is also going to decrease the number of thyroidectomies because a well-performed FNAC is going to give you a proper diagnosis, and that is going to avoid unnecessary surgeries. Now, a lot of people, they say that there is a thyroid nodule, whether you're going to do a sonography guided FNAC or a palpation guided FNAC. So there is no question or discussion right now in this. This is very simple. Even if you have a thyroid nodule which is properly seen, it is better that you do a sonographic guided FNAC, because then you are going to target the solid area of the thyroid nodule. You are going to target your FNAC properly so that your cytological yield is proper, that can be assessed on the microscope directly at the site of the FNAC itself. And you're able to avoid these, target it properly. It may that we FNA using a sonographic guidance. So there's a Bethesda category of system of reporting by the pathologist. It's a well-known system which is followed world over. And this is a must. Whenever you are seeing a cytology report, it must be reported as per the Bethesda system. If it is not, you'll have to discuss with your pathologist that they have to report it according to the Bethesda category. And from Bethesda category 1, which is a non-diagnostic aspirate, to Bethesda category 6, which is definitive malignancy, it is very important that the cytologist report based on the Bethesda system. So just for the sake of completion, I've just put up these 6 systems with the non-diagnostic benign follicular lesion of undetermined significance, neoplasm of undetermined significance, suspicious and malignant diseases. Now, a lot of investigations like thyroglobulin, calcitonin are being performed along with the thyroid nodule. So calcitonin, only when your FNAC is showing suspicious of a medullary carcinoma thyroid, or it is showing a medullary carcinoma thyroid, which is very, very different from a differentiated thyroid cancers. So when it is showing features of medullary or suspicious, only then a calcitonin and serum CEA levels needs to be done in a thyroid nodule. In all the other cases, it may be avoided. A routine assessment by doing a calcitonin is not indicated. Similarly, serum thyroglobulin, it is not beneficial because thyroglobulin is secreted from the thyroid capsules. So a intact thyroid gland is present. You do not have to do a serum thyroglobulin, not even a baseline. A thyroglobulin may be considered only after doing a total thyroidectomy, so that you have, if there is any residual thyroglobulin secretion from a thyroid nodule somewhere else in the body or from metastasis. Otherwise, it's just an observation that is required. Laryngoscopy is very important. All patients who have the thyroid nodule or are planned to undergo a thyroid surgery, they must get their vocal cord status checked, because this documentation is going to help us avoid a complication and know whether there is a complication or not. And there is no role of a PET-CT in a case of a differentiated thyroid cancer or a solitary thyroid nodule. So the bottom line is, when there is a less than 1 centimeter low risk thyroid nodule, we are going to treat them by hemithyrectomy. If it is a more than 4 centimeter, we are going to offer total thyrectomy. Now there is difference of opinion between 1 to 4 centimeter low risk nodules. It may be hemi or total thyrectomy depending upon the other features. Indications of total thyrectomy are less than 4 centimeter when there is a high risk nodule or there is a lymph node metastasis or a distant metastasis that is present at the time of diagnosis. If that is there, we are going to do a total. So this unbiased discussion has happened with the patient, and then follow the guidelines until the concrete evidence is available. Now, these are Japanese studies, and they have studied in the last 30 years that they can observe even a thyroid cancers. So if they have diagnosed thyroid nodule and FNACs, only a hemithyrectomy or ipsilateral central compartment clearance is done, and surgery was recommended for 1.5% patient due to low new nodal metastasis. And this was over a period of 5 years. So we have to understand that the progression is also very slow in a thyroid disease, and a lot of these patients may be observed as well. But when not to observe in a papillary microcarcinoma, when it's a young age, when it's a patient of less than 15 years of age, he has a history of childhood radiation exposure, which is causing a thyroid cancers, or there is a positive family history in multifocality disease and in aggressive cytological features. Those patients need not be observed. They have to be treated even with a small nodule. We have to be aware of the central compartment metastasis because this has been a debate whether we are going to do a central compartment neck dissection or not. So there are certain features like age less than 45 years, male gender, multifocal disease. These are associated with central compartment metastasis. However, we have to be careful. Without metastasis, we may not have to address the central compartment neck. Now, once again, the lateral, it's more common in younger age groups, more common in larger tumors, more common in papillary, followed by medullary, followed by follicular carcinomas, and when there is any mutation positive cancers in those cases. So thank you so much. The crux about the presentation that we would like to give is that whenever you have a thyroid malignancy, you do not have to jump upon treatment or an aggressive treatment all the time. Work up a patient appropriately so that you know the diagnosis, you know the workup, and you are aware that how you are going to manage that patient. And offer treatment when indicated in the right manner. So this is going to avoid a lot of fear generation in the patient as well. Thank you so much.
Thank you for such an insightful lecture, sir. Any questions from the audience? So for
Morning, sir. This is Dr. Abhay Kulkarni. I just
please.
joined little bit. Sir, actually, it is not exactly related to the topic which you had taught, but there is one question where I wanted your opinion on that. You said FNAC. It is FNAC and FNAB are the same terminologies, or they have got some different?
So FNAC and FNAB are different. So fine needle aspiration cytology in a thyroid malignancy, it is done by a 25 or a 26 gauge needle.
Okay.
So it's a very, so only the cytological characteristics are picked up, only cytology cells are picked up in a FNAC. When we talk about FNAB, it's a core biopsy using a sonography guided. So it's a thicker biopsy, it is going to give a tissue, and in a FNAC, it's only the cytology. So you are going to get the cytological cells. So when we talk about FNAC, it's a guided biopsy. But it is
Okay, sir. Okay.
once again done
Thank you.
by a
Thank you.
needle.
thanks a lot, sir.
Thank you.
So now we will be moving on to our next speaker of the day, Dr. Epsom Somi. She is Associate Professor in the Department of Oral and Maxillofacial Surgery, Baskent University, Faculty of Dentistry, Ankara, Turkey. She has also obtained her PhD degree from Oral and Maxillofacial Surgery from the same university. She has various peer-reviewed publications in SCI, SCIE, ESI, ESCI, and other international and national index journals. She has been facilitated with numerous awards for her oral presentations. She is the organizing secretary of the International Oral Cancer Congress 2025. Her area of interest include oral oncology, oral pathology, and TMJ disorders. She will be covering the topic of critical statistical mistakes in head and neck cancer studies. Over to you, ma'am.
Thank you, ma'am. Good morning. Would you let me share my screen, please? Will you help me? Because it's prohibited.
Dr. Efsun, you can try.
Can you let me?
You can try to share
Okay.
your slides. It's you can share.
Thank you. No. It's okay?
Yeah, it's visible.
Thank you. First of all, I thank to all you to kind invitation for this valuable conference. Hello, and my name is Efsun Somay. Today we will explore the critical yet often overlooked relationship between sarcopenia, trismus, and survival in head and neck cancer patients. It's a very hard topic, and it's a very complex topic for me to explain to you, because it's very complex for me too. Why does this topic matter? Oncology has made significant strides in tumor removal and cancer therapy, but are we doing enough to ensure our patients thrive after treatment? A patient who survives cancer but cannot eat due to muscle loss or trismus has lost their quality of life. And understanding sarcopenia and trismus is essential for enhancing patient survival and recovery after treatment. First of all, head and neck cancers represents the ninth most prevalent malignancy globally, account for over 650,000 new cases annually, and more than 330 deaths globally. And these cancers arise from multiple anatomical regions, and including the oral cavity, pharynx, larynx, and paranasal sinuses, and posing diverse treatment and challenges. So, head and neck cancers presents complex challenges, and understanding of the impact of sarcopenia and trismus is critical for improving patient outcomes. What is sarcopenia? Sarcopenia refers to progressive and generalized loss of skeletal muscle mass, strength, and functionality, often exacerbated in cancer patients by systemic inflammation and cachexia. Well, aging contributes to sarcopenia. It's much more aggressive in cancer patients due to systemic inflammation from the tumor, nutritional deficiencies caused by swallowing difficulties, and metabolic change from cancer cachexia. For example, imagine your muscles as a factory. In a healthy body, there's a balance between muscle protein production and breakdown. And in sarcopenic patients, there is this balance shifts towards excessive breakdown, leading to severe muscle loss. The prevalence of sarcopenia varies from 20% to 70% among head and neck cancer. And older age, lower system, socioeconomic status, and geographic variation can play a role. And the higher incidence in advanced states, they commonly seen in advanced states in head and neck cancer and those undergoing aggressive treatments. The prevalence in a study composed by Jovanik et al., they stated that the prevalence of sarcopenia in head and neck cancer patients ranged from 35.5% to 54.5%. So sarcopenia has emerged as a critical determinant of prognosis and treatment tolerance and survival outcomes. Nutritional factors can play a role in etiology of sarcopenia in head and neck cancer patients. For example, malabsorption, reduced intake, cause reduced intake due to swallowing difficulties, and cancer cachexias can cause systemic inflammatory response and metabolic disturbance, and radiation-induced damage to swallowing muscles and chemotherapy-associated nausea and fatigue can cause sarcopenia, can play a role in etiology on sarcopenia in head and neck cancers. Year by year, there are a lot of authors define sarcopenia. In 1989, Rosenberg et al. Defines sarcopenia as a loss of muscle mass and function. Then the definition was changed in years, and lastly, Bahazin et al. Stated that sarcopenia is a loss of muscle strength and function. There's no common consensus about definition of sarcopenia yet. Sarcopenia is a neurodegenerative process reducing in anabolic hormone productions or sensitivity, dysregulation of cytokines secretions, and modification in inflammatory state. Muscle catabolism, protein turnover imbalance, and hormonal influences play roles in pathophysiology of sarcopenia. For example, elevated levels of cytokines like interleukin-6 and TNF-alpha may cause muscle catabolism and reduce synthesis and increase degradation of proteins, muscle proteins, will have to occur protein turnover imbalance, and the decline in anabolic hormones such as IGF-1 and testosterone can cause hormonal influences to occur to happen to sarcopenia in head and neck cancer. The relationship sarcopenia and survival, there are a lot of contributing factors. The main factors are inflammation, nutritional deficiencies, and treatment toxicities. Also, interleukin-6, TNF-alpha, and their role in cancer-induced systemic inflammation is a dominant parts of sarcopenia too. A study by Stone et al. In their study, they concluded that sarcopenia is strongly associated with poorer overall survival and progression-free survival. Studies show 2-year survival rate 36.5% in sarcopenic head and neck cancer patients, and compared to 60.5% in non-sarcopenic patients. There are clinical implications. Sarcopenia can cause treatment tolerance, but how? Sarcopenic patients exhibit higher rates of treatments or oncologic treatment interruptions, reduce efficacy, and increase toxicity. Then post-operative complications it can cause bad surgical outcomes, like postoperative complications, including infections and delayed recovery are more common. And quality of life, it deteriorates the quality of life for the patients. It impairs sarcopenia, impairs physical function, immune response, and overall well-being, further diminishing quality of life of patients. There is a in its etiology, trismus can be taken apart as a hypothesis. Trismus is a debilitating condition characterized by restricted mouth opening and commonly occurring as long-term complication of head and neck cancer treatment, and it affects 28 to 42% of head and neck cancer patients in post-radiotherapy period. Inflammation, fibrosis, and usually, especially inflammation and fibrosis, can cause, due to radiotherapy or oncologic treatment, can cause trismus in head and neck cancer patients. What is the interplay between sarcopenia and trismus? The study by Kobochi et al. Declares that sarcopenia and trismus share similar pathophysiological pathways, including systemic inflammation, cytokine storms, radiation-induced fibrosis, and they exacerbate malnutrition and functional decline. In a study composed by Kashihara, they stated the neutrophil lymphocyte ratio, platelet lymphocyte ratio, and lymphocyte monocyte ratio. They investigated the effects of these biomarkers on sarcopenia. So they found the statistically significant relationship with these biomarkers and sarcopenia. We know from the past publications, these biomarkers are also effective on the occurrence of trismus too. So they share similar pathophysiological pathways. Sarcopenia exacerbates weakness in masticatory muscles, and then trismus limits oral intake and accelerating sarcopenia. Then sarcopenia and trismus perpetuate each other, worsening outcomes. In a study by Brie et al., they used to measure sarcopenia, the index masticatory muscle, skeletal muscles, by measuring pterygioid and masseter muscle. They assess them at the level of mandibular notch, and they also concluded that the pterygioid and masseter muscles are responsible for trismus, causing trismus, and we commonly determine the sarcopenia if we measure this sarcopenia with these muscles, and they are related to trismus, so they can play a role in their each pathophysiologic mechanism. Nutritional deficiencies caused by sarcopenia and trismus also leads to weight loss, weakened immunity, and impaired treatment tolerance. Additionally, malnutrition negatively affects the clinical outcomes, treatment response, and overall survival of cancer patients, increased complication rates, poor postoperative outcomes, and longer hospitalization, and a poor quality of life. And so cancer-related malnutrition may account up to 20% of cancer deaths and may lead to cachexia, a significant predictor of overall survival, characterized by unintentional weight loss and body loss mass index and reduced mass. So we conclude that it's concluded that it may affect 75% of cancer patients too. What we can do to support the nutritional status for sarcopenia and trismus, with caloric protein needs, tailored plans based on patient requirements, and enteral nutrition for using feeding tubes for severe trismus and malnutrition, and supplements like omega-3 fatty acids and vitamin D. Giacosa et al. Reported that some critical factors in sarcopenia can play a role, like low protein intake, low muscular protein synthesis, low serum vitamin D, low intake of omega-3 fatty acids, and microbiota unbalance and sedentarism. There are some diagnostic tools for sarcopenia. We can use imaging techniques, like skeletal muscle index, cross-sectional muscle area, and novel approaches like masseter muscle volume assessment. And how we can diagnose trismus with mouth opening measurements and fibrosis evaluation. In the literature, the authors mostly cited Digitra et al.'s classification for head and neck cancer patients, restricted mouth opening level. This level is 35 millimeters. So we named the patients as trismus status, the patients whose maximum mouth opening under 35 millimeters, we can call these patients trismus patients. We use some techniques for measuring mouth openings, and 3 fingers caliper and electronic caliper, and widely used terabyte open mouth scale. Sarcopenia leads higher rates of radiotherapy interruptions, as I said before, and chemotherapy toxicity and treatment gaps, reducing overall treatment efficiency. The Atay et al. Declared in their study that overall survival tended to be shortened in a sarcopenic group than in non-sarcopenic group, and also progression-free survival was significantly better in the non-sarcopenic group than sarcopenic group. So sarcopenia is important in survival of these patients. Despite the advances in radiotherapy, these complications not diminished, but their incidence are minimized with these techniques, like intensity modulated radiotherapy and volumetric modulated arc therapy. In a study composed by Peterson, they stated that mastication structure mean dose by more recent radiotherapy techniques were generally below proposed tolerance doses, with dose reductions 10 to 20 gray compared with earlier techniques. Then modern radiotherapy without mastication structure sparing intent results in below 10% of head and neck cancer patients experiencing trismus compared with 60% treated with earlier techniques. So with the help of the advances in the radiotherapy, the complication risk like trismus prevalence is decreased. Sarcopenia affects the immune functions of patients, head and neck cancer patients. Sarcopenia impairs immune response, increasing the susceptibility to infections and reducing treatment efficacy. In a study by Zhang et al., they reported that interleukin-6, TNF alpha, interferon gamma can cause apoptosis and decreased regeneration in muscle cell, then reduced muscle cell, they can cause reduced muscle cell, and with the help of the inflammation, it can cause sarcopenia. These biomarkers is also effective in trismus, radiation-induced trismus, or oncologic treatment cause trismus. So the pathophysiology is the clue for the same pathology. Sarcopenia leads to muscle weakness, including jaw muscles. Then trismus occurs, and trismus restricts oral intake and exacerbating sarcopenia. So at the end, bidirectional relationship worsens survival outcomes. In a study Low occlusal force, reduced masticator muscles, thickness, wearing dentures, and loss of natural teeth can may cause low protein intake. Then, with the association of oral hypofunction, reduced tongue pressure, and reduced chewing function, they all form sarcopenia in head and neck cancer patients. What is the impact of sarcopenia on survival? First, reduced muscle mass caused poor treatment tolerance and high rates of chemotherapy and radiotherapy and toxicity, and increased hospitalization times, and mortality. A study by Anajapapa et al. They declared that they examined 246 patients, and they examined of these patients, 58% of these patients investigated had pretreatment sarcopenia, and approximately 20% of these sarcopenic patients had treatment interruptions lasting more than a week. Then we concluded this station that sarcopenia affects the oncologic treatment, badly affects the oncologic treatment efficacy. While examining the impact of sarcopenia, we faced three main points. First, direct effects of sarcopenia on survival. Reduced muscle mass correlates with higher mortality. Sarcopenia significantly reduces the survival rate in head and neck cancer patients due to impaired immune function and decreased physical resilience and higher rates of treatment-related complications. And loss of skeletal muscles, mass patients' ability to tolerate skeletal muscles, I mean masticator muscles too. Aggressive therapies like chemotherapy and radiation, leading poorer overall outcomes. Then, sarcopenia cause increased infections and delayed recovery. These two main points have an effect on worse, poorer survival. And sarcopenia causes impaired mobility and decreased treatment adherence. What is the impact of trismus on survival? Trismus caused nutritional deficiencies from impaired oral intake and compromised rehabilitation post-treatment, and a higher risk of aspiration pneumonia and infections. Then it's the survival rates. As also study, they declared that trismus was most prevalent in patients with oral and oropharyngeal cancer. Then a trend towards worse 5-year overall survival was seen among patients with trismus, like sarcopenia too. There are some inflammatory pathways in muscle wasting. In muscle wasting, pathways of wasting, the case tokens like interleukin 6, interleukin TNF alpha, and interferon gamma play a effective role in pathways of muscle wasting. They all induce muscle protein degradation and promote cachexia, fibrosis, and jaw muscles. Then they can cause trismus too. The role of radiotherapy in muscle damage is must not be neglected because radiotherapy cause fibrosis development in masticator muscles and radiation-induced systemic inflammation, and potentially exacerbates both sarcopenia and trismus and aggravated in vicious cycle. Multidisciplinary management strategies is important for treatment of these complications. So oncologists, dietitians, and physiotherapists and speech therapists can be a part in this team, and we must perform integrated care plans for early intervention and customized rehabilitation programs. In multidisciplinary team, the physicians and the doctors examine some structures, some effective structures, those important for both sarcopenia and trismus. Skin, oral mucosa, teeth, jawbones, salivary glands, muscles and soft tissues, temporomandibular joint, tongue and taste buds, and alteration of smell and others. So they examine by examining these structures, they determine dermatitis, mucositis, caries, hypercoloration, fibrosis, and trismus, dysphagia, and speak difficulties, etc. So these structures are both common affected in sarcopenia and trismus. Trismus and survival outcomes. Trismus, as you know, negatively impacts eating, speaking, and dental hygiene, affecting oral health and survival. Masseter muscle and pterygoid muscle, also masseter muscle, is important for chewing, and first affected area is masseter muscle in trismus. The radiotherapy can induce fibrosis, further worsening trismus and leading to long-term complications. Basically, radiotherapy can cause releasing of cytokines and systemic inflammation. These biological mechanisms are also responsible for trismus. Then decrease in masseter muscle, the reduced mastication efficacy, and potentially leading to difficulties in proper food intake. Reduced mastication efficacy and increase of risk of malnutrition cause sarcopenia at the end of the day. So there are some conclusions about my presentation. Sarcopenia and trismus are interrelated and serve as significant concerns in patients diagnosed with head and neck cancer. Both conditions profoundly impact treatment efficacy, survival outcomes, and quality of life. The pathophysiological mechanism underlying these conditions are to a large extent shared pretty reciprocal relationship. Sarcopenia may contribute to onset of trismus by impairing the function of the masticatory muscles. Conversely, trismus can deteriorate sarcopenia by restricting nutritional intake if not addressed in a timely and appropriate manner. So by adopting a holistic strategy, healthcare professionals can improve patient outcomes and enhance the quality of life for those affected by sarcopenia and trismus too. So future research should focus on understanding the molecular links between sarcopenia and trismus to develop more effective prevention and treatment strategies. As a conclusion, the early detection and integrated management improve outcomes. We must know this, and sarcopenia and trismus require a holistic multidisciplinary research. So we should promote research, patient education, and policy reforms. So foster collaboration across specialties for comprehensive care. Thanks for your patience.
Thank you, ma'am. Any questions from the audience?
Yeah, good morning, madam. This is
Good
Dr. Abhay
morning.
Kulkarni. Yeah, first of all, very nice presentation and a new information we have got through your presentation. And in fact, I would love to do research in these matters. So we'll be needing your guidance in future. So please, will you please share your email ID in the chat box or somewhere where I can contact you for further this thing. That's a
Of
request.
course,
And
my
yeah,
pleasure.
yeah. And secondly, uh,
Mhm.
my question is, to diagnose sarcopenia now, only trismus is the factor. Like if the patient is more having a trismus, that means the patient is suffering more from sarcopenia. That's what is we should say, or anything else parameter by which we can judge the sarcopenia in head and neck cancer patients.
Who diagnosed first? Radiologist and radiation oncologist diagnosed the sarcopenia from skeletal muscle index, and recently we use a total masseter muscle volume for the imaging, and oncological patients regulates their ways for treatment outcomes and treatment interruptions. Body mass index is also calculated by radiation oncologists and oncologists. Then they in our institution we perform a very occur multiple team. Then we by maxillofacial surgeon as being a maxillofacial surgeon, we determine the treatment. So three complements join, and we have an opinion about the sarcopenic status of the patients too. A multidisciplinary team is also important for this determining. So, sarcopenia is most important thing that affects survival of the patients too. We usually examine the patients before the beginning of the therapy and treatment. So we also take a deal with our patients, and we follow up patients for sarcopenia, trismus, and tooth loss that causing trismus and sarcopenia.
Okay.
Yes, so thank you.
Please share your email ID, ma'am, for further reference, for further
Thank
contact.
you. Of course, of course.
Thanks again, ma'am, for giving such a in-depth knowledge on a new topic, which is also relevant in cancer patients. So the next speaker for the day is Dr. Srinivasan.
Good morning. Are you able to hear me?
Yes, sir, you're audible. Dia, will you please introduce Dr. Srinivasan for the gathering?
Yes, ma'am. It'll be my honor, ma'am.
Yeah,
So the next guest speaker that we have for today is Dr. B. Srinivasan. Sir is a maxillofacial prosthodontist and dental oncologist, as well as the founder of Enhanced Head Neck Rehabilitation. Sir serves as a consultant at multiple prestigious hospitals in India, including Sir H.N. Reliance Hospital in Mumbai and several hospitals in Pune, such as Jahangir Hospital, Ruby Hall Cancer Center, and KEM Hospital. His leadership roles include Vice President of the International Society for Maxillofacial Rehabilitation and the founder of the Association for Maxillofacial Prosthodontics and Rehabilitation in India. Sir has also been actively involved with the Indian Prosthodontic Society as a former executive committee member and the past president of its Pune branch. Sir's professional achievements include participation in the WHO's Call for Action 2030 in Geneva and receiving multiple international fellowships from the Union of International Cancer Control UICC for advanced training in the Netherlands and Sweden. Notably, he has performed what is possibly the first ever remote treatment for an ear prosthesis, which was recognized by the Australian High Commissioner to India and featured in the Times of India. Sir is also an innovator, having received the Biotechnology Ignition Grant from BIRAC, Government of India, and serves as a reviewer for the same organization. His contributions to academia include authoring a chapter on prosthetic rehabilitation in head and neck surgery textbook and publishing a case report on a customized ocular prosthesis in a renowned maxillofacial rehabilitation book. So, as a philanthropist, he manages the Enhanced Social Initiative Trust to support patients in need. He is a frequent speaker at national and international conferences and has undergone training in social entrepreneurship, including fellowships with United Limited India and the Stanford Sea Spark program. His collaborations extend globally, working with institutions like Highland Medical Center in Switzerland and organizations such as Tara Trust and Andhra Medtech Zone to improve cancer care accessibility. Sir holds degrees from Bharati Vidyapith Dental College, Government Dental College and Hospital, and has trained at Tata Memorial Hospital and the University Medical Center Groningen in the Netherlands. So for today's topic, sir, we welcome you, sir, on the topic Impact of Technology in Maxillofacial Prosthetic Reconstruction and Rehabilitation. We welcome you, sir.
Thank you, Dia, for your kind words of introduction. Am I audible? And is my Is my slide visible to all?
Yes, sir, you're audible and your slide is visible, sir.
Thank you. Thank you so much. Thank you everyone for this very kind and warm welcome and gathering here, around your respective computers on a Sunday morning. So here I am to talk about what technology has been able to do in terms of creating the much needed impact for an unmet need of head and neck cancer rehabilitation. Um, I mean, I'm a very strong believer of the fact that technology, if it is accessible only to the elite, it is irrelevant. For it to create the much needed impact, it is absolutely mandatory for it to be accessible by the masses. It should be both affordable and accessible for those who need it the most. And only then is that technology really relevant, at least in my eyes. So I'm a big fan of frugal innovation, and especially in light of the strides that our country, India has made in the recent past, where we successfully, launched, our space program, and at a cost which is lower than many of the Hollywood movies, is an inspiration enough to suggest that we in India can achieve a lot, and that too at a fraction of the cost that is possible in the West. With that, if I may say, the central idea, I would like to take this entire discussion forward, which is frugal innovation and how it can really impact the lives of so many in need. Now, the facial disfigurement is actually a problem statement for many patients in their millions across the world. We don't see these patients and we don't recognize their problems either, because these are not discussed on many of the fora, at a national or international at a level. But it's a huge problem because it creates physical, financial, emotional issues for a lot of these patients who are actually in their millions, and significantly alters their productivity. It alters their quality and dignity for life, which is a right for every human. And the unfortunate part is that less than 5% of these patients undergo any kind of rehabilitative treatments which can help them get reintegrated back into society. The vast majority of these patients accept their problems with a fatalistic attitude. Now, the importance of rehabilitation has been established in literature for many years now. So it's really appalling that even to this date, despite the fact that it's been established, over 40 or 50 years ago, we still have a very long way to go in terms of implementation of these rehabilitative services on the ground. So the burning issues of these patients are pretty much obvious, especially if they've lost a portion of their face or their mouth. It's ranging from speech, swallowing appearance, chewing, and productivity. Huge loss of self-esteem for a lot of these patients because of these disabilities. And you would be surprised to note that these kinds of the WHO does not treat or does not mention any of these as disabilities. I'm happy to be proven wrong on this front, but this is my understanding. So the problem is that the accessibility and affordability for these kinds of rehabilitative services takes a beating, and the care to patient ratio is extremely skewed, with patients needing to travel across geographies to be able to access care, and that's the biggest bottleneck, the way I look at it. So, I mean, let's straight away get into the statement of the problem through a small video, and how we really try to use technology to and ensure that care reached somebody who was otherwise inaccessible. She was a lady from Kashmir and attacked by a bear and lost a major chunk of her face. And it was very difficult for both her to come to pool and spend a lot of time, and very difficult for me either to spend a lot of time with her, in where she was residing. So, sorry. So, I'm sorry for this glitch. Yeah. So the biggest part of this particular journey was that a major chunk of this process was without even seeing the patient. So over 90% of this journey was without seeing the patient, and this was remote healthcare delivery in its true sense. At least that is what we attempted it to be. So now we know that whether it's oncology or craniofacial defects of any types, you have an entire team which is working behind the patient, and this is how it should genuinely be done so that the outcomes are favorable. But technology has really changed the workflows, and it has, in a scenario where high skill and experience or low affordability and accessibility are major challenges, technology, we felt, had the promise to de-skill the process, make treatment more precise, time efficient, affordable, accessible, and more importantly, scalable, so that there are thousands and lakhs of patients who can actually be benefited. Now we looked around the literature and felt that there was enough evidence in the literature to suggest that technology can be harnessed, and it sounds really promising. So we came out with a digital protocol with support from a grant from the government of India, BIRAC, and with very tangible benefits for an innovative solution to patients, wherein we could treat the patient without even seeing the patient, without calling the patient to our treatment centers, and de-skill the entire process, so that even entry-level clinicians with minimalistic skill sets can also start treating these patients. Now, the only way to look around for solutions is sometimes not necessarily in your domain of expertise. So we were using remote control on a day-to-day basis. We were used to hyper local delivery and to courier services and logistics being taken care of by different companies. And we are also used to ready-to-eat solutions in our day-to-day lives. So we just try to put all these things together and combine remote control, doorstep delivery, and ready-to-eat solutions, and convert the analogy to a remote data capture and design a doorstep delivery and a ready-to-treat solution. So this, we embarked on an ambitious project of trying to use the mobile phone as a scanning device, because we felt that the way in which the mobile phone has really penetrated the Indian market has caught the imagination of a lot of people. Its reach is unparalleled today. And we felt that if we are able to use the digital technology behind the use of the mobile phone, we may be able to solve a very big problem. So we started with a CT scan because of its omnipresence in the primary health centers, and then slowly started graduating towards the use of the mobile phone. So all we needed here was a CT scan from the patient or a mobile phone scan, which any one of you can do, or even the patients can do actually from the comfort of their homes, and then send us the data. So the data that is acquired through a CT scan or a mobile phone can be processed through different softwares, and then we can make do with the designing the prosthesis. So in this particular case that I was talking about, the lady, we got certain CT scans, we just got a dental impressions, and we started designing the entire prosthesis, the maxillary prosthesis, based on assumptions related to the fundamental principles of prosthetic dentistry. And then once we had the obturator designed and processed through multiple steps, we started designing the entire prosthesis, because we had to do the intraoral prosthesis first before commencing with the facial prosthesis. It was designed using software, and then through a series of CAD related steps, a silicone prosthesis with a base color based on photographs was the result. And mind you, we have not seen the patient at all at this point of time, relying completely on CAD data and photographs. And and we finally called the patient. Yes, a few tweaks had to be made with respect to the prosthesis because of altered lip lines and things like that. So minor tweaks were definitely required, but a major chunk of the prosthesis was ready even before we saw the patient. And then, so we were able, in this entire journey for the patient, she did not have to spend many weeks or months leaving her place of residence and then going to a different city and staying there. spending huge amounts of money for travel, lodging, and boarding, but she had to spend very little time. So that made the process really frugal. So this was the entire journey that she went through, and I can just share the entire journey with you. Yeah. This process eliminated the need for a clinical doctor to be highly skilled with their hands or behaving like a sculptor. The use of CAD and 3D printing simplified the entire process.
के जो चेहरा था, चेहरे की भी रंगत आ गई है और वही पुरानी तरीके से देख रही है और 2-3-4 दिन हो गए लगभग वो खा पा भी रही है अच्छे तरीके से।
So, but we did not stop, with just this patient, and it really enhanced our confidence a lot that we can indeed start treating patients remotely, and we started utilizing this use case into other kinds of defects as well. For example, a cheek defect where you don't really have to be in front of the patient anymore. A lot of these patients who undergo radiation therapy end up with orocutaneous fistulae, and these kinds of huge defects on the cheeks are not necessarily amenable to plastic reconstructive surgery. So we were able to use our entire protocol to create a cheek prosthesis for this particular patient. And again, he was located about 800 kilometers away from us, and all he needed to spend with us was a couple of hours so that we can tweak the prosthesis. So this was really a game-changing experience as far as the patient was concerned. We try to extend this entire process for maxillary defects as well. So now if you have a general practitioner who is seeing such a patient, but feels that he's not really, trained enough to start with the impression procedure right from the beginning, we can use our protocol to at least create a skeleton of the maxillary prosthesis, and all that the clinician now needs to do is reline the entire prosthesis. Now, relining the prosthesis is going to be way easier than starting from scratch. So that really ensures that this process can now be simplified so that people with minimalistic skill sets can also explore treating such patients in need. So you don't have to make flamboyant prosthesis every time. Sometimes, a simple plate can solve the problem as well. Now, here was a patient who had a lot of trismus, and he had a maxillary defect, had undergone multiple surgeries, and just had 3 teeth, in the oral cavity. Now, an conventional obturator prosthesis using impressions was very difficult due to trismus. We use the same technology, to be able to create a model from which we can actually fabricate a plate. And the biggest takeaway for this particular patient was that the Ryle's tube was eliminated and he was able to feed through the mouth. So it need not necessarily remain, these prostheses need not be flamboyant, and extravagant. The kind of social impact that this creates is enormous. Now, an ear prosthesis that has been made for a girl who was not necessarily willing to go to school, due to peer ridicule, changed her entire, way at looking at life. From being a social recluse, she suddenly exploded onto Instagram. So also this young boy, 19 years of age, who because of bilaterally missing ears, even went to the extent of contemplating suicide because of peer ridicule again. Now you give him an auricular prosthesis or a prosthesis, because there were two, and see the transformation. It's there to see. So these are all life-changing prostheses, and they can make a huge change in the lives of people. So Remate, we pushed our boundaries from just treating patients within India and went on to try out the treatment modalities to check if we can collaborate with people to give these patients at remote locations, even overseas. And yes, it works, because we were able to treat a patient with bilateral auricular prosthesis for a patient in Sydney. And we were fortunate enough to get some eyeballs for this particular case, where it was tweeted by the Australian High Commissioner to India, and also found a mention in the Times of India during the peak of the lockdown. So bottom line is that the patient and doctor location now becomes completely agnostic, and you don't really need the patient to travel. It's the data that can travel over the internet, and with the judicious use of CAD and technology, you can really make a huge difference. Data from home is what we are essentially looking for, and you can look at the use of the mobile phone as a scanning by the patients themselves. The patients themselves can look at these, look at the protocol, make their own scans, send it to us, and we can manufacture and send these prostheses to a clinician in the vicinity of the patient, who can help fit the prosthesis and tweak it for the patient. So this is going to simplify the entire workflow for a lot of patients. So, but we are merely looking at the tip of the iceberg. We are going to be embarking on machine learning and a lot of similar high-end technologies, which is going to simplify the entire process even further. Augmented reality, mixed reality are all going to be the order of the day in times to come. This was our first test case with the use of machine learning, where we attempted even de-skilling the process of CAD designing. So it works. It needs a few tweaks, but it's very, very promising. So how does it really impact? Offers a huge advantage to patients, because you can they don't have to travel at all, and then even their data becomes archived, because being digital in comparison with the conventional analog modalities of treatment. The advantage to hospitals is that they don't need to invest in these high-end technologies themselves. They can outsource on demand. They can save out on their infrastructural costs. There is no need to clinicians don't need to maintain any equipments or inventory, and yet make these services available to the patients who need it the most, and ensure that this entire process delivery becomes sustainable and viable for them as well. So this is about how technology can impact facial prosthesis. Now I'm just going into how it can impact jaw reconstructions as well. Now, whenever you have jaw deviations as a result of lack of appropriate reconstruction, it becomes a huge problem for the patients. And the use of the fibula for reconstruction, so for the surgical reconstruction, is today considered as the gold standard. But the biggest challenge is is if the goal of the entire treatment protocol is to replace the dentition along with the replacement of the jaws, then it calls for an element of planning. And it's not uncommon to see that the fibula is way off, and it's not in a position which is amenable to any kind of prosthetic intervention to replace the dentition. So these kinds of good outcomes are possible, provided there is a reasonable amount of planning that goes behind it. So here is a situation where there was a segmental resection without any kind of radiation therapy for this particular patient, and it was a case of a failed fibula. Now, the only way forward was to sort of plan the entire jaw reconstruction, assuming that the entire goal of reconstruction is to replace the dentition after that. You start working backwards, and you determine the occlusion first, and then work backwards to ascertain the position of the fibula. Now, this was a two-stage procedure in this particular case. Then we were going to place the implants in the leg. wait for 6 weeks, and then wait for them to integrate in the leg. After 6 weeks, we re-explore the leg and remove the fibula along with its blood vessels. And in the intervening 6 weeks, we would have kept the prosthesis ready. And on the day of reconstructive surgery, we replace not just and reconstruct not just the jaw, but also the dentition. So it becomes like a jaw and teeth both on the same day. So this is the process of planning of an occlusion guided mandibular reconstruction. And I can just run through a short video, explaining the entire process. So this was essentially done in 2 phases. So the entire planning is done through a software, and the output of that is a 3D printed stent, which can be used for placement of your osseointegrated implants. Now, the positioning stent ensures that the implants are positioned in exactly the same position that they have been planned. Now, this entire process is very technique sensitive because it does need call for a lot of planning. Now, the next step is to, after placing the implants, is to capture the actual positions of the implants, because there could be a slight variation in what you planned in CAD and where you actually ended up placing the same. So you capture the actual position of implants, which could be a fraction of a millimeter here and there. And then there is a series of laboratory steps which will ensure the manufacturing of the prosthesis. Now you use a split thickness skin graft and put it over the implants, and also a membrane, so that 6 weeks later you are able to re-explore, and you are able to the tissues are not adherent to the to each other, and you are able to separate it out. Now, in the ensuing 6 weeks, you have ensured that the prosthesis is now ready. And now we are waiting for stage 2 surgery. Here again, just prior to surgery, we have ascertained that the occlusion is all in place. The maxillary and the mandibular arches are all in sync with each other and in sync with the occlusion. And then we are proceeding into the OT, for the stage 2 surgery. Here you can see, you can actually see that the fibula cutting guides are in place. You can see those implants there in the corner. Now the cutting guides are used to sort of make those osteotomies in the fibula as was planned in CAD. You can also see that the skin graft has now been taken up and is creating a keratinized tissue around the implants. Now, those into dental implantology will appreciate the fact that you need keratinized tissues around the implants for their long-term success. The prosthesis that we had created is now thankfully fitting like a glove, and now it's in place.
1 second, sir. 1 second. Depends the length of the duration. Yeah. Okay.
Then we use the reconstruction plate on a 3D printed model, so that we save time on pre-bending. So these are the mandibular cuts. So what we've done is we've cut the fibula. We're also cutting the mandible. And these are all pre-planned. Then, right at the end, you ascertain whether everything is in occlusion. There's a splint which is used to ascertain the same.
Okay. You know what I mean? Because if you put it here and you release it, the contact will.
Eventually, we have the prosthesis in place. We have the stents or the splint, which ensure that it's in the right kind of occlusion as that was planned. With meticulous planning and an attention to detail during execution, you can ensure that you have the jaw and the teeth completely aligned with each other at the end of it all. So you have the implants which can be eventually integrated. You have the provisional prosthesis that is put in place, and these kinds of outcomes, reconstruction and rehabilitation, can very easily be achieved if everything falls in place. The way planned. It calls for a lot of attention to detail. during the entire process. So the bottom line is that it is definitely possible to use technology, and when used appropriately, it can create a huge impact and can be life-changing for a lot of patients. Now we are moving rapidly with the use of technology, and moving ahead with navigation and virtual and augmented and mixed realities. I personally have not used them in my day-to-day practice yet, but I'm definitely keeping a watch on them because I'm reasonably convinced that these are going to be the order of the day in times to come. So in conclusion, my dear friends, we are what we are because of our patients. I consider myself extremely privileged to have been given a few skill sets which can be useful to a significant pool of patients. And I'm also, I consider myself lucky that I got an opportunity to delve into certain areas which can create a huge impact in the lives of patients, especially when it is an unmet need. So these kinds of platforms and fora are important to help spread these kinds of messages and make people aware that the emerging technologies, should be given their due at their appropriate time. We need to be early adopters in the use of technology because they can create enormous impact in the life of patients. So with this, I would like to sign off. I hope that I've been able to drive the point across in the effective use of digital technology, especially considering the kind of impact that it can create in the lives of a lot of patients. Thank you for this wonderful opportunity and giving some time to so that I can share my views with all of you. The way forward, as far as I'm concerned, is to combine the clinical service with digital technology so that they can be harnessed effectively. A lot of people feel that AI is going to replace doctors. I think no, it's always the man behind the machine that counts and not the machine. So AI is in times to come will continue to remain a tool, but it's always the doctor or the clinical doctor who has to call the shots at the end of the day. So what's the take-home message at the end of this entire presentation is that innovation is possible in low-resource settings, and remote healthcare delivery is going to be is already a reality, and it's going to be more a routine process, than a luxury in times to come. Prosthodontists and digital technology together are going to play a very, very significant role in head and neck reconstruction and rehabilitation. The kind of impact that we can create in times to come is going to be enormous. And it's not a one man's job. It calls for a lot of people to come together. And I would like to use this platform to actually exhort everybody to open up their mind and eyes to these kinds of issues. And I'm happy to collaborate with anyone who is willing to offer their services or come and collaborate so that we can create a lot of impact for a lot of patients in need. Because I very fervently believe that, as I mentioned right in the beginning, is that what's really it's really impactful only if science and technology is able to reach out to the masses. Otherwise, it's not really that that's important. But this is the change that that anyone thought. It was definitely not meant to be this way. I think what we are looking for is a different kind of change. Thank you, ladies and gentlemen, for a very for your attention and giving me the opportunity to share my views with all of you. Signing off. Thank you.
Thank you so much, sir. It was a very, very comprehensive overview of the principles, concepts, and techniques involved in the prosthetic rehabilitation. And your focus on innovation and technology has really opened the eyes of many present here. And I'm sure you're doing a wonderful job for the community and Indian population. So I really express my sincere appreciation for your enlightening lecture on prosthetic rehabilitation. Thank you so much, sir. If anybody has any questions, either they can put it in the chat box or they can talk to sir. Even in the chat box, people have really appreciated your lecture. They are saying it was a very inspiring, service-oriented lecture. So thank you so much, sir.
Thank you. Thank you. I'm just putting down my email in the
Yes, sir.
chat
Here,
box.
kindly put your email ID and also a phone number if possible. Thank you, sir. Thank you.
Thank you. Thank you so much. Bye-bye.
Bye. Dia, we can proceed ahead with the next session, and you can introduce the next speaker of the session.
Yes, ma'am, will do, ma'am.
Yeah.
So the next speaker that we have for today will be Dr. Mohan Menon, sir. Sir is a consultant medical oncologist at the Sir H.N. Reliance Foundation Hospital. He has 22 years of experience practicing as a medical oncologist both in USA and in India. Prior to coming to India, he was a consultant physician at Hartford Hospital in Connecticut and a clinical assistant professor of medicine at the University of Connecticut School of Medicine for 17 years. He is a visiting faculty member at the Gray Cancer Center, Hartford Hospital. He has completed his fellowship in medical oncology from the Roswell Park Cancer Institute, Buffalo, New York, prior to which he completed his residency program in internal medicine at the University of Connecticut School of Medicine. He is an American board certified in medical oncology, internal medicine, and palliative care, and was one of the first physicians in the United States to be certified in both medical oncology and palliative care. He also has an MBA in healthcare from Alvernia Institute. His additional areas of interest are cancer symptom control, lung cancer, head and neck cancer, and breast and gynecologic cancers. So, for today, his lecture will be on the topic of. Is Sir here?
Yeah, I'm here.
Ma'am. Okay. So, welcome, sir. We welcome you. It is an honor to be introducing you, sir, for the moderating this time, sir. Welcome you, sir.
Thank you. Thank you. Let me just get my screen. Hold on one second. Screen's a little different from how it is usually. You use share screen, right? Isn't that what you use for sharing?
Yes, sir. Yes, sir.
For some reason, it's not showing up how it usually does. 1 second. Huh? Plugin is required. Hold on, let's see. Okay, can you see?
Yes, sir. Your screen is visible now.
Okay, good. So, used to be a little different before, and but whatever. All right.
Your screen
So,
is a bit stretched.
So shall I start?
Sir, sorry to interrupt you, sir. Your screen is a bit stretched. There is some issue with the settings of your screen display.
Okay, hold on. Let me try again.
Yes, sir.
Is this good?
Perfect, sir. Perfect.
Okay, wonderful. Very nice. All right. So, okay, so this is the first slide. That's progress. So, systemic therapy for oral and head and neck cancers. That's my talk. And what does it mean? Basically, I'm going to talk about what we give both intravenously and orally for oral and head and neck cancers. Why have I said oral and head and neck cancers? Because I realize oral and around that areas is your area of interest, but head and neck cancers is a broader name that we use, even though oral cancers are a lot more common in our country. So what will I talk about? We'll talk a little bit about the background for head and neck cancer, organ preservation, which is more applicable to laryngeal cancers, but to a small extent for oral cancers also. Adjuvant therapy that we give after surgery in the form of, I won't talk about radiation, I'll talk only about the chemotherapy part, that is who gets it. If you have advanced oral cancer, what chemotherapy would you give? We'll talk about immunotherapy, which is the new kid on the block, metronomic therapy, targeted therapy, and finally conclusions. So it's a very common cancer. Oral cancer is very common, amongst the most common cancers in the country, more common amongst males than women. And smokeless tobacco, as you know, is a significant public health concern. Most people are developed in the later stages only because we don't have great screening protocols. And the number of cases is just increasing over a period of time as per GloboCan. Now, why are we saying oral and head and neck? Because it's a heterogeneous group of malignancies in the oral head and neck region, which most of them are squamous cell carcinomas, that is 85 to 90%, and are caused by similar etiologies, that is tobacco, alcohol, viruses, and so on and so forth. Now, if you have a metastatic foci of disease, the likelihood is that your prognosis is going to be worse. And most of the times, we use multiple modalities for treatment. That is surgery, radiation, and systemic therapy. And I'm focusing my attention on systemic therapy. Now, from an etiologic perspective, the vast majority of patients develop head and neck cancers from the usage of tobacco, chiefly smokeless tobacco and burnt tobacco, along with alcohol. But it's good to keep in mind that there are other causes too, which is HPV and EBV. And HPV is mostly oropharyngeal, and EBV, that is Epstein-Barr virus, is mostly nasopharyngeal. And the treatments for these are very similar, but they respond much better to the treatment that we give, especially with the systemic treatments that we give. So it's something to just keep in mind. The treatments haven't changed dramatically, but the feeling is that perhaps we may use less radiation over time, and so on and so forth. Now, this is sort of what happens at a cellular and molecular level. The picture up over here is showing what it looks like and how it progresses from hyperplastic or leukoplakia to frank cancer. So this is what it looks like from at a cellular level. The cellular appearance moves from hyperplasia to dysplasia to frank cancer. And as you can see, the cellular appearance also changes. And at a genetic level, you start seeing these variations. You start seeing in certain early changes, such as the loss of and TGF alpha and EGFR and so on and so forth. And over a period of time, you keep losing more and more of the quality of the genetic material. What happens over a period of time is that these cells keep on accumulating more and more genetic deficits. And as that happens, you develop more and more aggressive disease. Treatments for head and neck cancer, as you know, surgery was there for a long time. It started even before the turn of the last century. Radiation started somewhere in the 1940s, 60s. Chemotherapy, sort of systemic treatment, started in the 1980s. Targeted therapy and immunotherapy. From the timeline perspective for systemic therapies, we first figured out that cisplatin and paclitaxel works somewhere in the 1990s. And then subsequently, we started finding more and more biologic reasons to treat these patients. There is cetuximab, which works against the EGFR protein, which is overexpressed in head and neck cancer. We use it along with radiation, and we sometimes use it as per what's called as the extreme trial, which is what you see here, which was published in 2011. What subsequently caused a lot of excitement was the role of immunotherapy. That is, how do we get the body's own immune system to fight against the cancer? And the drugs such as pembrolizumab and nivolumab, and there is a new drug called taripalimab, which basically works by blocking the cancer's ability to mask itself from the immune system. Then there's also something called as CTLA4, which is ipilimumab. There is some data that ipilimumab with nivolumab may be more effective, and we'll talk about that later. But basically what it is unmasking the cancer to the immune system so that you can fight against the disease. So this is, in short, what happened in our field since the last 20 odd years. So the first thing that I'd like to talk about is organ preservation. That means, how do you preserve the anatomic sanctity and function of the oral cavity as well as other organs? And a lot more data exists in the field of laryngeal cancer. There is the VA study group that showed that you can preserve the larynx. Now, why do we talk about this? Because when you take people with advanced cancer and you put them through this laryngectomy, possibly followed by radiation, the survivals aren't that great. That means only half the number of people with advanced cancer who went through the process of laryngectomy, lost their speech, lived for 5 years. So then the question came up, can you reduce the morbidity of a laryngectomy by treating these people with chemotherapy and chemotherapy with radiation? And we found that chemotherapy works quite well and has high rates of complete tumor regression. So what was found was that if you use chemotherapy followed by radiation, you had approximately an equivalent survival with surgery, and you also preserved the larynx in about 2/3 of the patient, which was, I think, a good improvement compared to where we were before. We also found that something similar, although not as impressive, occurred in this group of people with hypopharyngeal cancer and base of tongue cancer. As far as tongue is concerned, probably not as impressive. That is, if you can preserve the tongue, maybe you might be able to preserve speech for a little bit more. And in selected T4A patients who decline or are unfit for surgery could potentially be benefited by treating them with systemic chemotherapy with radiation. Moving on to adjuvant therapy after surgery. And one question is, which group of patients are you going to treat with chemotherapy? And this is the NCCN guidelines. And what you can see over here is that while they have given a fairly wide margin, what they say is that if you have adverse features on pathology, such as extranodal extension, you have positive margins after surgery. Also selected patients whose margins are close, who have N2, N3 disease, T3, T4 primary, evidence of perineural invasion, vascular invasion, lymphatic invasion, you could potentially consider that. But for practical purposes, I think most of us sort of settle down to these two things, extranodal extension and positive margins. These are the two groups of people in whom we consider giving systemic therapy after surgery, along with radiation treatment. What about chemotherapy for advanced cancer? Well, here I've sort of put in a flow diagram for how we treat these patients. So if the disease is P16 negative, that means people who do not have what you call EBV infections, that group of people we would consider for radiation alone. Subsequently, if your performance status is good, that is the group of people we would give chemoradiation, cisplatin given every 3 weeks or 40 milligrams per meter squared given weekly. If it's not a healthy patient, then we could consider giving cetuximab instead of cisplatin, although the standard of care continues to remain cisplatin in this group of people. And that is sort of how we consider using chemoradiation in these patients. They have to be followed closely over a period of time. And if you have advanced disease that is not resectable, we have a variety of agents that work against this disease. We can use single agent in people who are somewhat poorer on terms of performance status, or we could use a doublet. When you use a doublet, the likelihood of a response is much higher, although the toxicity of treatment is more with combination treatment. So combinations like paclitaxel carboplatin or paclitaxel cisplatin, gemcitabine, a platinum-based doublet. That's usually what we use under those circumstances. There are lots of side effects, lowering of blood counts, nausea, hair loss. I'm sure you're familiar with most of these. And that's something that one has to keep in mind when you're treating these patients. This is an important thing. This is an Indian discovery where we use low doses of a combination of methotrexate, celecoxib, and geftinib. And the combination has less side effects, mostly causes skin rash, mouth sores, but no lowering of blood counts, no hair loss. It's very cheap. And this is a study that was done by Vijay Patil et al., where they showed that this combination seemed to work as well, if not better, than intravenous cisplatin. Now, moving on to immunotherapy, which is something that we are all quite excited about. We talked about pembrolizumab and nivolumab. Basically, what you see is this. This is a T cell. This is a cancer cell. This is what's called as an antigen-presenting cell or a dendritic cell. And what happens is that this is the first stimulus. Through the MHC class 1 or class 2 protein, it presents a polypeptide to the T cell receptor. Now, you also have to have a co-stimulatory molecule. And these are the co-stimulatory molecules that are present on the antigen-presenting cells. Now, they can be stimulatory, which is the green ones that you see, or inhibitory, which is the yellow one that you see. So in the absence of the co-stimulatory molecule, this T cell will go into anergy. But in the presence of the co-stimulatory molecule, either you will have a response, as you can see over here, or you will have an inhibitory response. So what happens is that if you block this thing, this interaction between PD-L1 and PD-1, you will actually have a lack of inhibitory signal, which in turn will cause the T cell to respond. So that when the T cell goes ahead and sees this particular protein on a tumor cell, you will have a response. As you can see over here, that is, this is an antigen-presenting cell. This is a T lymphocyte. And what happens is that Keytruda blocks the PD-1 receptor. There are inhibitors for PD-L1 too. And by blocking that, you can get a stimulatory response. And basically these cells that are primed, the T cells that are primed, leave the blood vessel, go to the periphery, and they start the process of killing the cancer cell by a variety of mechanisms. So that is what you need to understand about PD-L1. It's basically blocking an inhibitory response from the PD-1, PD-L1 pathway that causes the cancer cell to be attacked by these T cells. Now, how do you know if the treatment is going to work, the immunotherapy is going to work? We don't have great ways to know, but there is something called as CPS and TPS, which is basically what we try to see is how many of these cells, that is the tumor cells, stain with PD-1. And that is TPS. CPS is the combination of T cells, of the tumor cells, as well as the immune cells around. And as you can see over here, there are very few cells. That is, a CPS less than 30 is very few cells that are staining. And once you get to 50, you get a lot more. 80 and 100 is pretty much most of the cells are staining. The presence of these cells that stain is very likely to predict that the patient will respond. There are other markers also that seem to tell us whether a person will respond or not. But at this point, this is what we have, which is the best currently. How does it compare to other treatments? Well, pembrolizumab as a single agent, pembrolizumab with chemotherapy, that is a platinum-based chemotherapy, and what was considered the standard therapy with this drug called cetuximab were compared in this particular trial called as Keynote 048. And what they found was that there's definitely an improvement in the group of people who were treated with this particular regimen. More so if your CPS, which is what I showed you earlier, the likelihood of the tumor cells staining for this particular protein, PDL1, the likelihood of both improvement in an overall survival and progression-free survival was much better in the pembrolizumab arms. There is a newer agent called toripalimab, which is a drug that was discovered in China, which also showed an improvement in overall survival both at 1 year, 2 years, and 3 years, which seems to be the new kid on the block. It's approved for nasopharyngeal carcinoma in India, melanoma and urothelial cancers, hopefully soon. And the advantage with this drug is that it's somewhat cheaper than pembrolizumab and nivolumab. And so that's another drug that you might hear about soon. We talked about metronomic therapy, that is using 3 oral agents. Does it work does it have any synergy with immunotherapy? And there is some data to suggest that there is this low dose immunotherapy using nivolumab, which is one of the other PDL1 drugs. And it improved both 1 year overall. This is a fairly decent sized trial, 76 patients in the low dose nivolumab arm, 75 patients in the metronomic arm. And it looks like they had an improvement in the 1 year overall survival from 16.3 to 43.4, which is a nice improvement. And the median overall survival was also increased from 6.7 to 10.1 months. There were some side effects. Most patients did have some side effects. But it seems like this is another new way to treat, that is low dose metronomic therapy with metronomic therapy with immunotherapy seems to be doing well. And especially in the patients who are frail and have an inability to tolerate regular chemotherapy, this may be one way to go. Can you use 2 drugs, 2 immunotherapy drugs? Will that work better than one? And this is a study where they combined nivolumab with something called as ipilimumab, which is something which works against what's called as the CTLA4 pathway. It seems to have some mild response, but I guess the slide is upside down. But basically, it's doesn't seem to work too well in that situation. What are the side effects with immunotherapy, they are different from the side effects that you have with chemotherapy. Most common thing is a skin rash. It can cause hypothyroidism in about 15 odd % of patients, and you should check for the TSH and thyroid function. Less commonly, it can cause hepatitis in about 1% of the patients. Colitis and diarrhea, and pretty much any organ of the body can be affected by this. The timings of these side effects are different. The skin rash is the first thing that occurs about 2 to 4 weeks after initiation of treatment. Liver toxicity occurs much later. Diarrhea occurs somewhere around the 5th week. So these are the things about the side effects. What is so exciting about immunotherapy? It's this particular thing. That is, when you give chemotherapy, what happens is you'll get a benefit and the survivals go down over a period of time. You use targeted therapy, maybe it's a little bit better. But when you use immune checkpoint inhibitors, you have this group of people that seem to be long-term survivors if you can get the immune system to react against the cancer. And when you combine it with other agents, that is chemotherapy and targeted therapy, etc., the potential for survival is a lot more. And that is why we are all excited about this concept of immunotherapy with other modalities of treatment. We'll talk a little bit about targeted therapy. The surface of the cancer cell has a bunch of different proteins. EGFR is the one that we use the most, but MET is another one, Notch is another one. And there's a bunch of other pathways that are rendered abnormal because of this particular, in this particular disease. EGFR, you can use these local agents such as erlotinib and afatinib. Doesn't seem to work very well. What seems to work much better is cetuximab, which is present on the surface of the cellular membrane. And we'll talk a little bit about that. This is cetuximab. I told you where it goes and attaches itself, that is on the surface of the T cell, on the surface of the cancer cell. And it's a monoclonal antibody, fairly large protein, blocks the EGFR receptor, and can be used in combination with radiation, especially in patients who cannot receive chemotherapy, so with platinum. So in that group of patients where we use radiotherapy with cetuximab versus radiation therapy alone, there's a study called as the Bonner study, in which it seems to work quite well. Here is the overall survival in that group of patients. However, if you had to choose between cisplatin and cetuximab, cisplatin continues to remain the standard of care. There is the extreme study, which was an important study by Vermoken et al., where in patients who had advanced head and neck cancer, when you gave them chemotherapy alone, the likelihood of survival is this. When you gave them chemotherapy with cetuximab, it seems to work much better, both in terms of overall survival and progression-free survival, with the median overall survival of improvement from 7.4 months to 10.1 months, and progression-free survival from 3.3 to 5.6 months. Another thing to sort of keep in mind is that these patients with oral cancer as well as head and neck cancer, because of their exposure to tobacco, alcohol, and similar agents, have a high likelihood of developing a second primary about 2 years after the initial diagnosis. So one has to be careful to screen for these things. Head and neck, obviously, you can look at the oral cavity as well as the rest of the head and neck region. Other two diseases that one has to keep in mind are lung cancer and esophageal cancer, which occurs more commonly in these two patients. So how do you put it all together? What one can say is that if you have somebody who is healthy and has a good performance status, you treat them differently than if you have somebody who is having trouble getting out of bed, who's spending most of his or her time in bed, and has other medical issues. So, in that group of patients that are healthy, you can consider using either immunotherapy or more commonly immunotherapy with a platinum and 5-FU based regimen. Now, if someone has a CPS that is high, that is the likelihood of that person responding to immunotherapy is high, you can consider using this immunotherapy regimen. An alternative regimen, if that were not to be the case, is a combination of cetuximab with platinum. Now, if you've used immunotherapy upfront, then you use cetuximab and platinum as second line, or vice versa, depending upon how the circumstances are. So, the treatment has changed. It's not chemotherapy alone, it's chemotherapy with something. And that something is either immunotherapy with a PD-1, PD-L1 agent, or a targeted therapy such as cetuximab that works in that situation. If it's a frail patient, you can use monotherapy, either with methotrexate or that is chemotherapy in that form, or you can use pembrolizumab, or you can use metronomic therapy, which we talked about earlier. One second. Now, if it's somebody who is on the healthier side, you can certainly consider a platinum doublet. And sometimes, patients' performance status improves. That means, when they're frail and weak, you can only start with monotherapy. As they get stronger, you can get to using the more aggressive regimens. This is my last slide. Oral cancer is a serious public health concern. We all agree on that. Head and neck cancers, including oral cancers, have similar etiologies and treatments are kind of similar. Post-surgery, we can give adjuvant chemotherapy with radiation in people who have positive margins or extranodal extension, or whoever you feel who has T3 or T4 disease, in whom you feel that the likelihood of recurrence is high. We have several chemotherapy drugs that work in this particular disease. We use a targeted agent such as cetuximab in combination with radiation, as well as with chemotherapy. The latter is an advanced disease. We talked about immunotherapy with chemotherapy, and that is better than cetuximab. We talked about nivolumab and toripalimab. And most recently, oral metronomic therapy seems to have synergistic benefits with immunotherapy, which is what we are most excited about. And I've seen in several patients that it really gives a lot of benefit to patients. That is all that I have for today. Thank you. I'll stop the
Thank you
screen
so much,
sharing.
sir. Thank you
Thank
so
you.
much, sir.
Thank you
Sorry,
so
ma'am.
much, sir. Your lecture was very, very informative regarding the various systematic approaches, targeted therapy, immunotherapy, combination therapies. So your lecture is highly appreciated by us. And I'm sure that people must have gathered some new information regarding the latest chemotherapy protocols which are going on. If anybody has any questions, they can ask sir in the chat box, or they can unmute themselves and they can ask sir. Okay, sir. Thank you so much. Thank you once
Thank you for
again.
having
Highly
me.
appreciated.
Have a nice
Very
day.
insightful lecture.
Bye.
Thank you. Have a great day, sir.
Same to you. Bye.
Yeah. Dia, please introduce the next speaker for the day.
Yes, ma'am. So the next speaker for the day is Dr. Vidhi Katira, ma'am. She is a consultant oral physician and radiology from Gujarat. She has completed her BDS from AECS Maruti Dental College, Bangalore, Karnataka, and her MDS in oral medicine and radiology from Narsanbhai Patel Dental College and Hospital, Gujarat. She has worked in the private dental clinic for 2.5 years now in Rajkot from December 2012 to May 2015, completing her BDS and dealing with scaling, restorations, RCTs, extractions, fixed and removable complete and partial dentures, and other many minor procedures. After completing her MDS, she has worked as a dental surgeon in GCRI, Gujarat Cancer Research Institute in Ahmedabad, for 7 months. Then she delivered online lectures on oral mucosal lesions and online workshops on oral cancer on Dentist Channel Online, and was the keynote speaker on topic named Post and Pre-Operative Antibiotics in Dental Implant Practice in second Virtual Implant Expo, which was held from 5th to 13th November 2021. She has been a guest faculty in EduCan Module 2, Asian Head and Neck Cancer Foundation on Investigating of Oral Cancer, which was held on 21st November 2021. Presently, she is working as a senior lecturer in GD Goenka Research Institute of Dental Sciences since 10th April 2023. So welcome, ma'am, on the today's topic of current trends in chemotherapy for oral cancers.
Yes. Just a moment, I'll share the screen. Is it visible?
Yes,
Yes,
ma'am.
ma'am, it is visible.
Okay, fine. I'll start with it. A very good afternoon to IOCCON, that is International Conference of Oral Cancer, all the speakers, all my senior staff, and the participants. I guess I'm the youngest because I just completed 2 years of my senior lecturer in the Goenka. So, without wasting much of the time, I'll start with the topic, which is the current trends in chemo prevention in oral cancer. These are my contents: introduction, the treatment, the new treatment modalities, the limitations, the current ongoing clinical trials, and the references. Oral cancer refers to tumors that occurs in lips, hard palate, upper and lower alveolar ridge, anterior two-thirds of tongue, sublingually, buccal mucosa, posterior part of the tongue, muscles of molars, and oral cavity. More than 90% of the oral cancers are carcinomas with squamous epithelium and differentiation from the mucosal epithelium, thus called oral squamous cell carcinoma, which is the sixth most common cancer worldwide, with 50% of the 5-year survival rate. Now, already the before lecture was on this chemo and radiotherapy. So I'll be just briefing about the treatment part. Okay, and then I will move to the current trends which are in chemo prevention, especially in the chemo prevention. Okay, and the ongoing trials which are going on in chemo prevention. So, in brief, I'll just say the treatment of oral cancer includes single modality surgery, radiotherapy, that is external beam radiotherapy, EBRT, or brachytherapy, or the chemotherapy. Various combinations of these modalities with or without systemic therapy has been used. The selection of treatment is always based on the consideration of the disease control, anticipated function of cosmetic outcomes, and availability of resources and expertise. Depending on the type of cancer and its stages, patients are treated with one, two, or three any of these modalities and its combination. The mainstay of treatment for oral cancer is usually surgery. Okay, that is after surgery, it can be EBRT with or without chemotherapy, which are generally employed in three situations, which is adjuvant to the primary surgery to enhance the loco-regional control, that is LRC, for the cases with unfavorable pathological features. Second is primary treatment for the cases that are unable to tolerate or unsuited for surgery. And third is the salvage treatment in the persistence of recurrent disease setting. Now here, this figure shows that when there is local or definitive therapy, then we use surgical therapy and the radiotherapy. But for distance metastasis, where these both are not possible, at that time, first we use the chemotherapy and then we use the other two therapies as an adjunct therapy. What is chemotherapy? Chemotherapy is the treatment for oral cancer that uses anti-cancer drugs to destroy the cancer cells. Two other medical terms used to describe cancer chemotherapy are antineoplastic therapy, that is anti-cancer therapy, and cytotoxic therapy, that is cell-killing therapy. It is often used with the combination of radiotherapy. Chemotherapy. Now there are three types based on the settings, that is induction chemotherapy, concurrent chemotherapy, that is chemo plus radio, and then adjuvant chemotherapy. Now, induction chemotherapy, it was first given by Dr. Frey in 1982, and it is used for definitive therapy, that is radiation therapy or surgery. Means this therapy is used before we undergo the surgery or before we undergo the radiotherapy. It is often used in the patients with locally advanced diseases and in patients with advanced nodal disease, means where the lymph nodes are involved. Now, the potential benefits are cytoreduction or downstaging of the tumor, which will help for easy surgical procedure. When the tumor is more in size, at that time, the cytoreduction or downstaging, the staging of the tumor, that is the TNM staging, has to be reduced. So in that case, is first this chemotherapy is given, and then we can go for the surgical therapy. It avoids the potential for the poor drug distribution due to compromised vascularization from surgery or the radiotherapy. But here there is intact vascular bed which allows for better drug delivery and also healing. There is decrease in manual manipulation of the tumor. Now, when chemotherapy is used for oral cancer, okay, it is used before surgery and it is used after surgery. Now, when you use after surgery, it is used to kill any cancer cells that are left behind. Means once you have done the surgery, okay, and after that, if there are any cancer cells to be remaining, then chemotherapy can be given. Okay. Now, before surgery, means if there are large cancers, for example, in the before slide, I said if there is a large tumor, now to shrink that tumor, we need to give the chemotherapy first and then we need to do the surgery. So before surgery, to shrink the large cancer so that the less tissue needs to be removed. When surgery is not an option, it means to treat the cancer that are too large and have spread too far, that is distant metastasis. In simple language, when the cancer is spread too far, that is distance metastasis. So in that cases, we give first chemotherapy. To relieve pain, that is to control the symptoms of the advanced oral cancer, we give the chemotherapy. Now, how it is given? The drugs are injected into vein or taken by mouth. The healthcare team will plan the drugs, dosage, and the schedules. Now, the potential adverse effects is development of drug-resistant cells, increased toxicity with subsequent drugs, inability of chemotherapy agents to produce significant reduction in tumor, proper determination of extent of surgery also may be difficult. It means here there are the limitations of chemotherapy, that the how much tumor reduction we want, that much we do not want. As for example, it is 5 centimeter. Okay, I'm just giving an example. So if we want that to be 2.5 or 2 centimeter, but with the chemotherapy agents, it is just reduced till 4 centimeter. So that is the one of the negative or the adverse effect or the negative point of chemotherapy, that it does not give us the significant reduction in tumor. Second, there is increased toxicity with the drugs, and our body, there is development of that drug resistant cells. Now, the use of chemotherapy, both in combination with radiation as a monotherapy for patient with advanced disease, is also advisable. Okay. The treatment of locally advanced oral cavity cancer is often multimodal, involving the surgical section, radiotherapy, and the chemotherapy. Despite the advancement in surgical and radiotherapy, that is the RT techniques, treatment has been largely remained unchanged for past several decades. The treatment of loco-regional advanced disease is approached with primarily surgical resection followed by post-operative RT, that is the radiotherapy. As for other cancers of head and neck, the use of chemotherapy in oral cancer is considered as an adjuvant therapy to the curative modalities of the surgery and the radiotherapy. Post-operative concurrent chemotherapy, that is CRT, with cisplatin remains the standard treatment for resected disease with high-risk features of positive surgical margins and or extranodal extension. It means when there is extranodal extension, when the lymph nodes are involved along with the high risk patients, at that time we go with concurrent chemo radiotherapy. Means chemo plus radio both are done with the cisplatin. Now, how chemotherapy works? Cancer is an uncontrolled growth of cells due to different gene mutations by carcinogenesis. Chemotherapy prevents the division of these abnormal cells with different mechanism, that is damage to DNA, damage to enzymes required for growth, and damage to the microtubules. Chemotherapy differs from surgery or radiation in that it most of always used as a systemic treatment, means the drug travels through the body to reach the cancer cells wherever they are, although there are various ways to use chemotherapy to treat one part of the body. Means whenever there is a tumor in chemotherapy, okay, the drug has to travel through the body to reach that cancer cells. This technique is different from radiotherapy or the surgical therapy. Now, what are the objectives of chemotherapy? That is cure, control, and palliation. Now, what is cure? To improve the chances of cure and functional and or cosmetic outcome by avoiding the surgical procedure. That is the organ preservation part. Okay. Now, here, when the tumor is totally cured by chemotherapy is one objective of this treatment modality. Second is control. If cure is not possible, there are many cancers, okay, which are widespread or having distant metastasis. So cure is not possible. If cure is not possible, then goal may be to control the disease so that it does not damage the body more. Okay. So in that cases, the shrink of the cancerous tumors and or to stop the cancer from growing and spreading to different places is the second objective of chemo prevention. So to decrease the incidence of distant metastasis and secondary primary tumors. Now, what is palliation? That is the third objective of chemotherapy. Now, when the cancer is at advanced stage, chemotherapy drugs may be used to relieve the symptoms. So when the only goal is to improve the quality of life of a patient and not to treat the disease, then it is called palliation or the palliative treatment. Now, it can be given in the both ways, systemic and regional. In systemic, we have intramuscular, intravenous, subcutaneous, and intravenous, intramuscular, and subcutaneous. In regional, we have intrathecal, intratumoral, means only in the tumor part, or intralocal or intralesional. Okay. Currently, the targeting drug delivery is an emerging as an effective approach for oral delivery of different therapeutics. Herein, there is a provision of state-of-art review of the current progress of the target drug delivery for the oral cancer therapy. Variously, oral delivery systems including polymeric or the inorganic nanoparticles, liposomes, cyclodextrins, nanolipids, and hydrogen-based forms are used. The biomimetic system with respect to the oral delivery like therapeutic vitamin, exosomes, proteins, and virus-like particles are also described today with emphasis of oral cancer treatment. In current therapies, anti-cancer drug, for example, 5-fluorouracil, cisplatin, placitaxel, and docetaxel are used alone, and it can be also used in combination, which have been employed in the chronochemotherapy of oral cancer treatment. This has been proved in the year in 1994, 2005, 2006, and 2009 by these authors. However, they are highly toxic to normal cells as intravenous administration with non-specific tissue distribution within the bodies. And it easily causes greater damages to the healthy tissues with severely adverse reaction. So in 2002, the Cruzius said that these anti-cancer drugs do help in chemotherapy in oral cancer patients, but when they're administered intravenously, okay, when there is no systemic, no specific tissue distribution in the body, then it causes damages to the healthy tissue or the normal cells. So in addition, low solubility, permeability, and poor bioavailability of these cancer drugs in bodily fluids are also noted as one of the limitations of the oral chemotherapy. Therefore, development of new therapeutic regimen or the modifications of current approaches are significant urgent for improvement of human health and survival against the oral cancer tissues. To overcome these advantages of current treatment techniques, scientific community has turned towards nanotechnology to develop new and more effective nanotechnology based drug carrier systems to optimize oral, buccal and intravenous treatment routes. So to overcome these advantages, now we are moving towards the nanotechnology. An innovative approach to improve the efficacy is the target drug delivery system that has the greatest potential to increase the drug bioavailability and biodistribution at the site of the primary tumor, showing promise in the overcoming complications of the conventional anti-cancer drugs and enhancing the therapeutic efficacy. Is there any problem? Hello? Hello? Shall I continue?
Yeah, please
Yeah, yeah.
continue.
Okay, fine. So, especially the naturally derived and synthetic polymers are exploited as two common candidates for delivering the chemotherapy agents at the tumor site. And the targeted drug delivery system is capable of releasing a bioactive molecule at specific site to improve the individual health outcomes for oral cancer. Thus, the target drug delivery system is more promising and has the ability to reduce the extent of side effects of some chemotherapeutic drugs, which can be exploited as a therapeutic strategy in head and neck cancer patients. Now, nanotechnology based carriers for oral cancer therapy. To address the issues of conventional chemotherapeutic agents, molecularly targeted therapies are urgently required for improving the drug efficacy and reducing the toxicity. Therefore, by means of novel contribution of nano delivery systems, the drug loaded nanoparticles with optimal size can express the smart manipulation of drug release behavior once the micro environment is slightly changed, which is utilized for the targeted therapy. It means here we have small, that is nano delivery systems, okay, which are drug loaded nanoparticles, which are having the optimal size of related with the tumor site or the cancer site. So these nanotechnology based drug carriers have allowed for selective methodologies for oral squamous cell carcinoma treatment. Compared to the chemotherapeutic agents, these target drug delivery systems are widely used to control the drug release with advanced advantages on the improved therapeutic effect and reduce the side effects like absorption, metabolism, distribution, and elimination. Now, various nanotechnology-based carriers based on nanoparticles, liposomes, cyclodextrins, nanolipids, and hydrogels are discussed in my PPT. In addition, biomimetic nanoparticles of vitamins, proteins, peptides, and virus-like particles are also used as potential carriers for chemotherapeutic agents for oral cancer therapy. Now, main is the target drug delivery, that is local drug delivery, TDD. Now, we will learn what is TDD. TDD is a strong and specific evolving method in cancer management where active pharmacological ingredient, that is API, is taken to the targeting site, sparing the non-target organs or the cell, triggering selective and efficient localization, thereby maximizing the therapeutic index along with the minimization of the toxicity. Here, what is local drug delivery? There is an ingredient, that is active pharmacological ingredient, which is taken to the target site, okay, and the non-target organs or cells are spared. Spared means we are not touching that area, and the trigger is selective and which is effective to that localized cancer cells. Therefore, there is minimum toxicity and we have the maximum therapeutic effect. The drug is directly transported either within or in the proximity of the target through drug delivery vehicles that transport the drug. The successful target drug delivery system works on 4 principles: retain, evade, target, and release, which means loading of the sufficient drug into the suitable drug carrier; evade, not affecting the body secretions; third, maintaining the circulation of long duration and reaching the target size, and thus releasing the drug within the appropriate time for effective functioning of the drug. Now, local drug delivery or the target drug delivery is a type of drug delivery in which a drug is transported to the target site without affecting the normal body system, as I explained before, as compared to the conventional routes, thus preventing the side effects on the healthy cells. This method has been shown having beneficial effects on oral tissues in oral cancer, such as rapid oral mucosal turnover rate, leading to self-repair. It means after giving this local drug delivery agents, the self-repair or the self-healing is also good, along with the minimum toxicity and no side effects to the adjacent parts of the body or adjacent tissues, thus elevating the adjacent tissues due to long-term exposure of anti-cancer drugs. So the local drug delivery has many benefits as well as drawbacks. An ideal target drug delivery system must possess certain characteristics, and there are different targeting systems for the drug delivery. You can see these are the benefits and these are the drawbacks. The benefits are it is simple and easy to approach, less drug dosage is there. Okay. And when you want to increase the drug concentration at the site, you can do that also. There is no effect on the normal tissue, decrease toxicity, increase therapeutic efficacy, increase specific localization, modulated pharmacokinetics, cheaper techniques, controlled biodistribution, reduced dose, and improved patient compliance. I guess the improved patient compliance has to be the first one. Okay, because we are more towards our patient safety and the minimum toxicity going in their body. What are the drawbacks? It may evoke some immune reaction against the IV system, leads to clearance of the target drug system very fast, not completely able to get localized into the tumor cells, and there may be diffusion and redistribution of the released drugs. Now, ideal drug delivery system is restricted drug distribution to the target cells or organs, minimum drug leakage, non-toxic and non-immunologic, easy, simple method, biodegradable carrier. The carrier is a biodegradable, therapeutic amount of drug is released. It should not affect the drug reaction. There is uniform capillary distribution. There is control and predictable rate of drug release, and there is therapeutic amount of drug release, which is physically stable. Now there are there are 4 types of targeting system of local drug delivery: passive, active, magnetic, and immune. Now various methods of local and target drug delivery system for oral cancer. First is fast dissolving oral thin films. Okay, so this is FDDS, that is fast dissolving drug delivery system. This is a modern delivery system which is designed to amplify the shortcomings of the TDD. Okay, that is traditional drug delivery system. These FDDs are of 2 types: oral integrated tablets, that is ODT, and oral thin films, that is OTF. Now, OTFs are further compromised into mucoadhesive buccal films and oral dispensable films, that is ODF. Okay, so there is a flow chart, you can say. First is the FDDS. After that, there is oral disintegrating tablets, that is ODT, and OTF, that is oral thin films. Now, in this oral thin films, again, we have a 2 type, that is mucosal buccal films and oral dispensable films. Okay. Now, ODFs possess specific unique characteristics, which include fast dissolution, adhesiveness to mucosa, systemic drug administration, and active pharmaceutical ingredient, that is API, here, which is swallowed with saliva and the GI route of absorption. The system has solid dosage in the form of strips which are kept in mouth, which dissolves quickly even without use of water. Now, OTF has treated a wide range of diseases such as migraine, schizophrenia, opioid dependence, pain, nausea, vomiting. But now they are used in this oral potentially malignant lesions and oral cancer as an adjuvant therapy. In 2009, Shimoda H. et al. Indicated that dexamethasone containing fast dissolving oral thin films, that is OTF, as an effective cancer chemotherapeutic agent. Remini et al. Studied the effect of mucoadhesive buccal films loaded with immunocoid for treating the oral precancerous lesions and concluded that it resulted in enhancement of drug release than other conventional forms. In 2014, Costa et al. Suggested Citiosine-based mucoadhesive film along with the photodynamic therapy. Now, what is photodynamic therapy? That also I'll be showing in my later slides. To boost the retention of 10% of 5-ALA in the tumor tissue, and it found reliable aid in oral cancer therapy for local drug delivery. Paul and Kaman developed evaluated the mouth-dissolving film of drug ondansetron hydrochloride using a pterogum and observed an improvement in its bioavailability, release, disintegration time, and tensile strength in comparison to the conventional method. Jin Bajao et al. Investigated the role of mucoadhesive patches loaded with the methotrexate liposomes in the local drug delivery system for oral cancer and found suitable bioadhesive properties and prolonged release time. So different scientists have used different materials in the OTF, that is oral thin films and mouth dissolving films, and have released and have got the very good results compared to the conventional methods. Now, ETF are the improved drug delivery system that offers many advantages over more the traditional delivery methods. All the advantages and disadvantages I have kept in table 2, which I will tell at the end. So this is table 1. Okay, now these are the constituents of the fast dissolving oral thin films: polymers, mucoadhesive polymers, permeation enhancers, sweeteners, flavoring agents, saliva stimulant agents, plasticizers, and coloring agents. Now the second one is hyperthermia and thermoablation. For centuries, heat has been used for the therapeutic purpose in the medical field. Human cells are capable of withstanding wide range of temperatures. Generally, a complete necrosis occurs almost instantly at the temperatures of 60 degrees Celsius. Hyperthermia, that is HT, is a non-invasive technique where the body tissue is exposed to high temperatures ranging from 41 to 50 degrees, whereas thermoablation includes temperature above 50 degrees. The main objective of thermoablation in cancer is the removal of the damaged tissue along with the healthy margins by applying heat and electromagnetic waves. It involves some of the common methods such as RF, that is radio frequency electric current, microwave frequency radiation, that is MW, laser magnetic induction, cryoablation, and high intensity focused ultrasound, HIFU. Now, in thermal ablation, the option of an effective heat delivery route to the tumor is critical and challenging. The effects of hyperthermia depends upon the duration of high temperature, homogeneity in the tissue, type of tissue, and the type of aid used. The mechanism of local hyperthermia involves direct cell killing effects, including apoptosis, DNS damage, and the reduction in the perfusion coordination and its effect, which enhances the radiation sensitivity and drug absorption. Hypoxia and immune modulation also. For successful treatment of cancer, HT, that is the hypothermia therapy, can be given in combination with the conventional cancer treatment modalities, such as the radiation and the chemotherapy. Tumors become the radiosensitizers in the presence of thermal stress, making them responsive to radiotherapy and improving the survival cancer rates. It means along with the radiotherapy, HT can be used as an adjuvant therapy wherein the tumors become radiosensitized, so they respond to the radiotherapy more as compared to the conventional methods. The chemotherapeutic agents can be loaded with nanoparticles via active or passive targeting. Brook et al. Assessed the efficacy of RF, that is a radio frequency ablation aided by the computed tomography in the palliative therapy of 14 advanced malignancy of head and neck cancer that recurred frequently with 27 applications. 100% success was observed in tumor targeting and 67 showed life improvement, while 11 of the applications showed major complications like stroke, carotid blowout with death, and threatened carotid blowout with subsequent stroke. Now, Belviford et al. In the retrospective study conducted from 2002 to 2014, he evaluated 22 patients with unresectable head and neck cancer treated with thermal ablation and observed better survival rates and concluded that this technique could prove a successful treatment for treating head and neck cancers locally. This method exhibits benefits, as I said, benefits and limitations I will show in the table 2. Now, intratumoral therapy. The conventional systemic chemotherapy is normally restrained for metastatic and recurrent tumors, which deliver the drug to the tumor site passively. This normally causes drug expulsion, due to which the cancer cell develops resistance towards the drug, the inability reducing the therapeutic effects. Hence, the local drug delivery directly into the tumor site may overcome these limitations. Okay, so when there is conventional systemic chemotherapy, the drug is delivered to the tumor site. Okay, but sometimes it is like that, drug expulsion is there, due to which the cancer cell develops resistance toward that drug. So particularly we are using intratumoral therapy, means the local drug delivery is directly done into the tumor site to avoid these limitations. So the recent literature depicts local intratumoral therapy for oral cancer, which is becoming more common in practice to enhance patients' quality of life. The localized drug delivery to the tumor site is done by several methods, such as injecting the drug directly into the tumor, infusion through the catheter, vascular infusion, or the intracavitary placement. Normally, most of the tumor sites are injectable, but some of those may need specific technologies to complete this action. So, intratumoral therapy can also be used for immunotherapy with cytokines, immune modulators, genes, and interferons. Now, Bakir et al. In the retrospective study presented an analysis of 3 patients which are already re-irradiated with recurrent head and neck squamous cell carcinoma who were treated with the intratumoral injections of holminium-166 microspheres under the ultrasounded guidance with a dose of 70 to 100 gray. They concluded that the palliation of the head and neck squamous cell carcinoma patients was minimally invasive and relatively safe. Lee J. et al. Studied the intratumoral application of biodegradable hydrogel controlled drug release system and observed the enhanced therapeutic effects and diminished side effects of suberoline hydroxynic acid cisplatin, that is SAHADDP, in the treatment of oral squamous cell carcinoma. SU et al. Explained 32 Syrian male hamsters after cancer induction and divided into 4 groups: saline intraperitoneal, saline intratumoral, doxycycline intraperitoneal, and doxycycline intratumoral. So there was a scientist, okay, with 32 Syrian male hamsters after the cancer induction, divided into 4 groups. Okay, he took saline as intraperitoneal, saline as intratumoral, doxycycline as intraperitoneal, and doxycycline intratumoral, and evaluated them clinically, histopathologically, and immunohistochemically. So, dox-IP and dox intratumoral, that is doxycycline intraperitoneal and doxycycline intratumoral, reported a significant decrease in the mean tumor volume, and the intratumoral therapy was included as suitable alternative to the systemic administration. Now we'll move to the photo. All the advantages and disadvantages, again I am telling, I'll say at the end. The photodynamic therapy, that is PDT, is the non-invasive types of phototherapy which is characterized by its efficient therapeutic results. It is an established and proven aid to treat various malignant and non-malignant disorders. The most important advantage of photodynamic therapy is it reduces the long-term morbidity, and it is a new method which has significant parameters of success of treating oral cancer and dysplasia. It mainly uses 3 components to attain the required effect on tumor cells, which are photosensitive compound, photosensitizer agents having significant wavelength, and oxygen dissolved in the cells. So, this photosensitive agents, that is PS, yeah, photosensitive compounds, are substances that absorb light with specific wavelength, leading to some photochemical or photophysical reactions. These components provide desirable effects within the damaged tissues when used together and form a highly reactive product, which causes remarkable toxicity, eliciting cell death via apoptosis or necrosis, but ineffective when exposed to tumor cells. Okay, now what this photosensitive compounds do, they absorb the light with specific wavelength, which leads to the photochemical or the photophysical reactions. Okay, but they are not, means they cause the cell death, they cause the apoptosis, and they cause the necrosis, but they are not effective when exposed to the tumor cells. Now it works on the three mechanisms, that is direct cytotoxic damage to tumor cell, destruction of tumor vascularity, and inflammatory reaction that leads to systemic immune response. Now the PS must be a single material with deep absorption of red to infrared wavelength between 650 to 800 nanometer. Now they are divided into porphyrins, induced protoporphyrin, chlorines, and that is M-tetrahydroxyphenylchlorine, MTHPC, benzoporphyrin derivative, pyrophenyl formide derivative, that is HPPH, and tin-2-ethylpurpurin, bacteriochlorine, phthalatocyanides, synthetic and natural dyes. Various clinical trials concerning this porphyrins and porphyrin sodium are being conducted for treatment of cancer in the oral cavity. In 2013, Riguel and et al. Assessed the safety of pyrophosphamide bromides HPPH in that is the photodynamic therapy in 45 patients with early head and neck squamous cell carcinoma and concluded it a safe treatment. Recently, Khan et al. Investigated the capability of simple smartphone-based device for imaging 5-ALA-induced protoporphyrin 9, that is PP9 fluorescence for treating 29 patients with oral squamous cell carcinoma. It has been found that this method, when combined with other techniques, resulted in a better version with minimal side effects. So due to all these properties, photodynamic therapy becomes the most successful current therapy in oral cancer. The limitations are always there, which I'll discuss later on. Now, photothermal therapy, that is PTT. It is a revolutionary technique that utilizes and encourages therapeutic near-infrared laser photoabsorbers that generate heat for cancer cell thermal ablation. Now, PTT is a local treatment modality that mainly employs the assistance of optical absorption of the photothermal agents called the photosensitizers, which absorb light energy, gets excited, and convert it into heat energy that targets the tumor cells. The agents get stimulated by electromagnetic radiations like radio frequency, visible light, microwave, or the infrared. This technique is minimally invasive, resulting in minimum cytotoxicity. It is independent of oxygen for the cellular and tissue interaction and uses the light for longer wavelength which does not harm the normal cells and tissues. An ideal photosensitizer must have the least toxicity potential in the absence of light. Cytotoxin in the presence of light of certain wavelength and a strong dispersibility in aqueous solution is advisable. There should be adequate photostability, high cross-section absorption, easy activity, and solubility in the biocompatible solutions. At present, several materials have been used for PTT, such as noble metal nanostructures, nanocarbons, transition metal sulfides or oxides, and organic nanoagents. The gold nanoparticles has been used as an innovative tool for diagnosis and drug delivery for different cancers due to their remarkable properties, which include bacteriostatic, anti-corrosive, antioxidative, high stability and non-toxicity, non-immunogenicity, high permeability and retention effect, and high surface volume ratio, which provides additional benefits. Inorganic nanoparticles are based on noble metals like gold, which are potential photothermal agents with high therapeutic efficiency, which are non-toxic, non-immunogenicity, high permeability, and high retention effect, which helps in penetration of drug and the drug accumulation at the tumor sites. Some PTTs and PDTs are also combined. It means photodynamic and a phototherapy are combined to improve the therapeutic effect in oral cancer management. Zul L. Zul et al. Studied the efficacy of PTT with nanoparticles in the treatment of cancer and depicted that it is having more efficient effects. Now, immunotherapy. It has been developed as a progressive innovation for the treatment of diverse types of cancer, leading to the localization of head and neck. Immunotherapy counteracts the suppressing signaling pathways of immune system and strengthens it by stimulating its specific components. Now, what does immunotherapy do? It suppresses the signaling pathways of the immune system and strengthens it by stimulating the specific components. It is used as a remarkable approach to cancer therapy because it includes both cell-mediated as well as the humoral immunity with variable form of antigen receptors that can distinguish between normal and the cancer cells. It means the immunotherapy, it has a remarkable approach to cancer therapy because it includes both type of immunities, that is humoral and cell mediated. Okay, and with it has the variable form of antigen receptors which knows which is the normal cell and which is the cancerous cell. Now this is divided into active and passive. The active immunotherapy requires tumor cell attack, which use the tumor as a target. The cells here are dendritic, NK, and cytotoxic T cells. Mainly, whereas in passive immunotherapy, the cell surface receptors are targeted, okay, leading to enhancement of the immune system and further to the development of antibody-dependent cell-mediated cytotoxicity. Now, systemic cell-mediated immunotherapy. This is a non-specific type of immunotherapy that leads to the replacement of entire immune system by local or systemic anti-tumor response. Now, targeted immunotherapy. The studies are being conducted to investigate the use of several tumor-assisted antigens, which can be used as a therapeutic targets in head and neck squamous cell carcinoma. These can be either tumor-specific antigens, tumor-specific mutated proteins, or antigens overexpressed in the tumor cells. Now, vaccines. Vaccines are the therapeutic measures that include an anti-tumor immune response by acting as a tumor-associated antigen, that is TAA. Now, vaccine is also used as a therapeutic measurement for this immunotherapy control in the cancer, oral cancer. And the immune stimulatory adjuvant resulting in the immune sensitization to the tumor antigens. Vaccines direct T cells to recognize and eliminate the tumor cells. They contain variable antigens such as DNA, RNA, peptides, dendritic cells, or the whole cell. There are different types of vaccines. Sorry. Yes. Antigen vaccine, dendritic cell vaccine, DNA or RNA vaccine, and a whole cell vaccine. Now, what are antigen vaccines? They are made up of unique patient tumor antigens that destroy cancer cells further. What are the dendritic cell vaccines? They are made up of dendritic cells that are capable of recognizing and attacking the cancer cells. The DNA or the RNA vaccines, they are the tumor regression vaccines with effective results. Now, whole cell vaccine, rather than containing specific antigens, these vaccines are developed from the entire tumor cells. Several vaccines are currently under review. Okay, we are not completely reliable on the vaccines for the head and neck squamous cell carcinoma, like the DNA vaccine INO3112 and the peptide vaccine, that is Mucin 1 and Allovax. Okay, these are the vaccines which are currently in the clinical trials for the head and neck squamous cell carcinoma. Vaccine induce long-term immunity with less toxic effects and can be used in combination with other immunotherapies. Only limitation is high cost, long time taken, to bring the immune response, inability to apply the therapy of fast growing tumors. Like if there is a tumor which is fast growing, then the vaccines are not used. We cannot use, I mean. The immunotherapy is being used as a promising technology in the therapy of oral cancer nowadays. Okay, now this is the table 2, which I was writing in all my slides, that this is the advantages, this is the disadvantages. Okay, I am not going to say all the advantages. Okay, if you want, you can take the photo. I'll just say 2 or 3 advantages of each and we'll move to the next slides. Just a minute. Okay. The first is the photodynamic therapy, PDT, that is target cells. The targets only cancer cells sparing normal cell. It means it targets the only cancer cell and does not affect the normal cells. Can be delivered as an outpatient procedure. Okay. It is less risky, less time taking, inexpensive, effects on the tumor vascularity. It may alter the immune response, offers the potential improved functional cosmetic outcomes. It maintains the normal tissue functioning and long-time morbidity is reduced. Now, what are the disadvantages? It treats areas where light can reach, local skin reactions. There can be local skin reactions. Limited penetration of light leads to less depth of tumor destruction. It means, as I said before, if we want, if there is 5 centimeter of tumor and we want it to make by 2.5 or 3, but if light does not penetrate in the depth of the tumor, then the tumor cannot be destructed or the size cannot be reduced. There is immunosuppression, mild to moderate pain at treatment sites. Patient is advised to avoid the sun for few weeks. Now, photothermal therapy. The capability of deep tissue penetration is there, which was the side effect in the photodynamic therapy. Now, it does not affect the surrounding healthy tissues and cells. There is minimum toxicity. It improves the result when there is used with the combined therapy. Now, thermal stability is highly critical parameter for photothermal materials. The morphology of nanomaterial has significant effects on its physical chemistry and biological properties. Immunotherapy, it helps in induction of the systemic immune response. As I discussed in the 2-3 slides before, it has humoral and cell-mediated immunity. It helps in tumor regression, targeting approach, better tolerance, less cytotoxic, induction of tumor necrosis, apoptosis is there, and it does not affect the normal healthy cells. Now, what are the side effects is diarrhea, fatigue, tiredness, and pantocytopenia. Monotherapies are not capable of overcoming major events. It can lead to anti-tumor immunity in the patients. Now, ultrasound. It is non-invasive, painless transmission of energy into the body, helps to increase the drug penetration, very helpful in gene therapy. Intact skin, no puncture, hence there is low risk of introduction in the infection, reduces the interaction with anti-neoplastic agent with healthy tissues. It helps to increase the drug penetration, but the side effect is time consuming. Stratum corneum must be intact for effective drug penetration. Strong, attenuated by bone. Therapeutic agents are variable, and ultrasonic rays may lead to DNS damage in cancer cell sometimes. Okay, ultrasound is the latest one. Okay, we'll see this. Ultrasound is widely used in diagnosis as well as therapeutic applications nowadays. The ultrasound energy can be used as non-destructively for effective therapeutic outcomes for drugs and genes for better cancer treatment. These drug delivery systems works in a manner by which the acoustic energy deposition of the ultrasound is used to create vascular and cell permeability changes to intensify the transport of the drugs as well as for positioning and activating the drugs and genes via specially tailored vehicles or the formulation. It means here the ultrasound acoustic energy is used to create the changes in the vascular and the cell permeability so that the cells become more permeable when the drugs are transported to that cancer site or the tumor site. This cavitation acts as a triggering factor that leads to drug release as a targeting region. Multiple ultrasound drug responsive systems are used like microbubbles, nanobubbles, nanodroplets, and polymeric micelles, liposomes, and microemulsions. Research in the last decade has shown novel ultrasound directed gene drug delivery system has immense potential clinical therapeutic value for cancer patients in the future. Now, various mechanisms involved in the sonoporation are production of hyperthermia. The ultrasound increases the medium temperature by absorption of the sound waves. With increase in the ultrasound frequency, the coefficient of absorption also increases, which leads to the hyperthermia. And we know due to hyperthermia is one of the technique or one of the modality for chemo prevention in the oral cancer, and which can be used as an adjuvant therapy also, hyperthermia. Now, production of the cavitation activities. In the medium where ultrasound is exposed, the hollow space is created, which is termed as cavitation, which is divided into two categories. That is internal, that is bubble grows rapidly depending on the ultrasound frequency. It collapses after reaching certain diameter, and then there is stable, internal and stable. Instable oscillating bubbles are formed which collapse due to sonochemical reactions in extreme conditions where the temperature is about 5000 K and the pressure is 3000 bar. Now, acoustic streaming effects. Physical forces of the ultrasonic sound waves expert pressures that lead to the displacement of ions and micromolecules, perturbation of the drug carrier, cell permeability, and capillary rupture. Stresses are inflicted upon the cells and tissues as a result of cavitation events. The current novel approaches mentioned above have been found to be useful and beneficial as they come with certain obstacles. As we know, there are always advantages and disadvantages, okay, which exist for the treatment cancer. The photodynamic therapy can be used for the treatment of cancer beneath the skin, as the light is used to penetrate 1/3 of an inch or 1 centimeter. Photothermal therapy causes damage to the normal tissues, and at times there is an insufficient therapeutic effect due to limited penetration of light. In cancer immunotherapy, the limitation includes difficulty in identifying the significant biomarkers, development of the resistance to the drug, and its expensiveness. Now, during hyperthermia and thermoablation, the accuracy and the homogeneity of nanoparticle accumulation at the cancer site is critical issue, and the nanoparticles do not penetrate the poor vascular tissue. To fully exploit the possibility, however, better understanding of paradoxical role of fibroblast in malignancy is required. In most of the solid form of tumors, cancer-associated fibroblast, that is CAF, are major microenvironmental components that are emerging as a key participant in immune modulation that changes the tumor microenvironment. To fully exploit this possibility, a better understanding of this role of fibroblast in malignancy is required. Now, recently the clinical trials are going on with this recent technique, that is the target drug delivery system, that is TDD, okay, or the LDD, that is local drug delivery. Okay, these are the ongoing trials. If you want, I'll read one by one. Okay. Different techniques, still the research has been going on. For example, the fast dissolving oral thin films. Okay, they are yet to start. Okay, here. Second, means they have done the placebo effect with the drug. Okay, they are in the phase 1, but we haven't got the complete this study that okay, this can be used in each and every patient, or this has this type of effect with no side effects. Okay, then hyperthermia and thermoablation, they are recruiting these techniques in head and neck cancer with high recurrence rate. Okay, and there was one study going on in the influence of tumor microenvironment, head and neck neoplasm recurrence tumor. That study has been completed, okay, in Berlin, Germany. Okay, the phase 1 has been completed. In about 2, they have completed phase 1. They are in the phase 2. They are recruiting. Okay, the combination of hyperthermia and concurrent chemoradiotherapy, that is CCRT, for head and neck cancers. The next is randomized multicentric therapeutic confirmatory study for efficacy and safety of proximism, better supportive care versus best supportive care in patients with advanced head and neck cancer. Okay, this is ongoing therapy. This is the phase 1 and phase 2. They are the intratumoral drug proxenium. Okay, that drug is given intratumoral. Phase 1 and 2 is cleared. Phase 3 is going on. The trials are going on. That's intratumoral. Okay, then in phase 2, there is one more study going on for metastatic or unresectable recurrent head and neck cancer. Intratumoral is going on. Clinical trial phase 2. The next one is combined with the cisplatin and paclitaxel in patients with head and neck cancer. Okay, this is in phase 2. Okay, intratumoral injections are given with cisplatin drug along with this intratumoral therapy with the uh, paclitaxel. Okay, in the nasopharyngeal carcinoma, they are doing this study in phase 2. Next is photodynamic therapy. Okay, this study is completed. Phase 1 has been completed. Teporphin sodium device is used. Lumaflex light delivery catheter via Lumaflex light delivery catheter. Okay, so they have completed phase 1. They have done it in liver metastasis, pelvic cancer, head and neck cancer, sarcoma, rectal and breast cancer, mouth cancer, and colorectal cancer. So they have completed this photodynamic therapy phase 1 in these cancers. Okay. Next is this stage 1 is also completed photodynamic therapy along with the conventional surgical therapy in HPPH. Okay. In the lip and oral cavity cancers, oropharynx, paranasal sinus, salivary gland, along with 30 plus more cancers of head and neck. Now, photosensitizer, that is redaporfin dose 50 J per square meter of laser light, okay, of 750 plus or minus nanometer is used. Okay, and phase 1 and 2 they are ongoing. Advanced head and neck cancer mein. Okay, for advanced head and neck cancer patient, photosensitizer, that is redaporfin with the laser light at 750 nanometer is used, and the trials are going on phase 1 and phase 2. Okay, this is photothermal therapy, pilot study of laser therapy in the patients with refractory and or recurrent tumors of head and neck. Phase 1 means the study is totally completed. Okay, so phase 1, 2, and 3 they have done in the American Western regions in the Arizona Baylor College of Texas. This study is completed for phototherapy. This is immunotherapy. This is phase 2 active. Active means the study is going on at present. There is surgery done, then intensity modulated radiation therapy is given, image guided radiation therapy along with the drug that is cisplatin. And it is used in the treatment of resectable head and neck cancer, head and neck carcinoma, and cancer of head and neck, other squamous cell carcinomas. That is in phase 2. The next is clinical trial, malignant neoplasms of overlapping sites of lip, oral cancer cavity, and pharynx. The phase 3 is going on. Okay, here they have given cetuximab dosage. Okay, initial dosage was 400 milligram per square meter IV infusion over the period of 120 minutes. Okay, 250 milligram per ml per week at the second visit, and then IV infusion over the period of 60 minutes. So that is going in phase 3 at present, and the IOCCON Laboratories Private Limited and Enzyme Biosciences Limited. That is not yet recruited. Okay, they are in the phase 3 trial. Okay, it is used in recurrent locoregional or metastatic squamous cell carcinoma of head and neck here. Okay, but they have not recruited. Next, the ongoing is the first line in treatment of locally advanced head and neck cancer with double checkpoint blockade and radiotherapy. That is intratumoral and infiltration of CD8 plus tumor cell. Okay, so they are in phase 2. Next is clinical trial to investigate the biomarker effects of the pre-surgical treatment with DNA damage repair agents in the patient with head and neck squamous cell carcinoma. Okay, they are planned to undergo surgery, likely to be followed by radio and chemo. Okay, they have used the drug seralasertib 160 twice daily, but they are in phase 1, they are not yet recruited. So like this, I guess this is the last one. This is on ultrasound. There's a head and neck ultrasound hyperthermia. As we said that when sound waves are there, then the heat is generated and it affects the tumor cells. So ultrasound hyperthermia treated with therapeutic ultrasound device. Okay, on 1, 3rd, 5th, 7th, 9th day of 21-day cycle each with the drug fluorouracil and cisplatin. They are in phase 2 and they are on the verge of recruiting. Okay, so this is my conclusion. Oral cancer is an emerging public health problem worldwide. Various conventional therapies are used for treating oral cancer. Okay, all techniques described here in this presentation are proven effective results in therapeutic interventions of oral cancer. Moreover, they can be used single or with the combination with the conventional drug delivery systems or the drug therapy to show the beneficial outcomes. More research on CAF, that is collagen activating fibroblast, and the relationship with tumor microenvironment will help in better understanding the target cancer therapeutics. Several clinical trials, as I showed, are still going on, and we are waiting to see the results there. These are my references. Thank you.
Thank you so much, ma'am. Anyone, if have any questions, may please ask. Ma'am,
In case there
question
is
is a
1
question
minute,
in chat box.
just a moment.
Are 5 ALA, PS, and other photosensitizers available in India?
Sorry, ma'am. Just a moment, ma'am. Yes, ma'am. Okay, sorry. Ma'am, that Zoom box is not opening. Just a minute.
Ma'am, I'll repeat the question.
Wait a minute, ma'am. Wait a minute. That Zoom box is not opening. It's just my presentation opening. Mm. Ma'am, I'm unable to see that Zoom box.
Ma'am, I'll repeat the question if you want.
Yes, ma'am. Please repeat the
Yes,
question, ma'am.
yes. Are 5 ALA photosensitizers and other photosensitizers available in India?
Ma'am, I don't have idea. Mostly it is not available in India because the studies are mostly, I have seen the studies are mostly done in Germany and in US. I haven't seen any study done here in India yet. I haven't come through along it.
So, ma'am, are there any photosensitizers available, or you are not aware of it?
Ma'am, I'm not aware of it. I'm sorry. Means mostly those are with the studies which I have come across are already done in the USA and Germany. I don't know, ma'am, the photosensitizers available in India.
Okay, ma'am, no problem.
Yes,
Ma'am,
ma'am.
please share your email ID. If anyone has any question, they may contact you in the future.
Yes, ma'am. I'll write it in the chat box.
Okay, ma'am. Okay, ma'am. Ma'am, then I'll move to the next speaker.
Yes, ma'am. I'll just write my email ID and then.
Okay, ma'am. Okay. Next, I'll be introducing the next speaker of the day, Dr. Manpreet Arora. Dr. Manpreet Arora is graduated from Manipal College of Dental Science, Mangalore, Karnataka in 2003 and completed her MDS in Oral Pathology and Microbiology in 2006 from the prestigious Manipal College of Dental Sciences, Manipal. She is currently working as professor in the Department of Oral Pathology, Faculty of Dental Sciences, SGT University. She has been part of the SDT family since 2010. She has a teaching experience of more than 19 years and has presented various papers in national and international conferences. She has also been awarded with many national and international publications to her credit and is in the panel of examiners for both undergraduate and postgraduate in prosthodontics in various universities. Also, she has authored and reviewed books of her own specialty. She believes that a dentist, particularly an oral pathologist, needs to assume a leadership role in early diagnosis of oral cancer, which is a growing problem globally and in India, and her area of interest lies in the newer methods and techniques for timely detection of oral cancer at a very early stage. She has a keen interest in forensic odontology and has done a universal certification course of 1 year in forensic science and forensic odontology. Besides being involved in teaching and the academic activities of the department, she was alumni in charge of the university, member of editorial board, SGT University Journal, and is also involved in various university activities. Dr. Manpreet is a member of the Indian Dental Association, a life member of the Indian Association of Oral and Maxillofacial Pathologists, and a life member of the Indian Association of Forensic Odontologists. She actively participates in various specialty related conferences and continuing dental education programs and is very keen on the overall development of the students. She is a dynamic personality who is always ready to contribute to the development of the university. So today she'll be presenting with the topic liquid biopsy, a step closer to oral cancer diagnosis. Ma'am, please, over to you.
Thank you for the introduction. Very good afternoon to everybody. I hope I am audible and my screen is visible.
Yes, ma'am, you are audible and your screen is also visible.
The topic which is given to me today is liquid biopsy, a step closer to oral cancer diagnosis. So we have been reading about oral pathology, listening about oral cancers from morning. So just a brief overview. Oral cancer is the sixth most common form of human cancer. It can arise de novo or from oral pre-malignant disorders, with leukoplakia being the most common PMD. Now, PMD has an estimated annual malignant transformation rate of 10%. And despite different technological advances in the medical sciences, it is still not possible to predict which oral pre-malignant disorder will progress into cancer. And clinician and pathologists, they are still relying on the same histopathological and clinical indicators which were used for last 40 years. So what is the most important challenge in oral cancer is to reduce its burden and to improve the outcome of outcome for the individual which are affected. I'm sorry, I'm just give me a second. I think there is a glitch. Just give me a second. I cannot view my slides actually. Can you all see my slides?
No, ma'am.
Your inbox is visible actually.
Oh.
Email is open.
Yes, now slides are visible.
So what's the challenge? Regrettably, despite of the oral cavity being of the easy access, oral squamous cell carcinoma is still being diagnosed in a very advanced stage, mostly in stage 3 and 4 of the disease. And this is translated to a significant morbidity and an estimated overall survival of approximate 50% in the first 5 years. So the challenge of this decade, therefore, is to reduce both mortality and morbidity of this disease through the development of the strategies that detect oral squamous cell carcinoma at an very early stage. Now, next is what is liquid biopsy then? So liquid biopsy is nothing else but to analyze the biomaterials, which are protein, microRNAs, circulating tumor cells in the body fluid, such as blood, saliva, breast milk, and urine. Since we are talking about oral cancer, salivary markers are increasingly recognized as a promising tool for early detection and diagnosis of oral cancers, as saliva is easily accessible and comes in direct contact with the oral lesion. It can be collected with minimal discomfort, and it has the potential for mass screening and routine monitoring in contrast to traditional methods like biopsy. So saliva contain biomarkers, which are molecular indicators that can help diagnose, monitor, treat oral cancer. So today, in my presentation, I'll be limiting myself only to the markers which have been, studied for oral cancer and not in other cancer per se. So which molecules, now the question is, which molecule present in saliva have the utility to be used as biomarkers for the early detection of oral cancer? So the aim of my presentation is to provide you a literature review on the molecules which have been assessed and possible biomarkers which are promising for the diagnosis of SCC, and also challenges in the use of these markers to clinical settings. Now, till now, if you see the literature, more than 60 molecules have been studied in saliva of the patient with oral squamous cell carcinoma and oral pre-malignant disorders and healthy controls. And most of these detected markers have been oriented towards early diagnosis of SCC and predicting the malignant transformation of oral PMDs. Now, when we categorize these markers which have been studied in saliva, we can broadly classify or categorize them into 6 subcategories. First is enzymes, glycoproteins, cytokines, microRNAs, metabolites, and some miscellaneous. So we'll be discussing the important ones in each category. Coming on to first the enzymes. So when I went through the literature, these are the 6 enzymes which have been studied to the maximum. Among them, MMPs, matrix metalloproteases, 9 was the most frequent studies. Lactate dehydrogenase, aldo keto reductase family 1 member B10, 1-fructose, cathepsin V, and kallikrein. And all of these enzymes, they have been reported to be altered between healthy and oral SCC patient and have shown to be elevated salivary concentration in SCC patient when compared to control group. And if I talk about all these 6 markers, LDH is the most studied enzyme among the 6 markers. Now, when we talk about MMP, matrix metalloprotease 9, it has been described as having multiple function, including its participation in protein and extracellular matrix degradation, promotion of angiogenesis, and regulation of initial step of carcinogenesis and invasion. Most of these studies which have been done on MMPs agreed on the potential of this marker for the diagnosis of SCC and PMDs with possible utility for predicting the malignant transformation of previous PMDs and treatment monitoring of oral squamous cell carcinoma. In a study done by Smriti in 2020, she has also reported significantly higher salivary MMP 9 in SCC patient when compared to OMD patient. The most studied biomarker, that is lactate dehydrogenase, which is a catalyzing enzyme found in most of the cell, participating in cellular metabolism and playing a key role in final step of anaerobic glycolytic metabolic pathway. LDH is associated with cell membrane damage, and therefore quantification of salivary LDH could be related to death or cellular damage. And many studies, they have shown that salivary concentration of LDH could be related to tumor size and cancer cell. A study done by Awasthi in 2017 suggested that elevated level of this enzyme could be explained by uncontrolled cell mass increase, leading to the release of free analytes into the saliva. The second category of biomarkers which have been studied, they are glycoproteins. Carcinoembryonic antigen and CD44, they are the 2 which are included in this categories. And studies, they have shown that both these increase in saliva of oral squamous cell carcinoma compared to control group. CEA has also been analyzed in conjunction with another marker, that is N-alpha acetyltransferase 10P. And when we combine these two markers, there was a significant increase in the sensitivity and specificity of the detection of SCC, which was 92.75% and 85% respectively. Now, the maximum studies were done on cytokines. Many studies, they have analyzed the expression of salivary, expression of different cytokines, which included IL-6, IL-4, 10, 13, 1 beta, 1 RA, 17A, 17F, interferon gamma, tumor necrosis factor alpha, hepatocyte growth factor, CRP, VEGF, and most of these studies were done on cytokine IL-8. Now, interleukin-8 play a very different role in carcinogenesis process, and it is including the promotion of epithelial to mesenchymal interaction, angiogenesis, and tumor growth. Now, however, there was some discrepancy regarding at what stage of the disease the detection of IL-8 was more relevant. Many of the studies, they have shown that IL-6 was mostly useful in early stages, while other associated its increase in later stages of squamous cell carcinoma. And apparently, interleukin-8 is better at discriminating these stages of SCC than oral PMDs, as not more than 60% of the articles indicated a rise of interleukin-8 in oral pre-malignant disorders. So the studies, maximum studies evaluated interleukin-8 in SCC and reported its usefulness for discriminating between healthy individual and oral cancer patients. In a study done by Singh et al. In 2020, both IL-8 and interleukin-1 beta were effective salivary diagnostic marker in all stages of SCC, showing a significant discrimination, especially in stage 3 and stage 4 and post-operative phases of SCC. Similar results were also reported with interleukin 7A and 17A and 17F, which were significantly overexpressed in saliva of patients with more advanced stage of diseases, particularly in stage 4. And furthermore, patients with larger primary tumor to the size of T4 and greater nodal involvement were also found to have higher level of interleukin 17. Another important cytokine which have been studied a lot is tumor necrosis factor alpha, which is reported to be a very important molecule within the inflammatory process, also capable of stimulating growth of fibroblast and inducing cell death. Now, this tumor necrosis factor alpha was also suggested to have possible utility in distinguishing between PMD, SCC, and healthy individual. The tumor necrosis factor alpha induces the release of other cytokine, thus creating a tumor environment that favors the proliferation and survival of these malignant cells. In this regard, some author proposed even that tumor necrosis factor alpha to be related to patients' lymph node involvement. Now, most promising results have been shown by analysis of microRNAs in saliva, and there are several studies which have investigated the concentration of different microRNAs in patients with SCC and oral PMDs, and all of these, they have shown significant difference in patient with SCC and PMD compared to control group. But what I found in these studies was care has to be taken while assessing salivary RNA level, as according to some studies, there might the level might also be affected by periodontal status. The fifth category of biomarkers which are analyzed in saliva are metabolites, which include ornithine, O-hydroxybenzonate, R5P, and tumor-specific antigen as biomarker for diagnosing SCC and PMDs. And it was found that there was significant increase of these metabolites in saliva of patients with less differentiated SCC. Some studies are also done on glycine and proline, which are both elevated in saliva of patient with SCC. In the miscellaneous category, we have angiopoietin, nucleolar complex protein, transgene, and reticulocalcin, which showed significant increase in patient with SCC compared to healthy controls. Now, in an interesting study by Data et al. They have found that when you combine these two markers and you study two markers together, that is your nucleolar complex protein 1 and reticulocalbin 1, the sensitivity and specificity increases from 68 and 70% to 98%. So combining the markers is the key. So whatever literature I have gone, the conclusion of the detection of salivary marker is that the salivary biomarkers, they do have potential to become a useful tool in detection, control, and prediction of malignant transformation and metastasis of oral PMDs and SCC. And all the authors in these studies, they have agreed that it is unlikely that one single molecule would meet all the requirement to be used as a biomarker. So efforts should be made to focus on developing a panel of biomarker utilizing different category of biomarkers, the 6 categories which we have used. Among the analyzed markers, some have shown more promise than others in diagnosing SCC and PMD, as they were assessed more and reported high sensitivity and specificity. And these included the 6 markers: tumor necrosis factor alpha, interleukin 1 beta, interleukin 6, interleukin 8, lactate dehydrogenase, and MMP9. They are the most promising with the strongest evidence in literature. However, every study they have, suggested more studies with larger cohorts and more robust study designs, which are required before translating the use of these markers to the clinical setting. And it would be interesting for future studies to assess the sensitivity and specificity of these markers when they are combined. Thank you very much for your patience listening before lunch.
Thank you so much, ma'am. Anyone if has questions can please ask. Ma'am, there is a question in chat box. Markers for OLP.
Okay, so markers for so these 6 markers, that is lactate dehydrogenase, which I've discussed in the last slide, they have been showing more sensitivity and specificity for marker for PMD means prediction of malignant transformation of PMDs. That is salivary microRNAs, mostly microRNA 21, then tumor necrosis factor alpha. Even studies have been done on glutathione peroxidase, uh, protein. So they all have been, they are sensitive markers for the transformation of PMDs into SCCs. But again, larger sample size and, combination of markers, they are required to, establish that this marker can be used to predict the transformation of PMD into cancer. Many have shown promising result, and among them microRNA 21, glutathione peroxidase, tumor necrosis factor alpha, and as I've told, alpha fetoproteins. They are better. They have shown good sensitivity. Anything else?
Okay, ma'am. Thank you so much. Ma'am, please share your email ID.
Yeah,
If anyone has any question, they'll get back to you.
I'll do that.
Okay, ma'am. Thank you so much.
Thank you for the opportunity. Thank you.
Ma'am, please share your email ID.
Already shared on the chat box. I hope you
Okay,
have.
ma'am. Okay.
Thank you.
Okay, ma'am. Thank you so much.
So there is a announcement from organizing team actually. Please listen carefully. We have 2-3 speakers who are having some emergency and all. I'm just letting you know about the status actually. So that's why we are having. Generally, we are not taking any lunch. We are because it's a virtual program, so we are allowing that our audience is also simultaneously having lunch and watching program. But we supposed to take a break of say 1 hour. We'll resume by 3 o'clock. The reason is that our one speaker, Dr. Saidul Islam, he's supposed to talk on reconstructive surgery. He is not available. His phone is not reachable. And Dr. Manish Tiwari, he went with his family to Kumbh Mela, Prayagraj, and he said that he would be his connectivity would be available some hotel and all, but due to some poor connectivity, he is not able to join the program because he said that's not possible with the poor connectivity of say mobile because it's interrupting. So all these speakers, even Dr. Ruwan, there is a huge power cut in Sri Lanka. So there is a blackout almost in Sri Lanka, and there is a two more speaker who would be joining from Sri Lanka, but they are, I just spoken both of them, Dr. Atigala and Dr. Rasika. Both would be joining with their power backup. They have the generator and all, so they would be joining. Dr. Rasika will join immediately after the break at 3 o'clock, and then Dr. Atigela will join. So, and then one speaker which supposed to join Dr. Vishal, his son is admitted with some, problem with his lung and all. So he said that I would send you the recorded videos. So we have the recorded videos of all those speaker, and we would be sending you on your email, registered email, and you can watch the program there. And if you have any question, regarding that video, you can send it to us and we can forward it to the speakers and they can answer you, or we can share direct email IDs of the speakers. So this is the announcement from the organizing team. We are resuming our program. Say it's a 1 hour break. We'll rejoin by 3 p.m. sharp, and then Dr. Rasika will start the presentation. Anybody want to ask any question, they can ask the question. We are not leaving the program. Just keep your microphone on mute mode and keep your camera off, and as soon as our speakers join, we'll reconnect. Anybody have any query, they can ask after unmuting your microphone, and they can ask the question. And it's really apology from our organizing team that it happens because it's a virtual world. All thing is based on the connectivity and all, and sometimes the connectivity is the issue. So we have to bear this. We are getting many speakers, those who want to join the program. This program is very prestigious, but we didn't allow them due to time constraint. But this is the problem we faces actually, that yesterday we also have to take a small break. Today we supposed to take, this is the first time happening in the the program of National Health Academy or MedSkill that we have to take break. Otherwise we never took any break in the past. All the recordings are available in our library, and you will also getting the the links of these videos. So those who are not able to watch the program or listen the program due to their occupancy in their work, they can see the program, and they can they can revise the program with the their interest area. So we would be sending the links of all the programs after the program ends. By the time we are just pausing here, and we'll rejoining at 3 p.m. Anybody have any question? They can ask question right away. Otherwise, we are keeping our microphone off, camera off. Yes. So it's 1:55. Just we are resuming it another 1 hour. We'll join again sharp 3 p.m. Indian Standard Time, and we'll continue. Thank you. Uh, with this request, Dr. Manish Tiwari has sent a link for his video. So by the time you are having your lunch, we are playing the video that which Dr. Manish Tiwari should would be covering in that. So this is the video. I'm just requesting my organizing team, those who are in the back end, they can play the video, and you just watch the video, and whatever is the question you would you want to get the answer, you can email to the email which is mentioned in our brochure, and we'll get the answer back to you. So can I request my backend team, could you please play the video? Mr. Rehan, could you please play the video?
Various neurovascular bundles, and my presentation focuses on surgical technique for compartment clearance of IDF using digital illustrations. There are multiple factors that makes the IDF clearance complex and challenging surgery. One of the factors is inability to assess the surgical margins in third dimension because of edema. And then there can also be heavy bleeding because of tumor proximity with pterygoid venous plexus. And now we will see the anatomy of the infratemporal fossa. This illustration represents the masticator space, which includes masseter, mandible, the temporalis muscle, and the lateral and medial pterygoid muscles and pterygoid plates. The infratemporal space lies medial to the mandible, that excludes the masseter muscle. This area contains various neurovascular bundles and also the pterygoid venous plexus. The oral cavity tumors, mainly the buccal mucosa and RMT tumors, have high tendency to spread into the masticator space because of their proximity with the masseter and medial pterygoid muscles, and also the posteriorly located maxillary tumors, and in some scenarios, temporal bone and orbital apex tumors can also spread to this region. Where in this diagram, a portion of mandible have been removed, and it shows the relationship of the maxillary artery, two heads of lateral pterygoid muscle, and how this space is bounded medially by parapharyngeal fat, and medial to that lies the internal carotid artery. So this fat makes a separation between the parapharyngeal structures and the infratemporal space. It is important to remove the entire masticator space as a single unit. This will minimize the bleeding because you are not disturbing the pterygoid venous plexus. And also, by removing the compartment as a single unit, you ensure that there is no residual disease left behind, especially in the third dimension. The IDF tumors can be classified into three categories: low, intermediate, and high. The low IDF involves the masseter and medial pterygoid muscles. The intermediate involves the medial pterygoid, lateral pterygoid, and the pterygoid plates. Where the high IDF tumors, they will involve the intracranial components and also the pterygomaxillary fissure area. The category 1 and category 2, these are considered operable and have got good outcomes with the procedure described. But the high ITF tumors, the tumors that have spread beyond the compartment, that is via the pterygomaxillary fissure or the foramens of skull into the middle cranial fossa. So these tumors, they are considered inoperable because when you operate them, chances of leaving behind residual disease is very high. Present demonstration is based on a posterior buccal mucosa lesion involving RMT and infiltrating the muscles of mastication, and also involving the mandible and the maxillary alveolus. So for such a case, when the lesion is located posteriorly into the buccal mucosa and skin is free, you go for a midline lip split incision. And when the lesion is located anteriorly, you need to go for a corner of mouth lip split in order to avoid necrosis of this area. The cheek flap should be raised, keeping the intraoral resection margins at least 1 centimeter away from the lesion and deep to the buccinator muscle. That is, buccinator muscles lies on the specimen side. Exposing the buccal fat pad, fascia over the masseter is taken into the flap in order to save the branches of facial nerve and keep the parotid intact. And this is how superiorly you need to expose the zygomatic bone and the maxilla. Once the cheek flap has been raised, we have to separate the masseter muscle from the zygoma and expose the zygomatic bone and sigmoid notch area. And after separating the masseter muscle, one need to release the sphenomandibular ligament. After that, segmental mandibulectomy is done with 1 centimeter bony margin from the lesion. Before further mobilization of mandible, stylomandibular ligament should be freed from the mandible. After segmental mandibulectomy, the mandible is retracted anteriorly in order to expose the internal maxillary artery, and that is ligated. This is a crucial step in order to avoid heavy bleeding during further course of surgery. Please note that anterior retraction is facilitated only after releasing the sphenomandibular ligament here. Once this is done, the mandible is retracted in order to expose the mylohyoid muscle medial to the mandible, and the mylohyoid muscle is separated at the same time, saving the lingual nerve along its length. Release of mylohyoid muscle enhances the retraction of the mandible, and now the palatal incision is given, followed by palatal osteotomy. And now the cut can be given on the lateral surface of the maxilla, and inferior portion of zygomatic bone and zygomatic arch can also be taken into the specimen depending on the extent of the disease. Now the specimen is down fractured and greater palatine artery is ligated. Once the specimen is down fractured, the temporalis muscle is resected from as high as possible, exposing the skull base, followed by resection of the lateral pterygoid muscle. At this point, the dissection is done by hugging the skull base bone, and this is the single most important step in this process. Once dissected, the pterygoid plates are exposed. There are two areas at this point that bleeds heavily. One is the pterygomaxillary fissure area, and second, the foramen ovale. It is important to keep the systolic pressure low at this point, and also bone wax and gel foam can be appropriately used. Now the pterygoid plates are separated from as high as possible in order to remove both the pterygoid plates at once, and it is osteotomized and the whole specimen is separated. And this photograph shows complete ITF clearance with the exposed skull base, the intraorbital fissure, the pterygomaxillary fissure, and root of pterygoid plates. The internal carotid artery is safe behind parapharyngeal fat and fascia. Hello friends, many of you had difficulty in understanding BSSO. So today I'll explain you BSSO in easiest language, and you will I'll try to explain you this. So suppose this is the mandible, this is the body, and these are the ramus of the mandible. I think like this you can visualize it better, that how the mandible is there, right? Can you visualize it? The ramus, both sides, and the body. Okay. And I have taken two papers because one is the inner cortex and one is the outer cortex.
Mr. Rehan, could you please stop sharing your slide? Yes. So, Dr. Manish, I think you are in a meeting room, though your connectivity is not,
Yes, I'm there.
So yeah. So we have played your video. People are very keen to listen you. As you know, they have listened you in last two editions. I think this is the third edition where you are our distinguished speaker. So there are some of, because most of the people who are watching live on our webcast on our website iocon.org, but those who want to interact with the speaker, they are into the meeting room or a Zoom room. So anybody who is there in a meeting room want to ask any question with Dr. Manish, they can ask question right away. He is available now, and we are fortunate that he is having such connectivity that even though he's a busy in Prayagraj, but he has spared his time and he's joined us for sake of our program and for our IOCCONians. So anybody who want to ask any question, they can ask right away question, or they can ask question through email or a chat box. Dr. Manish, there is no any question right now, and we would be sending this video along with your profile and all, so that they will watch it when they have time actually. And when there is any questions come, no, I'll definitely get back to you.
Sure, sure, Dr. Noel. Thank you so much. Thank you.
Thanks
Thank
for
you for
spending
having
your
me.
time, Dr. Manish, even though you are stuck somewhere. Yeah.
Thank you for having me. Yeah, thank you.
Okay,
Bye.
thanks, Dr. Manish. We'll see you in our next program then. Yeah. Okay.
Sure, sure. Bye bye.
I got the email from Dr. Ruwan Jesinghe. He is our speaker, and he is where the connectivity is again poor, and he have sent his recorded video. So my backend team is trying to play the video just the way we have played the video of Dr. Manish. So we are playing Dr. Ruwan's video. You just I'm just requesting my team. Just give me a moment. I'm just requesting my team. So before we play Dr. Ruwan's video, let me introduce Dr. Ruwan Jayasinghe. Dr. Ruwan is a senior professor and chair in oral medicine and radiology, and a specialist in oral surgery in the Department of Oral Medicine and Pediatrology, Faculty of Dental Sciences, University of Padania. He is adjunct honorary professor at Tized University, UK, adjunct professor, University of Sastra, Cambodia, adjunct faculty in Savita Dental College, Chennai, India, and adjunct faculty in Sri Ramchandra Dental College and Hospital, Chennai. He received his graduation BDS from University of Peradeniya in 2001 and received MS Oral Surgery from the Postgraduate Institute of Medicine, University of Colombo in 2005 and became a board certified specialist in oral surgery in 2007. He is a fellow of Faculty of Dental Surgery, Royal College of Surgeons and Physicians of Glasgow, and a fellow of National Academy of Science of Sri Lanka and in Craniofacial Research Academy. He has more than 150 full papers, research publications in international and local peer-reviewed journals, 8 full papers in proceedings, and 25 abstract published in journals, more than 220 international and local research presentation to his credit. He was awarded multiple awards for his research and teaching, include President's Award for scientific publication in the year 2012 and 2015, and NRC Merit Award for 2016 and KSM Health Prize in 2020. He obtained more than 15 research grants as a principal investigator and was a co-investigator in more than 15 grants. He has written more than 10 books and contributed chapters in books. He has delivered 8 orations, 30 international guest lectures, 40 local guest lectures, contributed to 20 symposia, more than 250 times as a resource person in workshops. He is current director of operational technical secretary at University of Britannia, a head operation and former director of Center for Research in Oral Cancer. He served as secretary of a specialty board in oral pathology, Postgraduate Institute of Medicine in the University of Colombo from 2009 to 2018. He was board member of the Board of Study in Dental Surgery, Postgraduate Institute of Medicine 2011, 2012, and 2001, 2019. He was the former head of Department of Oral Medicine and Pediontology of the Faculty of Dental Sciences and Department of Radiography and Radiotherapy in the Faculty of Allied Health Science. He held many positions in professional associations, including President of College of Dentistry and Stomatology of Sri Lanka and President-elect of Sri Lankan Dental Association. He is current President of the Sri Lanka Society of Oral Medicine and Oral Pathology. He was co-editor of Sri Lanka Dental Journal 2015-2018, serving in multiple journals as an editorial board member reviewer. He is current treasurer of Candy Society of Medicine. He is also co-organizing president of International Oral Cancer Congress 2025. With this brief introduction, I request my backend team to play the video which is being shared by Dr. Ruwan from Sri Lanka, so that our the registrants, all the attendees of IOCCON 2025 can watch the video. And if they have any query, they have any question, they can write it to us on the same email ID which is mentioned in a brochure. Thank you. Mr. Rehan, could you play the video? Yeah, your slides are visible.
Good afternoon to all of you. Greeting from Sri Lanka. It is a great pleasure to talking to you on the topic diagnostic aids for oral cancer OPMD management. As we know, oral cancer is a major problem in this part of the world. South and Southeast Asia, the people are suffering from oral cancer. Oral cancer developed from the OPMDs. Correct diagnosis and timely treatment of oral potentially malignant disorders may help in prevent malignant transformation. Even though the oral cancers can be identified at early stage, at the OPMD stage, unfortunately, most of the people do not come to the clinic at that stage or even at the early cancer stage. Majority of the people come late. Lack of awareness about the signs and symptoms of OPMDs and oral cancer is responsible for the diagnostic delay. OPMDs will have a different malignant transformation potential. Erythroplakia is having a highest malignant transformation potential is around 90%, whereas the leukoplakia, it varies from around 1% to 40%. Oral submucous fibrosis, malignant transformation rate is around 5%. It is very important to identify the oral cancer at very early stage. So if we can diagnose the oral cancers at the stage 1, the 5-year survival rate is more than 90%. Whereas when we diagnose it at the stage 4, 5-year survival rate drops to around 20%. Overall prognosis of oral cancer is around 50%, and this value has not changed over the last few decades. Oral cancer is having a worse prognosis among all major cancers, and this poor prognosis may be due to a late detection, a lack of applicable markers for early detection. Number 2, the possibility of second primaries. And number 3, failure of advanced lesion to respond to chemotherapy. And in these photographs, you can see early oral cancers. We are very lucky if we can see them, and the patient will be very lucky because they will have a better outcome with a good quality of life with this type of treatment. Unfortunately, we hardly see them in our clinic. Most of the time, this is what we are going to see in our clinic. Even though oral cancer is present in a place where you can see them easily and where the dental surgeon can recognize them easily, majority of the people, they do not come to us at early stage and they come at a very late stage. There are different reasons for this. Number 1, there can be identification delay, where the patient who is having the lesion, they do not recognize that they are having a problem. And it is due to the lack of awareness regarding the signs and symptoms of the OPMD and oral cancer. And then when they identify that they have a problem, they don't rush to the hospital immediately or to a caregiver immediately. And in many situations, there is a delay, and that is the presentation delay, starting from the time that the patient has identified that the patient is having problem, presenting it to the clinic. Again, this is because of the lack of awareness regarding the signs and symptoms. And in addition to that, at times, the fear psychosis plays a crucial role there. And then patient comes into the clinic, but there can be a diagnostic delay. Not each and every case is straightforward. Identification with the clinical features alone may not be that easy. At times, there can be a delay in the diagnosis. And this will become worse when the medical officers or the dental surgeons who are looking at the patient, they do not have enough experience in identifying the OPMDs and oral cancer. Finally, there will be a management delay. We have identified it, but there will be a time until we complete the treatment. And most of the time, this management delay is associated with the system. Managing OPMD and oral cancer is having an effect on the patient's quality of life, structural, functional, psychological well-being. Not only that, it has a very high economical impact to the patient's family, as well as to society as a whole. If you recognize the lesions at early stage OPMD, the management cost is much less. Whereas when you recognize them at the oral cancer stage, especially when it is late, the management will take a lot of money and time. So therefore, the recognition of the oral cancer at early stage, at OPMD stage, will benefit not only the patient and the patient's immediate family, the society as a whole. Diagnosis of oral cancer and OPMD basically depends on the histopathology. The biopsy of representative tissue with histopathological assessment is the gold standard for differentiating different types of OPMDs and diagnosing the oral cancer. In OPMDs, identification of oral epithelial dysplasia is very important because the level of oral epithelial dysplasia gives us a clue regarding the potential malignant transformation. Some of the cases are not straightforward, and they cause great challenge in determining the accurate diagnosis. Field cancerization, larger lesions may not be easy to diagnose with a single biopsy, and we may need multiple biopsies, and not only that, biopsies at different time intervals in order to identify the lesion properly. Thickness and heavy keratinization of the lesion can cause the difficulties in the biopsy procedures, not allowing us to obtain a deep enough or a representative sample for histopathological investigation. Early detection of oral cancer and OPMD is important. In order to prove that, we need the surgical biopsy. And in many cases, we may need multiple biopsies at biopsies at different time intervals. And all these causes some disadvantages. Surgical biopsy cause fear and stress among the patients, and there can be pain and damage to the healthy tissues. There's a risk of infection being it a surgical procedure, and there can be some temporary disability and discomfort. And finally, there can be a cosmetic concerns, especially when the lesions are present in the anterior mouth. And not only that, even histopathologically, at times it causes difficulties. And these difficulties will depend on the location, size of the lesion, depth of the lesion, quality of the biopsy specimen that has been taken, techniques of fixation and freezing that is used to prepare the slides, and clinicians' background and experience in obtaining the biopsies. Clinical observer subjectivity and variability during the visual oral examination and histopathological examination give rise to some limitations of the OPMD detection and oral cancer diagnosis. Therefore, it is very important for us to have new, objective, non-invasive methods for diagnosis of oral cancer that can be performed by a primary care provider. At the present, most of the case diagnosis take place in the specialist level, and the specialists are overburdened with work, so therefore this has to be taken into the primary care providers level. To reduce the mortality, morbidity, and economic burden associated with the oral cancer, early diagnosis is very crucial. In order to do that, we have to have a better screening tools. Identification of these screening tools and identifying the lesions at early stage will minimize the strain on the referral centers, which are overburdened with work at present. It is critical in improving the healthcare efficiency, enhancing the quality care provided, and reducing the cost associated with the procedures. Early diagnosis of oral cancer by general practitioners or dentists, possibly in the primary care setting, is very important in minimizing all this. There are multiple methods of screening oral cancer OPMD. Conventional oral examination or conventional visual examination being the most important one. Even today, conventional oral examination stands high up in the list because it gives multiple dimensions and provide good results. In addition to that, there are commercially available diagnostic aids and adjunct techniques which are coming up in big way. Some of them are simple, whereas some of them are advanced. Vital staining, especially with the toluidine blue, oral cytology, light-based detection systems, mouth self-examination, remote clinical examination, including the telemedicine, and blood and saliva analysis are some of them. There are some major advantages of these techniques. They will result in reduced fear and stress, reduced pain and damage to healthy tissues, reduced risk of infection, shorter recovery times and quicker return to work. Very ill patients can also be investigated and treated because the invasive procedure is minimal, more cosmetically pleasing outcomes, as well as there is good cost effectiveness. As I mentioned earlier, clinical oral examination, conventional oral examination plays a crucial role. And it acts as the gold standard for detection of early epithelial changes. Criteria for suspicion of OPMD and oral cancer includes the changes in the surface texture, loss of surface integrity, changes in the color, size, and contour deviations, as well as mobility of intraoral and extraoral structures. And when we are using the conventional oral examination for screening purposes of OPMDs and oral cancer, It has a variable degree of sensitivity, which is around 0.7, and a consistently high value of specificity, and it's always greater than 0.9. Even though it's a simple and well-used technique, the research in the area is heterogeneous, and the research varies according to the study participants, application of the index test, reference standards, as well as flow and timing of the examination process. Vital staining is the second most commonly used technique, and this has been used in the clinical practice as well as in the primary care setting. Even though there are many types of stains, including acetic acid, methylene blue, lugosiodine, rose bengal, and iodine staining, toluidine blue is considered to be the most commonly used dye for this purpose. When there is a loss of heterozygosity in malignant or tissues with epithelial dysplasia, and those will retain the toluidine blue when it is applied into the oral cavity. Toluidine blue can be used both in vivo and in vitro. It is a very rapid, inexpensive, and a practical test to be used under any circumstance. According to the current evidence, toluidine blue is a good at detecting oral cancer, but its sensitivity in detecting dysplasia is significantly lower. It can give rise to high false positive stains, resulting the difficulties in its use at the primary care setting. Subjective interpretation of staining and criteria for positive results is the major limiting factor. In these photographs, you can see some cases that has been used with the toluidine blue, and you can see the positivity in those. And you can see our publication in this area, which shows the toluidine blue can be used effectively in screening oral cancer or PMD. When comes the optical light-based technological, there are different types of light-based technologies, chemoemulsions, and tissue fluorescence images. Autofluorescence-based technologies are in use for some time. So here, what we are going to do is to use a light wave with a very specific nanolength and to see its reflection from the tissues. In normal situations, if the patient is having normal mucosa, the tissue reflection will give rise to apple green color when you look at it under the fluorescent shield. If the patient is having a dysplastic lesion, it will appear as black in color. This has been used in the clinical practice for some time, but unfortunately, its results are not very encouraging. It can be used as a clinical adjunct, not as a diagnostic adjunct. So this study of ours demonstrates the same, where the well scope is not very helpful when it is used alone, but when you combine it with the clinical examination and toluidine blue, it's useful. Chemoemulsion-based technologies are much similar to the light-based detection systems, but here we need a chemical to be applied first, and the chemical changes will be visualized using a light wave with a specific nanolength. And if the patient is having a dysplastic area, that will appear white in appearance. Chemoemulsion-based technologies has been used in the practice for some time now. Narrowband imaging is a technique that has been used in the recent past. And there are different protocols that can be used in the oral cavity. It is considered as a promising, safe, well-tolerated, non-invasive, fast method, which can be used in the clinical practice. Unfortunately, it is rarely applied in general clinics or the primary healthcare setting, which correlates with the lack of training and promotion of the technology. Oral lesions which considered as intraepithelial capillary group type 2 or above, it is recommended to do a biopsy to exclude any malignant transformation potential. There are some limitations, which includes less accuracy in the presence of certain epithelial types like thick co-keratinized mucosa. There can be bleeding in the visual field during the procedure. Diffusing and severe chronic inflammation associated with oral lichen planus may reduce its value. Visualization of vascular pattern may also be confusing in oral ulcers. The next comes the cytology techniques. Again, this is in use for some time with a lot of improvements. Cytopathology is considered a secondary examination technique, and the cells can be collected from the mucosal surface or internal sites. And this is an adjunctive technique typically utilized for oral cancer or PMD, including brush biopsy, brush cytology, and liquid-based cytology. Oral brush cytology is a minimally invasive technique, and it is safe and generally painless. Collected samples are fixed, stained, and analyzed via a microscope by a cytopathologist. Now we have computer-assisted technology to do the reading, which gives a better results. Salivary diagnostic has come big in the recent past. Saliva, being a biological fluid, can be collected non-invasively. And the salivary detection is considered to be simple and low cost. Saliva will contain not only proteins, but also the salivary contains cells which may fall from a cancerous tissue in the oral cavity. And now there are a lot of studies targeting the identification of true biomarkers, identification of the malignant transformation potential of OPMDs, as well as the malignant transformation risk overall. Multiple studies has conducted, and the people are trying to identify the most suitable biomarker in all these. In oral squamous cell carcinoma, Camerin and MMP9 displayed the highest sensitivity. And these can be used as a valuable tool for early screening and detection of head and neck cancer and oral cancer. But we need more and more research to expand the panel of potential biomarkers in oral cancer. So this is one of our study which demonstrates the different types of biomarkers that we have identified and that can be used in the diagnosis of oral cancer. Are adjunct tools useful? Is there a significant difference between the detection of OPMD and oral cancer using the adjunct tools? This is a critical question to ask. Unfortunately, even though these adjunctive techniques are in use for quite a period of time, the literature is not straightforward. The literature is heterogeneous and unconclusive. Are they equally applicable in cases with clinical manifestations with epithelial dysplasia without clinical lesions, with and without risk habits? For each condition, like submucous fibrosis or a lichen planus, and specialist care versus primary care. So all these are different from one study to the other. So far, we don't have enough evidence in all of these areas. There are few studies separately identify these tools under different clinical settings. Sensitivity and the specificity of adjunctive tools are detecting oral cancer is significantly greater than dysplastic or potentially malignant disorders. So this is basically an evidence-based clinical practice guideline for the evaluation. And this comes from the American Dental Association. And you can see the American Dental Association has given the different guidelines for the use of these the adjunctive tools in the identification. Ideally, adjunctive tools is to reduce the uncertainty in the diagnostic decision, but in many situations, it is not the case. Currently, there is insufficient evidence to deviate from the conclusion from the American Dental Association. So therefore, we need more and more research to show the best diagnostic tool that we can use. And these adjunctive tools can be classified as utilized in primary, secondary, and tertiary settings. So here you can see what we can use under different situations. So if it is a primary setting, the facilities will be minimal, and in many situations, what we can use will be the conventional oral examination. And here, we can use simple technologies which will help the clinicians the best. And when it comes into the tertiary center, we can use the techniques which are little advanced and which is little costly. When it comes to the screening in general, lack of evidence for the use of adjunctive tools for the population screening for oral cancer or PMDs. So far, we don't have any proper evidence for this. Specialist and properly tested adjunctive tool is necessary to administer the adjunct tools effectively. So if you are going to use it, you have to select the best and you have to have some training in using this. Limited evidence for the use of light-based adjunctive tools and the toluidine blue in the detection of OPMD oral cancer screening and in primary care. So if you are going to use it with these technologies, it is not going to work. So even today, in the population level, conventional oral examination stand as the best method. On the other hand, a study conducted in Taiwan reported a 5% increase in detection of OPMDs using toluidine blue compared to a control group. So this 5% in a way is a significant number considering the less costs involved with the procedure. When it comes to the general practice, primary care setting, it is very important for the dental surgeons to carry out the opportunistic screening, whether it is with the help of diagnostic tool or only with the conventional oral examination. Each and every dental surgeon must be able to do opportunistic screening. Population screening is not cost effective and it will not be possible to do in one go. Because even though we may not see the cancerous changes today, in days to come, weeks to come, months to come, the people get it. So it is not one-time screening. And therefore, it is not practically possible for us to do it. So as dental surgeons, we have a duty and the responsibility to do the opportunistic screening, which will have a better effectiveness. There will be new technologies in the future. So today, artificial intelligence-based systems are coming to the arena. And with time, there will be enough artificial intelligence-based systems. And people are trying to develop a lab on a chip. So this is unique microelectromechanical system to take protein and RNA biomarkers. So it applies the microfluidic technologies. So it is basically a combination of dentistry and engineering. Finally, I would like to conclude my presentation by mentioning few points, important points. Even though the oral cancer and OPMD is a major problem and it requires screening, still our understanding in the area is limited. Current gold standard is a clinical visual examination and surgical biopsy with histological analysis in diagnosing OPMD and oral cancer. To date, No adjunctive tools can be utilized to replace a conventional oral examination for screening for oral cancer. So therefore, each and every dental surgeon must be very thorough with the clinical examination. And we need more evidence. So therefore, it is our duty and the responsibility to conduct more and more research in the area and develop enough evidence for us to have evidence-based guidelines for the future. Thank you.
Dr. Smoothie, Dr. Rasika is there in the meeting room and she has already shared her slide. So you can, give her introduction and then we'll start our session post lunch today, the fourth day of IOCCON 2025. Over to you, Dr. Smoothie.
Yes, sir.
Yeah, good afternoon, Dr. Rasika. Dr. Samriddhi, please introduce the speaker, Dr. Rasika, for the next session, and we'll proceed ahead with the presentations.
Yes, ma'am.
Yeah.
Dr. Rasika Ekanaika is a senior lecturer in oral pathology at the Faculty of Dental Sciences, University of Sri Jayawardenapura, Sri Lanka. She holds a Doctor of Medicine in Oral Pathology from the University of Colombo 2016 and a Bachelor of Dental Surgery from the University of Peradeniya, Sri Lanka. Her research focuses on oral submucous fibrosis, oral cancer, and histopathological prognostic markers with peer reviewed publications and book chapters. She received the NRC Merit Award for Scientific Publication 2016 and has been an invited speaker at international conferences. Over to you, ma'am.
Thank you, Dr. Smoothie, for the kind introduction. Hope you all can hear me.
Yes, ma'am. Yes, ma'am. We can hear you.
Yeah, I'm really sorry. There's something wrong with my video, so I'll be just sharing the screen and hope that's fine by you all.
Yes, ma'am. Your screen is visible.
Okay, thank you very much. Okay, so very good afternoon to you all. My topic for today is discussing the histopathological prognostic factors in oral squamous cell carcinoma, and I'll be mainly focusing on South and Southeast Asia. Okay, to give a brief introduction of squamous cell carcinomas, it's a 90%, it constitutes the 90% of all oral malignancies, and the global incidence accounts for around 377,000 as per 2020 records. The highest rates are seen in South and Southeast Asia. Actually, nearly 2/3 of new cases are from South and Southeast Asia. Despite the advancement in treatment and in findings, still 5-year overall survival rate remains less than 5%, less than 50%, especially in these advanced stages. It's a multifactorial disease, and the prognosis is influenced by various factors, multiple factors as demographics, clinical presentation, histopathology, and molecular profile. And identifying these prognostic factors is important for the accurate risk assessment as well as tailored treatment planning to deliver a better treatment for an individual. So here in my presentation today, I would talk about how these histopathological features evaluated in H&E staining, which is the most commonly and routinely used in diagnostic pathology, influence the prognosis of oral squamous cell carcinomas, and most of all the findings are from the literature published recently in South and Southeast Asia countries, related to those countries. Okay, prognostic factors related to histopathological prognostic factors related to oral squamous cell carcinomas can be broadly categorized into two. That those are related to the primary tumor. There are about 13 factors I have listed. For an example, tumor size, depth of invasion, and tumor thickness, and so on, so on and so forth. I'll be discussing them one by one in the presentation. And there are factors related to the metastatic lymph nodes, cervical lymph nodes mainly. There are about 4 factors which I would like to discuss in the coming presentation. Okay, tumor size, that is the most basic and the most obvious one. Clinically, it is the maximum surface diameter. Pathologically, it is the maximum cross-sectional diameter. So this yellow line indicated here is how we measure this tumor size histopathologically. That is the maximum cross-sectional diameter of the tumor. And it is a significant independent prognostic factor and predictor of reduced survival and independent predictor of reduced survival. One literature, if I were to quote one Suresh et al. 2019 by India, from India, they have finalized that tumor diameter less than 2 centimeters have a better disease-free survival and overall survival compared to patients with tumors more than 2 centimeters in diameter. So the next factor is depth of invasion. It is the invasion measured from the normal basement membrane, just a normal basement membrane to the most deep part of the invasion. So that this blue vertical line shows the depth of invasion of the tumor. It is from the normal basement membrane up to the most deep part of the tumor. So this is one of the determinants of T stage in cancer staging, and it was introduced in 2017 to this TNM cancer staging. So later on, I would discuss a more or less similar factor called tumor thickness. So both these two, depth of invasion and the tumor thickness, are distinct measurements, and they can't be interchangeably used. However, when we study the literature, you see these definitions are often used very inconsistently throughout the researchers. So the depth of invasion is significantly associated with shortened survival, and it is mostly considered a predictor for cervical lymph node metastasis. So independent predictor of occult metastasis as well, and it would guide the decisions in elective neck dissections. So one research says that early squamous cell carcinomas, that is T1 and T2 with clinically negative neck, if that tumor has a 5 millimeter or more than 5 millimeter depth of invasion, that is an indication for an elective neck dissection, even though it is a clinically negative neck. However, there are some researchers who would say that depth of invasion alone is not sufficient as a prognostic factor for early stage oral squamous cell carcinomas as well. So these controversies are mainly due to the sort of lack of consensus about the optimal cutoff value for depth of invasion when determining the need for elective neck dissection. So varying cutoff values have been suggested in various researches, ranging from 2 to 10 millimeters, and discrepancies have been suggested according to the oral cavity subsites as well. So it basically needs further research and further studies to identify what could be the optimal cutoff value that can decide and that we can determine on an elective neck dissection. Tumor thickness, as I have earlier told, it is also a vertical measurement on the tumor invasion. However, it is always measured from the surface of the tumor to the deepest invasive point. It is once again, tumor thickness is also considered a predictor for cervical lymph node metastasis. Here also, once again, 5 millimeter is considered as the cutoff value for cervical metastasis. However, when compared this depth of invasion and the tumor thickness, two vertical measurements of tumor depth, tumor invasion, depth of invasion is considered a more superior prognostic indicator since it is always measured from the normal basement membrane to the deep invasive point. As you can see in this diagram, it always nullifies the effect of exophytic and ulcerative tumors. If you consider this diagram, the first tumor is an exophytic lesion. Second one is a flat lesion, while the third one is an ulcerated lesion with the same depth of invasion. However, when we measure the tumor thickness, you can see if it is an exophytic lesion, tumor thickness is always exaggerated. In an ulcerated lesion, tumor thickness is always understated. So because of this particular reason, always tumor thickness is considered a less predictive one for nodal metastasis. And prognostic significance of tumor thickness is also questionable. And then if you move on to the next factor, degree of differentiation, it's basically the histopathological differentiation of the tumor. most of the oral squamous cell carcinomas, according to the research around in the SAC, South and Southeast Asia region, they are moderately differentiated. And predominance of well-differentiated tumors are also reported by the Sirivardhan et al. From Sri Lanka. And this diagram, to your left side, it shows a well-differentiated tumor. On the other hand, to the right side, that diagram is of a poorly differentiated squamous cell carcinoma. This poor histopathological differentiation is correlated with poor prognosis and increased cervical metastasis. And one researcher, Sanaketen from Sri Lanka, have identified statistically significant association between degree of differentiation and 5-year survival rate. And from early as 1920s, these histopathological grading systems, which are prognostically useful ones, which we can use to predict the prognosis of a patient, have been used from early as 1920s. If we name few, they are the most widely used ones were Broders, Jacobson, and Brine et al. Currently, Brine's grading system is the most widely used and considered the most effective predictive system in predicting prognosis. However, these grading systems, they are not based on just one feature. They are usually use several features, multiple features to predict the prognosis together, including this tumor differentiation, pattern of invasion, host response, number of mitoses, so on and so forth. So the pattern of invasion is another feature that can be assessed in the histopathological sections. Pattern of invasion is the tumor cell invasion at the tumor host interface, and it reflects the tumor behavior. There are several ways of grading the pattern of invasion as well. There are several systems have been put forward. However, whether the tumor has a cohesive pattern of invasion, as in this picture to your left side, or whether it has a non-cohesive pattern of invasion, as this other picture, is the factor that can mainly affect the prognosis. So it is an independent predictor for prognosis, and this Brine's grading system and Worst pattern of invasion have their own grading systems to grade the pattern of invasion. And this higher invasive front grading, that basically those are non-cohesive one, or else if it is according to the Brine's grading system, that is type 4, according to the Brine's grading system, they have higher incidence of nodal metastasis, and most of them are stage 4 oral cancers, and they have an overall poor survival and prognosis. So even though this pattern of invasion is typically integrated into other grading systems, it is considered that it is a better predictor of prognosis when applied independently, when we consider whether they are cohesive or non-cohesive cells at the advancing tract, can independently predict the prognosis of a given tumor. So lymphocytic host response is the other factor, another important factor. It is the density of lymphocytes at the tumor interface. It can be graded, it usually is graded basically into 3 patterns: strong, intermediate, and weak. And this usually go hand in hand with the next factor that I'm going to discuss, that is the tumor stroma. Usually when the lymphocytic host response is more, as if in this picture to your left-hand side, the tumor stroma is less or minimal. And when the lymphocytic host response is minimal, as if in this picture that I'm pointing at now, you can see tumor stroma is abundant. So this lymphocytic host response is always a factor that it's favorable for survival and valuable predictor for survival outcomes. And some research have identified this T cell subsite CD4+, CD8+, and FOXP3+, which can be used as favorable prognostic markers. However, they need to be validated on their efficacy as predictive biomarkers in clinical setting before we use it for the routine practices. It needs further studies in that case. So tumor-stroma ratio, which I've been discussing earlier, it is the proportion of tumor tissue relative to the surrounding stromal tissue at the invasive tumor's front. And these stromal cells of tumor microenvironment can influence the progression of oral squamous cell carcinomas. So as I have earlier told, so stroma-rich tumors have poor lymphocytic response. That means that immune response can impede the tumor stroma development. And these stromal cells have an potent promoting effect on the proliferation, invasion, and migration of squamous cell carcinoma. So that this is an unfavorable factor when it comes to the prognosis. And especially these tumors with fibrotic stroma, they are considered chemoresistant. That shows that exert and resistant towards the treatment as well. And 50% is the cutoff value to grade the tumors into stroma-poor tumors or stroma-rich tumors. These low stroma-rich tumors, which have the low tumor-stroma ratio, they have an aggressive behavior and worse survival outcomes as well. Okay, tumor budding is a recently that is sort of a new histopathological factor we have started to evaluate, not as the conventional histopathological prognostic factors. Tumor budding is defined as the presence of single cancer cells or small clusters, less than 5 cancer cells at the invasive front of the tumor. It suggests the dissociation of invasive cancer cells from the main tumor mass, and we usually get a score of tumor budding that is always counting the tumor buddings under the magnification of 20 in a single field. In the field where they have the most number of tumor budding after scanning it with the low power magnification. So cutoff values for this tumor budding is once again 5. If they have more than 5 or more than 5 tumor buddings score, it is considered a high-grade tumor, and it is vice versa for the less than 5 tumor budding score. It is an independent prognostic marker associated with poor survival. High-grade tumor budding, once again, is considered as with a high risk for lymph node metastasis. It is also correlated with occult lymph node metastasis in early stage or a squamous cell carcinomas as well. So as I have earlier told, this is sort of a more recently introduced histopathological prognostic factor. However, it is considered to have a superior prognostic value compared to these conventional factors as TNM staging, depth of invasion, and WHO tumor grade. However, findings are not consistent, and this controversy is due to the choice of cutoff point that can influence the prognostic assessment. There's one study which have used 10 bud cutoff as the cutoff point, where they have reported that tumor budding is not a prognostic marker. So there need for standardization of the evaluation methods and the cutoff points as well. Okay, excision margin is once again another factor we assess routinely in histopathological biopsies, and it is once again a important, significant prognostic factor. Accepted standard definition in histological assessment is the clear margin, which we consider is 5 mm or more from the invasive treatment cells. Close margin is less than 1 mm, more than 1 mm, but less than 5 mm. Involved or the positive margins are less than 1 mm away from the invasive tumor cells. This has a significant prognostic insights into the local recurrence and survival. And these excision margins is a very important fact that we mentioned in the histopathological reports, which guide the surgeon towards the further treatment. Clear excision margins has higher survival rates and reduced risk of local recurrence, while these incomplete resections have adverse prognostic implications. However, once again, due to this cutoff value of the, along with this cutoff value of the excision margins, there are controversies whether this is prognostically significant or not, because recently there had been a suggestion that it's not 5 millimeter, it is 7 millimeter that decides whether additional key radiotherapy is needed or not. However, we need further research in order to modify these existing cutoff definitions for optimal excision margins. And there's another issue with when consider these excision margins, especially in these oral cancers in the South and Southeast Asian regions, because most of our cancers, they occur in the background of oral submucous fibrosis, and these biopsy specimens, when we process these biopsy specimens, there are some differences in these tissue shrinkage percentages after the biopsies during the processing. This tissue shrinkage is different from the OSF biopsies to the non-OSF biopsies. So once again, there's a debate over whether that shrinkage differences to be considered when we decide on these cutoff definitions for the excision margins. Lymphovascular invasion is one of the very important facts that we look in a oral SCC biopsy. This is the presence of tumor cells within an endothelial cell line space of a vascular oral lymphatic vessel. And it is an independent negative prognostic factor. It has a clear, significant association with lymph node metastasis and recurrence, and also there's an impact on the overall survival as well. And once again, there are some limitations in diagnosing lymphovascular invasions in a histopathological biopsy. First of all, there's a lack of precise definition, and there's a difficulty in detecting lymphovascular invasions in the H&E stain sections. On the other hand, distinguishing the lymphatics from the blood vessels in H&E staining is sometimes it's next to impossible, especially when they are small venules or the small lymphatics. It's very difficult to identify whether they are a lymphatic or a blood vessel. The immunohistochemistry which can be used to this distinction, the CD31 and D240 also has limited effectiveness, and especially in our clinical setups, we have limited availability of this immunohistochemistry as well. So further research is necessary to address these challenges from our region. Okay, perineural invasion, once again, is a form of tumor spread as a lymphovascular invasion. It indicates the tropism of cancer cells toward the nerve bundles. So the definition given is that the presence of tumor cells in close proximity to a nerve surrounding at least 1/3 of its circumference or inside any of the 3 layers of the nerve sheath. That is the most widely used definition for the perineural invasion. However, once again, there's variation in the frequency, a wide range of variations there, 5% to 90%. That this is because lack of standardized definition. In research, they have used multiple definitions, and there's no consensus among the pathologists regarding the definition of the perineural invasion. However, the perineural invasion is an indicator of poor prognosis. That has a disease that has more risk of disease recurrence, higher probability of regional and distant metastasis, and a lower 5-year survival rate. However, once again, there are controversies, no wonder. Some say that it is intraneural invasion, but not the perineural invasion that is associated with poor survival. Some say that perineural invasion has no significant prognostic importance at all. So I think this variability factor is due to, as I already told, one reason is lack of consensus among pathologists in detection of invasion, and there's no precise definition, precise way to distinguish between the perineural and the intraneural invasion. And when it comes to the nerve sizes that are involved, there's a wide range of nerve sizes are involved in this perineural invasion. Due to all these reasons, there's sort of a debatable arguments regarding the prognostic significance of perineural invasion. Okay, bone invasion is another feature that can be assessed once again with a lot of equivocal findings and arguments. It is included in the 8th edition of IOCCON cancer staging manual. There they have categorized tumors invading through the cortical bone as T4 or stage 4 disease. However, even in this IOCCON cancer staging manual, there's no definition, there's no way how we have to distinguish between the cortical and the medullary invasion. So once again, there are so many research with various findings where we have very debatable arguments. Some says that the medullary bone invasion had a significant association with distant metastasis. However, there's no correlation with the local regional recurrence. And some says that it has no significant value as when considering the survival. And some says that the bone invasion is not an independent prognostic factor for small squamous cell carcinomas. However, there's a very valid finding, a research paper saying that the mandibular canal invasion in gingival squamous cell carcinomas is an independent predictor of reduced survival. So among these, all these discrepancies are mainly due to lack of differentiation between cortical and medullary invasion. And more studies, more research are needed to improve the definitions and criteria of these bone invasion. Okay. The last factor of the primary tumor is the human papilloma virus, which is HPV-16 is the predominant genotype, followed by HPV-18. And there are several ways of diagnosing HPV-positive squamous cell carcinomas under the light microscope. HPV DNA, HPV RNA, and this overexpression of P16 in tumor is the most widely used one. However, the gold standard we consider is the HPV-16E7 mRNA because it identifies the actively transcribed oncogenic HPV, because P16 would identify just mere presence of HPV, and not that this HPV has caused any change on the cellular biology. It can't be assessed with the P16. However, P16 is the most widely used one to identify HPV in a tissue section. It is a significant, well-known, well-established significant prognostic factor for oropharyngeal squamous cell carcinomas. However, it is not the case. It is not the same for the oral squamous cell carcinomas. The risk of HPV in carcinogenesis of oral squamous cell carcinomas remain uncertain. The prevalence of HPV in oral squamous cell carcinomas is low, and it is said that it may not be a predominant risk factor when it comes to the oral squamous, when it comes to the causation of oral squamous cell carcinomas. And this HPV positivity and the survival outcomes in oral squamous cell carcinomas are once again is a debatable topic. Some says that there's no impact of P16 or HPV status on survival. Some says that no, HPV positive tumors have a better survival. As once again, some says that HPV-16 positivity correlates with the lower recurrence. Some says that some research says that it can increase the risk of distant metastasis. The role of P16 as a prognostic marker for survival in oral squamous cell carcinomas, however, up to this point, it is equivocal. It needs a lot of more research for us to come to a final, definitive conclusions regarding HPV positivity and the risk and the prognostic values of oral squamous cell carcinomas. Okay, with that, I would like to move on to the cervical lymph node metastasis and the prognosis. It is one of the most important and possibly the most consistent prognostic indicator when it comes to the oral squamous cell carcinomas. It has an adverse impact on survival. It has usually a significant relationship with the 5-year and 3-year survival rates. And there are several factors that we can consider when a metastatic cervical lymph nodes are present. One is the total number of positive lymph nodes that can be predict to have an effect on survival, local recurrence, and the distant metastasis. This multiple metastatic lymph nodes is associated with poorer prognosis. However, this total number of positive lymph nodes lacks significance as an independent predictor of survival. Therefore, additional nodal parameters like lymph node yield, lymph node ratio are now being used for better prognostication. And occult metastases also play an important role. Usually 20 to 40% of initially clinically negative cases have been identified to have occult metastasis, and no doubt this has a significant effect on the survival rate, and there are several diagnostic methods that can be used to identify occult metastasis in a biopsy specimen. That the most basic one is H&E staining, which can be sort of empowered by the immunohistochemistry or the molecular analysis. The location of positive lymph nodes also has a role to play in the prognosis. Usually the level 1, 2, and 3 are the sentinel lymph nodes for oral cancer tumors. Whenever the tumor metastases go beyond these sentinel lymph node levels, it is an adverse prognostic factor. Also the presence of contralateral metastasis and metastasis to facial lymph nodes are adverse prognostic factors with lower survival rates. Okay, size of the largest metastasis is the third factor that has to be considered in a metastatic neck. It is the greatest dimension of the metastatic deposit in the cervical lymph node, and it correlates with the end stage of the TNM classification. So it is important for a squamous cell carcinoma staging. It has a significant impact on the survival rates. Most significant risk factor for cervical recurrence is this size of the largest metastatic nodes, especially if it is more than 2 centimeters. It is considered a higher risk of recurrence. The last one is the extracapsular spread. It is the extension of the metastatic deposits beyond the lymph node capsule and into the perinodal tissue. This gold standard for diagnosis is the histopathology. It is said to be present in 50% of neck dissection specimens and 60% of patients with positive neck nodes. It is introduced into this TNM staging of oral cancers in 2017. And so now it has an effect on the end staging of a tumor. And it has a decrease in 5 years of disease-free and the overall survival. And macroscopic extracapsular spread is considered to have a worse prognosis than the microscopic extracapsular spread with regard to the recurrence rates and the prognosis. And once again, there's some sort of a debate over this extracapsular spread and its effects due to the variations in the definition of extracapsular spread. So more studies, more research are needed for a standardized definition and a classification system for this extracapsular spread. So with that, I think I have come to the end of my presentation. Thank you for listening for this time. Thank you very much.
Thank you so much, ma'am, for your lecture. If anyone has any question, you may please ask. Ma'am, please share your email ID in the chat box. If anyone has any question later on, he will get back to you.
Okay, sure, I'll do that. Thank you.
Thank you, ma'am. We'll move to our next speaker. Our next speaker will be Dr. Isha Noshin. She is currently the director, Dr. Madhu Center for Laser Dentistry and Endodontics in Kochi, and she is a laser consultant at CIAM MAR Hospital, specialized in laser tongue-tight release, and an invited speaker at WorldCon International PBM conference. She is also a key opinion leader for Skill Development Council Canada. She is a specialist in providing various laser specialty treatments in management of radiation induced oral mucositis, chemotherapy induced mucositis, and management of oral mucosal lesions using triple LLT, PBM assisted periodontal disinfection, post surgical management, TMJ pain management, tongue tie or phenectomy release using diode lasers, laser assisted smoking cessation. She has pursued her BDS at Rajiv Gandhi University of Health Sciences and her MDS degree in University of Health Sciences, Kerala. She has various awards under her credit, like KUHS University rank holder in MDS, awarded the best scientific paper presentation at the IAOMR National PG Convention 2015, best scientific poster presentation award at 2016 IAOMR National Conference, lasers in aesthetic dentistry at Bangalore, lasers in dentistry IDA Kochi 2015. She has also attended various CD programs on TMJ, TMD, orofacial pain and management, Amrita School of Dentistry in Kochi 2016, and she has various publications in under her credit. Ma'am, please, over to you.
Thank you so much. That was a lovely introduction. Can I share my screen, please?
Yes, ma'am. But your screen is not visible.
Yeah, my camera is not working, right? And
Yes, ma'am.
I'm
Now
having
your slides are
it's
visible. You
visible.
may
Okay.
start.
Yeah, okay.
Okay,
So,
ma'am. Okay.
good afternoon, everyone. My name is Dr. Isha Nausheen. So, I've been practicing lasers from past almost 12 years now. But in terms of oral medicine radiology, my laser experience is limited to my clinic, where we do all our oral mucosal lesion management using lasers. Now, it's only recently that we have started managing oral mucositis with lasers. We are associated, our center is associated with Lakeshore Hospital, one of the top hospitals in Kochi, where we prevent as well as treat oral mucositis, which is induced because of radiation and chemotherapy. So now, my topic today is PBM, that is photobiomodulation, and PDT, that is your photodynamic therapy using dyes to enhance recovery due to radiation or chemotherapy-induced oral mucositis. So what is this PBM PDT? I'm sure all of you are aware of diode lasers coming up in a big way in terms of managing oral mucosal lesions. So this is basically the concept of photomedicine, the use of photons in medicine to image, that we all know, and to treat medical disease. It is basically photo, that is the light, bio, which is living cells, and modulation, we exert influence on, either reduce its action or increase its action. So the modulation. It describes the biochemical reactions that occur in cells in response to light. So what happens basically is when light is of any wavelength, here it says 670, 810, 904, but any of the wavelengths of this particular range, if any of these wavelengths come into delivered onto the tissue via a probe in contact or non-contact mode, what happens is the light enters the cell's mitochondria, absorbed by the chromophores. Chromophores are different types. I will talk about it in short in some time. But mainly it acts on cytochrome C oxidase, which then increases its activity. So we all know the importance of cytochrome C oxidase, right? It basically controls our ATP production, it controls our reactive oxygen species and nitrous oxide. So a cell to perform in its optimum way, all these have to be in control. And laser therapy, depending on our diode laser of a particular wavelength, manages all this in its particular dose. So the dose is very important. Okay. So as soon as you put the light, you expose each cells onto this particular wavelength, there is increase of production of ATP, which basically repairs the cell. If there is any pathology, it repairs the cell. Then there's production of reactive oxygen species and nitrosols. So the chromophores that I was talking about, mainly it is cytochrome C oxidase, and this also the wavelength of light depends on where you are exposing it. If it is on hemoglobin, the action is different, or the absorption is different. Myoglobin, melanin, all these, the action of light on these chromophores is different. Okay, but the bottom line, it repairs cells. In a very, very layman word, I'm saying it repairs cells, it acts on the mitochondria. Okay, that is what our pathology is. Our pathology also is at the cellular level. So the depth of penetration, as I was mentioning, depends on the wavelength. Tissue penetration is peak at 810 nanometer. Here we are going into a little bit of physics. Okay, so laser machine comes in different wavelengths. Depending on your requirement, you need to select which wavelength you need to expose the tissue to. This is another class altogether. I'm just going to talk about the uses of these lasers in our oral mucosa. The application of photobiomodulation are immense. Right from the top of our head to the bottom of our feet, every part of the body can be treated using PBM. Okay. Apart from this, photodynamic therapy. It is nothing but a photochemical way of treating a microorganic induced diseases, or maybe even inflammatory. So you have a photosensitizer and you have an associated light with it. In the presence of oxygen, it gives you a photochemical reaction. Okay. So that is called photodynamic therapy because it is very dynamic in its action. So the photosensitizer can be toluidine blue, it can be indomethacin green, it can be now curcumin, even a turmeric. That is also a photosensitizer. And to activate these, I'm sure you all have heard of this, where you put toluidine blue or methylene blue, in fact, methylene blue onto the tissue. And the reaction is what we see in one of the small diagnoses of oral cancers, right? So it's the same concept where the deceased cell absorbs these dyes a little more than a normal tissue. And when you expose a particular wavelength of light, for example, for toluidine blue or methylene blue, you need 660 nanometer light. For indomethacin green, you need 810 nanometer. When these cells, once it absorbs the dye and you expose it to these particular wavelength of light, it causes microbial cell destruction. And that is targeted cell therapy using PBT. This is what happens. The normal cells do not get affected with this dye and with this light. The normal cells remain the same, whereas the deceased cells are destroyed because of the light therapy. Okay, so the applications of PBM PDT are numerous when it comes to oral medicine. Okay, every mucosal lesion which are symptomatic can be managed. I'm not saying you can treat the entire lesion. The management of symptoms is very, very extremely studied and very well accepted with PBM. Even the recent mucormycosis can also be managed with PDT. So when it comes to radiation mucositis, the radiation mucositis, as you all know, is extremely debilitating to a patient. A patient is already undergoing enough and more with cancer therapy. Added complication is our radiation mucositis. Not only just oral cancer, any head and neck cancer, as you all know, this is one of the major complications. You can prevent or at least reduce the severity with which the patient is going to suffer the radiation mucositis with PBM. Okay, when it comes to grade 2 and grade 3 and grade 4, where there is breach in the mucosal layer and there is microbial invasion, that can be managed with our photochemical PDT, photodynamic therapy with dye. But otherwise, grade 1, grade 2, where it is more of painful ulcers and erythema, all these can be beautifully managed with PBM. There are a lot of articles. The studies are immensely popular right now. It started in 2012, maybe even before that, but the most accepted article was in 2012, where the conclusion was that the results of LLT, in those days, PBM was called LLLT, low level laser therapy. It has very encouraging results in the prevention and treatment of radiation mucositis, and it is proposed as a new standard of care. Okay, there are numerous articles. Please go through these articles. The photobiomodulation therapy in the treatment of oral mucositis, not just treatment, even prevention. You do this one session of photobiomodulation just before radiation, you have excellent results in terms of the severity with which the patient comes back to you. So the preventive therapy is just the dose. Don't worry about it. Okay. So the WALT recommendation, that is our World Association of Laser Therapy, WALT recommendation, it very specifically says that prevention of oral mucositis is the key for treatment. Say you have not done a session before radiation therapy, it is fine. But within a day of radiation therapy, if you expose the patient to diode laser, especially 660, with its least penetration, only the surface gets exposed, it gives you very good results. The patient suffering really comes down. Now, the patient has suffered. Grade 1, grade 2 has been crossed. The patient has got a breach of oral mucosa because of radiation. Then PBM alone is not enough. It is not enough to reduce the pain only. You need to treat the microbial attack as well. For that, you need to do photodynamic therapy. Again, there are numerous articles, recent articles for photodynamic therapy, where they say that the antimicrobial photodynamic therapy for the treatment of oral mucositis has given very, very promising results. See, the bottom line of all this, diode lasers, especially 660 laser, the penetration is extremely low. It just crosses the oral mucosa. It doesn't go penetrate into the deep, into the bones, and there are no side effects. There are absolutely, either you get good results where the patient has pain relief, patient has got an antimicrobial result because of photodynamic therapy, or the patient will have no pain, no effect at all. The patient will be back to normal, whatever you do. So there is no side effect. There is no pharmaceutical treatment over here. You're not giving any kind of, what do you call it, systemic chemicals into the body. That itself is a huge advantage of this particular management. Then there is also a new article which has come up with a novel approach for head and neck cancer treatment. Okay, where this photodynamic therapy, the dye goes and attaches itself to the cancer cells, and you can kill the cancer cells with light. This is again an old concept which we have all been hearing about, but this using diode lasers, it is a lot more narrowed down to the particular cell. Okay, same concept as photodynamic therapy. The tumor cells, you attach the photosensitizing agent and you expose the light to it. So the effect of photobiomodulation on inflammatory activity. Basically, radiation therapy induced mucositis is nothing but inflammation. So the effect of photobiomodulation on inflammatory activity can prevent and control severe oral mucositis. And its mechanism of action is much better. It is much better than whatever the surface ointments that we give, be it anti-inflammatory, because the penetration is good. Penetration is on the surface itself. There is no systemic absorption of any kind of medicine in this. That is the key to PBM. Now, when it comes down to cost effectiveness, you might wonder, I'm sure all of you have gone through this particular episode where because of radiation mucositis, the severe radiation mucositis, the patient cannot undergo radiotherapy. The sessions of radiotherapy are either cancelled or reduced or postponed. That affects the management of the actual oral cancer, right? So with PBM, you can manage oral mucositis in such a way that the radiotherapy sessions are not interrupted in any way. Okay, so the faster the treatment, the more cost effective it is, both for the patient as well as the hospital where they undergo. The patient getting admitted to the hospital or getting demanding the treatment apart from radiotherapy because of its complications, those reduce a lot. So the cost effectiveness is huge. PBMT, that is your photobiomodulation therapy, is or more cost effective than your preventive therapy in case of severe oral mucositis. So it is a promising therapy, especially to avoid interruption. Our main aim of radiotherapy, chemotherapy is to treat our cancer cells, right? So there should not be any interruptions when you have an option of this kind, which is not an expensive option. It is a well accepted and very promising mode of treatment for oral mucositis. So in conclusion, what I want to say is oral cancer, or for that matter, head and neck cancer management or treatment is very, very painful when it comes to oral mucositis or radiation mucositis. Please keep an eye open, keep your heart open, keep your mind open to lasers in managing of oral mucositis, because pain is inevitable, but suffering is optional. We can give the option to a patient where suffering can be reduced. Thank you so much.
Thank you so much, Dr. Isha, for such an insightful lecture on the use of lasers in pain management and other things which you have told and discussed. If anybody has any questions, they can ask, ma'am.
Hello, madam. There is one question. I
Yes,
just
sure.
wanted to know the laser application should be done pre-operatively or post-operatively, and
Both.
what type of a laser should be used for the lesion.
Okay. So pre-operatively, definitely before. Now you know that the patient is going to undergo radiotherapy. So it's always better to do one session just before the radiation. Okay. Now, if you'll ask me what is the dosage, what kind of laser, all that is a completely different class altogether. So
Yeah,
depending on the condition, depending on the existing condition of the mucosa, the general 80% of the cases, we use something called 660 nanometer laser, which is a red light. It is a
Okay.
red light therapy. We must have heard of red light therapy. So you use
Yes.
red light therapy. We are basically in a very simple way, we are empowering the cells to accept this radiation without creating a lot of damage to the tissue. Okay, so you do a session before the radiation, a session after. And then depending on the patient's reaction, depending on the dosage of the radiation therapy that you're giving, all those, depending on the reaction of the oral mucosa, you can increase your sessions or decrease your sessions. But definitely one session before radiation therapy is the rule. It has to be done.
Okay. And in between, do you suggest in between
Yeah,
also?
definitely in between. What we generally do is once the patient starts radiation therapy, it's like every time he comes for a session, we do PBM before and we do PBM after. So
Acha,
he
every
doesn't have
time.
to come. Yeah, every time. So the patient doesn't have to come back for PBM, because already the patient is undergoing so much of the practicalities of coming to a hospital or getting admitted and all. So they generally, they are, for them, oral mucositis is something which they're like, it's okay, doctor, we'll manage, we'll suffer, no problem. So it is our duty to just do it for them. They will see the results. They will see the results within a few days, where they are able to accept all kinds of food. They are able to maintain their nutrition. That itself is a huge help.
Yes, yes.
Yeah.
Okay.
Thank you. Thank you so much, ma'am.
Thank you.
Yeah, that was very elaborative. Thank you. And have a great day and great evening.
Thank you so much.
Yeah.
Our next speaker is Dr. Manjula Attigale, who is joining from Sri Lanka. He would be joining in a short while. I just spoken to him. He'll taking just time. Just wait for 5 minutes, 10 minutes.
Okay. Okay, sir. Okay. So we take a short break of 5 minutes. In that time, if somebody wants to discuss anything, they can put the questions in the chat box so that we can address it maybe at the end or maybe now itself.
Uh, If we want to do some collaborative research with the foreign speakers and foreign researchers, can we do it?
Sir, it depends whether they want to do it with us or not. What kind of research it is, we'll have to send proposals to them.
Yeah, because some of the new modalities right now being discussed, probably less
Yeah.
studied on the Indian scenario background. And if at all we do those things in Indian background also, some authentic conclusion can be taken out for the oral cancer and some that will be useful to the society.
Yeah, right, sir. I mean, that we can discuss with them through the email, basically, and then if they're
Yeah.
interested, they can get back to you.
Yeah, collaborative research like they can carry out, we can carry out at our centers and compare the results, and then
Yes,
we
sir.
can come out with some authentic conclusions. It's like
Yes, sir.
that.
Then that can be done here.
Mhm.
By the time our new speakers joins, I'll let you know the sessions which is left today. They are very prominent speakers who are joining. One is from joining from Sri Lanka. One is joining from USA late evening at 7 o'clock. And we have two, three young speakers who are by the background of dental surgeons, but they are working in medical field. They are in medical palliation and also first Dr. Very senior academician, Professor Manjula Atigale. He is also our uh, in our team actually, in a consultant team, and he will be talking on management of advanced oral squamous cell carcinoma of the oral cavity, about experience in the oral and maxillofacial department, Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. So he would be talking for half an hour. Then Dr. Vibhu Ranjan Shah, he will be talking about functional rehabilitation of head and neck cancer patient. That how we should rehabilitation, because after treatment there are a lot of damage is done, and so we have to rehabilitate the patient and all. Then there are a lot of psychological and many thing related to the cancer and all. So Dr. Abhishek Kandwal, Professor Abhishek Kandwal will join, and he will talk on recent advances in palliative care in oral cancer. Afterward, a very senior speaker, Dr. Himanshu Aryan, he would be joining, and he will be talking about maxillofacial prosthodontics rehabilitation of post-surgical orofacial defects. And at the end, because we kept all the US speakers. First, Dr. Davis. Second, day, Dr. Sonal. She has spoken late evening. Very nice presentation, and she has spoken about the diagnostic adjuncts and a very nice presentation with good images and all. And she has spoken about the diagnostic adjuncts and veloscope, which is being used for screening the patient for oral cancer and pre-malignant lesions. So on the same way, Dr. Snehal Patel, he would be joining at 7 o'clock, and he will be taking half an hour, and he will talk about novel technology of early diagnosis of oral cancer. And he is a head and neck surgeon based in USA. So this is all about the sessions which is left for today. And then after that, we will having a brief vote of thanks. So with this note, I'm just checking whether Dr. Manjula Atigala has joined the meeting room or not. Just wait of all. I have requested him to come a bit early, and he agreed because we have already played two speakers presentation. There are other speakers who are also not able to join due to some connectivity issue and all. This is the first time we are facing this problem. We have this fourth edition, and recording of all those edition are in the our NHA YouTube library. Anybody want to listen those lectures and those sessions which is happening in 2022, 23, 24, and we are also recording these sessions. You would be able to watch this later on. So we never get these issues, and we are not keeping any lunch break, tea break, snack break actually, because we have many speakers who want to join this prestigious program, but we are shortlisting them and we are giving them a variation in terms of country, in terms of a specialty topic, in terms of spread in different institution and all. So as an organizer, we have to keep balance in selecting the speakers and all. But sometimes due to technology and due to say technological glitch and all, we are not able to get all the speakers on board actually. So this is why we are facing such a problem. We hope the rest of the session we don't have such problem, because I have already spoken to all the speakers. We are speaking speakers a day before, the same day. We have a WhatsApp conversation, but somehow due to technical issues, they are not able to join. So I'm just, tendering my apology if our registrants, our attendees are facing any problem, because their times is also very precious, and they are, they are keeping their time to watch the program, and they are also busy in their life. Sunday is more crucial for their personal thing and all, but still they spare the time and they join our program. So we are really apologetic to all those who are here. Bear with us. This is due to technical issues, and we will be right back. I'm just waiting for Dr. Manjula. I think Dr. Manjula has joined with his iPad. So, Dr. Smoothie, could you please greet him, and we can give a brief introduction. We can start the presentation.
Yes, sir. Dr. Ajit Manjula Attigale, Professor of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. He has a special interest in oral cancer and head and neck reconstruction. He also has pursued his overseas training at Mount Vernon Hospital, UK. He has short-term fellowship at OMF Department, University of Hospital Bern, Switzerland. Sir, please, over to you.
You take time, Dr.
Very
Manjula.
much for your kind introduction. Can you hear me?
Yeah,
Yes, sir.
you are
Yes,
audible,
sir.
sir.
Yes, sir. You audible?
Yeah. Thank you very much. I would like to thank the organizers for giving me this opportunity. And how can I share my presentation?
Yes, sir. Please share your screen.
With the MacBook, with iPad, we are facing issues from day one actually. So we have made you co-host, Dr. Manjula. You can easily share your slide. Yeah, it's coming.
Can you see the screen now?
Yeah, it's visible. Yeah, your
Hello.
slides are visible.
Yes, sir. Yes, sir. It is visible. Yes, sir. It is visible.
Right. Thank you very much. So actually, I'm giving an overview of our experience in the Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. I'll give a brief introduction to, most of you already are aware about Sri Lanka, which is a very small country compared to India, with a population of about 22 million and with good literacy and life expectancy of about 77 years. And this is our institution. I would like to invite any of you who are interested to collaborate with our university of Peradeniya, which is one of the oldest universities in Sri Lanka. To communicate with us. So we are very much dental faculty. Actually, this for a long period, this was the only faculty in Sri Lanka producing dental surgeons until about 2-3 years ago that we have another dental faculty. And in 1998, we had the chance of having collaboration with the Japanese government, JICA, to have a very nice facility donated to us, which gave a lot of input for this improvement of oral cancer management in Sri Lanka. So we have a very good facility with about 50-bedded ward, 2 operating theaters dedicated for this ICU, and an outpatient clinic. From the teaching activities of the university. I'm happy to say that we have conducted, and some of the neighboring countries were benefited with that. So in this particular presentation, I would like to increase incidence of cancer in Sri Lanka and the important management, reconstruction, adjuvant therapy, and rehabilitation, as still the prognosis is a problem of oral cancer. And I'm sure that these kind of institutions could contribute more with collaborations and advancement of the science in the future. In males, it is the highest with an increase over the year to about 2,700 cases in the year 2019, and with a female-to-female ratio of 4:1. And we have not achieved much over the years to improve the prognosis, although all the new knowledge has been brought in. But still, as you can see in the second graph, there is not much of improvement in prognosis, and age-specific incidence also gradually rising in both sexes, although the female ranks about 8th in the country. There are about 2 to 3 deaths every day in this regard. And one action of staging from stage 3 to 4, that is 73% has become over a period of 8-9 years to 63% with this regard. This data is a bit old, but I think it's a rough picture of together. We counting about 41.8, although we are getting 4 advanced lesions, more than nearly 50% or more still, with all the awareness programs and other aspects that we have conducted. And if you look at the site-specific prognosis, there is a drastic difference. I'm sure that in India and our region, the most prevalent site is buccal mucosa compared to Europe. but still there is much more better prognosis with the buccal mucosal cancers compared to the tongue with our number of patients. These are some of the advanced lesions that we have encountered over the past few years. Of course, palliation, and there's no resection. And as you can see, many of these are in young patients, especially the tongue cancer you see is a single mother, mother of one child, affecting with the whole tongue. And it was a diagnostic dilemma as well, because many biopsies proven it as negative for cancer, but finally only it was evident that it was cancer. Other common problem with this region is oral submucous fibrosis. This causes a lot of problems for us because there is limitation of opening of the mouth, and examination is a problem. And once you operate also with the radiotherapy, there is severe restriction of mouth opening. However, we try to improve that aspect. So it is a challenge. And unfortunately, the younger people who are getting affected with this condition is becoming more and more as the smoking habits are getting reduced, and people are, the same gutka and all those other prepared ingredients are being distributed around the schools, etc. So the younger population is getting these conditions, and it could be a problem in the future. And one other aspect is this clinically malignant exophytic lesions. I'm sure that this may be prevalent in India as well as the next. It may be due to the issues with the submucous fibrosis, and these many of these lesions look very alarming. But when you do biopsies, those are not frank cancer. But at some stage, all of a sudden, they turn into cancer. So what we are doing now is to excise the whole lesion without going for neck dissection, etc., because we don't have histologically proven this evidence to do so. And sometimes the excision biopsy might reveal some parts having CA. And a lot of efforts have been gone into the management of oral cancer in Sri Lanka with the official bodies like the Ministry of Health and the National Cancer Control Program, as well as the National Authority for Tobacco and Alcohol Control, NATA. With all that efforts in a multidisciplinary way, we were able to have some guidelines, although late, regarding management of OPMD as well as oral cancer. Of course, there are certain gaps, especially due to the lack of data sometimes. So those aspects are being improved in the system. So I hope that in the future, this will be more effective and reliable in the management of both these diseases. When you look at now, as I am mainly discussing about advanced lesions, as we get more and more advanced lesions after all these years, it is interesting to see how we can improve the prognosis as well as the quality of life of these patients. One fundamental thing is the complete resection of these lesions, and which is called actually the RO resection, R0 resection. And when you analyze this data, although little old, we can see when there is involved margins, the 5-year, as well as the clear margins give a definite advantage when you have clear margins. So it is very important for for a surgeon to plan in a multidisciplinary way for the complete resection. There are certain other evidence for local recurrence, 3 years, as well as the local recurrence, regional or distal metastasis, 5 year internationally, which clearly shows the advantage of clear margins in these patients. On the other hand, still, this is not local data, but it shows that alarmingly high level of margin positivity, at least in one margin, especially the deep margin in many of these literature. So it is necessary to study these aspects and in these units to understand and improve the clear, complete resection. Same, this is specific survival. Now, what are the strategies we try to implement to have, first of all, clear margins? Now, I would like to say that we are a resource-limited center where many patients are of poor socioeconomic status and they cannot afford imaging in the private sector. Being Sri Lanka is a free health service also attracts a huge number of patients to the government sector, and all these complicates the limited resources available when we want to assess it properly. So definitely it's obvious and it's very well documented that CECT will help in assess the local spread, the neck involvement, regional spread, as well as the some of the aspects of distal mets like the brain and the lungs, etc. But we have to wait for about 2 to 3 weeks or more to get a CECT done. Sometimes it gets more delayed. And as you may be aware, the recent turmoils in the country have led to more issues as well. So MRI, the availability of MRI is not that great in the government sector, and MRI is more expensive compared to CT. And also there are patient fears as well coming into this. So although sometimes it is very, very necessary, like to assess the perineural and the mandibular medullary involvement, etc., sometimes it is difficult for us to get MRI. So definitely we rely highly on clinical examination and then simple investigations such as the ultrasound scan, and then we go for CECT. And definitely in cases like involving the retromolar trigone, tongue, etc., that we try and somehow get these investigations when we stage the disease. If they can afford that, we send them to the outside private sector and get the staging done, the imaging done. It is well documented in guidelines that the importance of these and the applications of these, like the marrow signal with mandibular invasion when it comes to MRI. And one has to be aware of the limitations like dental artifacts in CT when we consider and use these investigations. So it is important for us to individually assess these patients and to see the applicability of these to get the most out of these investigations. So we try to utilize the same principles that is being practiced elsewhere to get complete clearance. Here, the compartmental resection, and also taking consideration of the nearby anatomy in planning resection. For example, in here, as shown in this article, it is important for us to know whether it is crossing the midline and involvement of hyoid, etc., whether it's in the anterior part of the tongue or the posterior part. And depending on that, we have to include parts like the lingual aspect of mandible or anterior lingual aspect of mandible, etc., into the resection to make it a clear resection, complete resection. Similarly, it is well documented that compartmental resection in relation to TIFO B lesions, especially chemotherapy has given much light into improving the outcome of these situations, where I will touch in later slides. So image-based anatomical surgical planning is heavily used in our practice, and there are limitations, as I explained. But we use these to help having a complete resection. And in that cross-sectional imaging, when it may be important for us to sit with the radiologist, consultant radiologist, to see the particular aspects. And simple techniques like puff cheek technique, etc., was not practiced in Sri Lanka some time back. But with these workshops, etc., these are being practiced widely, and we get more relevant information in the report to be applied in using planning resection. And also the surgeon has to be much more aware of the spatial structures in planning the resection. And one particular challenge is the deep tumor margin, where this imaging comes handy. Although frozen sections are not being considered for tumor clearance guidance, but recent literature suggests that not the surgical base related frozen sections, but the specimen driven frozen sections marked in an appropriate way and discussed with the pathologist by the surgeon then and there, although it takes little more time for the surgery, may be of value. And we are trying to, now we are applying that to a certain degree, and yet to see the results of these, outcome of these. One big improvement being discussed in many of the oral cancer forums as well as the oral cancer is the chemotherapy and advances in neoadjuvant chemotherapy. Whether it will improve when there is functional irresectability, such as the total glossectomy, and preserving the mandible and having improved prognosis. So it has been widely proven in the literature that there are potential benefits of neoadjuvant chemotherapy. And I'm sure that a lot of few discussions, presentations were there, very nice, very informative presentations were there. And in our experience also, we are experiencing that now, that there is much benefit in advanced tumors having the benefit of neoadjuvant chemotherapy. We are yet to analyze and publish, so I can't give you 100% scientifically accurate data, but in our experience, we have definitely seen good results with improvement in prognosis when we downstage the tumors with the neoadjuvant chemotherapy. So we can do a more functional resection in these patients when we subject them for neoadjuvant chemotherapy. And facilitation of organ preservation, as I mentioned, about the mandibular preservation to a certain degree, as well as preservation of important structures such as the orbit is evident with neoadjuvant chemotherapy. So early treatment of micrometastasis, when especially the neck is involved, extranodal spread, there is benefit of neoadjuvant chemotherapy, and that is one of the aspects. Improved response-based stratification, that is, when we start this, if it's not responding, there's room for the oncologist to change the protocol, the treatment protocols, and go into a more a different protocol, an aggressive protocol to manage those lesions. And with the reduction of the tumor bulk, there is chance of enhanced radiotherapy efficacy following neoadjuvant chemotherapy. So we are using this widely in our setup when we encounter patients with these problems and in many of the advanced lesions. Although there are definite problems of chemotherapy, the benefit ratio may be higher. So we use these in borderline resectable cases where T4A tumors, as well as especially in T4B tumors now, where it is below the jugular foramen region. It has been shown that it becomes amenable for surgery. And extensive nodal disease, as I mentioned, N2, N3, and unresectable T4B tumors, patient-specific considerations, especially in young patients with high tumor burden, and aiming for functional preservation of structures. Now, this is one of the cases we have done many years ago, and you can obviously see although the patient is doing well in relation to cancer, but the cosmetic and the functional issues are much evident. So now we have the expertise due to the contribution by the Japanese JICA. We were able to develop oral cancer microvascular expertise. So we are in a position to improve and have better cosmetic and functional outcomes in these patients. For example, now this is one of the patients whose tumor in relation to the floor of the mouth has spread into the mandible, both sides, and into the anterior tongue, and bilateral neck dissection, and this is the excised specimen. And we could use the fibula in this situation. And you can see the osteotomizing of the fibula while the flap is still attached to the leg there, and then fitting and reconstructing the defect. We have a small lab. I know that compared to India, it's because it's in these regions, it's very much advanced, the CAD/CAM technique, etc. But now we are having our own setup, which we are able to get the CAD/CAM models at least. So when there is affordable patients, of course, then we send them to either maybe India or Singapore and get the customized patient-specific plates even done. But nowadays, we are getting more and more input and companies to set up these facilities in Sri Lanka, and possibly in about 2 to 3 years, we might be having in our country where the titanium printing and milling is possible. Similarly, this is another case that very recently we did. And in this patient, in one side, as I mentioned, that clinically exophytic malignant lesion, like very aggressive kind of lesions, but several biopsies didn't reveal cancer. But on the right side, actually, but left side, it was frank cancer invading into the mandible, although it's at the initial stage in relation to the mandible. So he ended up with excision of bilateral cheeks, marginal mandibulectomy on the left side, and excision of about nearly 2/3 of the lip. In such a case, of course, without the advanced reconstructive techniques, it is difficult to cover. And although it is not an aesthetically much pleasing initially, that it is possible for us to refashion and correct it. This is on the left side is a ALT flap measuring nearly up to about 12 into 18 centimeters, and on the left side is a thick major flap. These are one or two cases which got benefited with microvascular surgery, fibula, and this young patient had a anterior mandibular CA and reasonable outcome in relation to function and aesthetics. And I have to say that although we do the fibular resection and repair, some of these patients are not in a position to afford for implants, and the government also not in a position to support for that. So still the implant placement is not regularly happening. We are going for secondary surgeries and sometimes dentures, but few patients have undergone implant and dental rehabilitation as well. This patient presented with anterior lower lip CA, and this is a reconstruction with the radial forearm with palmaris longus tendon, which helps to improve the function, and this patient can blow a balloon even. So this is, although not cosmetically 100%, functionally, these have improved the quality of life of these patients. This is a radial forearm free flap reconstruction of the tongue. Although we have gone through all this, but still there are patients coming like this, maybe recurrences sometimes, some are primary cases. This patient is a young father, and he definitely it's going to be palliative or terminal care patient, but as they wanted have their last days at home peacefully, that we just did a palliative surgery and gave them few days of decent life. So broadly, I think I have enlightened you what's happening in in Sri Lanka. This is one of the, we have several centers in managing oral cancer, and Peradeniya University Dental Faculty is one of the main centers. There are other few centers in Galle, Colombo, Anuradhapura, etc., Badulla, spread across the country. But there is, as I mentioned, you may have understood the limitations we have, and it is important for us to have proper records, have research to give the maximum for these patients. So in a summary, I would like to mentioned that advanced oral cancer requires a structured multidisciplinary approach, and oncologic resection, reconstruction, and adjuvant therapy must be well integrated. Rehabilitation is crucial for long-term functional outcomes, and collaboration between high-volume centers locally and regionally will definitely help in these aspects. So thank you very much.
Thanks, Dr. Manjula. My moderating team, are you there? Anybody who can take the moderation of question? If anybody from audience want to ask any question, they can ask question right away. We have a privilege that very senior academician, very senior faculty from Sri Lanka, very prominent oral and maxillofacial surgeon with us. So if you have any doubt related to anything, you can ask right away to Dr. Manjula. Anybody want to ask question, they can put in the chat box as well. So, Dr. Manjula, we are not getting any question right away, but stay with us. Maybe if there is any question arises in the chat box, they will, people are hesitant in sometimes asking questions. So maybe they would be, typing the question over there. So you can, if you have a time, you can stay with us another, say 15, 20 minutes, and you can ask the answer in the chat box if there is any question.
Sure. Thank you. Thank you.
So with your permission, we are moving to our next presenter, and we have to check whether he is available or not. So Dr. Manjula, thanks for you to joining, and I'm just moving to our next speaker. Thank you.
Most welcome.
Yeah. Dr. Vibhu Ranjan Sahani is joining. He's trying to connect, but he's facing issue. So he said that he is changing the device and he would be joining in another 2 to 3 minutes. Just wait for a while. By the time Dr. Vibhu Ranjan Sani joins, let me give his brief introduction, and then as soon as he joins, he will start his presentation. Dr. Vibhu Ranjan Sani, he is a consultant head and neck surgical oncology and oncopalliation. He is currently working at Rajiv Gandhi Cancer Institute and Research Center, Niti Bagh, New Delhi. Her recent achievements in surgical experience. Just hold on. I think he joined. Let me make him a co-host. So I'm just telling about Dr. Vibhu Ranjan Sani. His recent achievement is surgical experience from more than 1,000 cases of head and neck cancer surgery. Specialized in head and neck oncopalliation, trained in communication skills including end of life discussion in terminally ill patient, expertise in speech and swallowing therapy for patients with head and neck cancer. Recently completed CCEPC from AIMS, Indian Institute of Medical Sciences, New Delhi. Has numerous scholarly publication in addition to book chapters. Received certificate from appreciation for work in the field of head and neck oncopalliation from Healthy Ho, and organizing member of PADs 2023 and Hospelocon 2023. So we are just waiting for Dr. Vibhu. I think if he joins, we'll immediately start his presentation. Dr. Manjula, could you stop sharing your slide, because I think your slides are coming. Yeah, thanks, Dr. Manjula.
Hello.
Yeah, Dr. Vibhu, I have already given your, by the time you are joining, I have your brief introduction.
Fine.
So,
Thank you.
so
Thank you so much.
yes, but there might be chances that I have missed any prominent point. So to understand our audience well, you can give your brief introduction, and then we can start your presentation.
Fine.
Yeah.
Can I share the screen, right?
Yes. Your screen is visible, Dr. Vibhu.
Thank you, Dr. Nurul. I am Dr. Vibhu Ranjan. Good evening, all. First of all, I am Dr. Vibhu Ranjan Sahni, consultant head neck surgical oncology in Rajiv Gandhi Cancer Hospital, Niti Bagh. Today, my topic of discussion is functional rehabilitation in head neck cancer patients. So we all know head neck cancers. It is a cancer of oral cavity, laryngeal cancer, hypopharyngeal cancers, salivary gland tumors, and sinus tumors, and there may be a skull-based cancer and cervical esophageal cancers. So there are many problems which will be related with the cancer. Because of the disease itself, there are so many problems like pain is there. There will be a dysphagia, deformities, facial deformities there, some fungating mass is there. And because of the treatment per se also, there are, because of the surgery, it leads to medical debility, damage to the central or peripheral nervous system sometimes, and there may be a deficit in the swallowing and other musculoskeletal disorders. With radiotherapy also, there is will be a damage to any
Dr.
ligament,
Vigu
there will
Ranjan,
be a
your slides are
fibrosis.
not visible. It was visible, but now it disappears. Could you please share it again? So not visible to us actually.
Okay.
Screen is blank.
Fine. This is fine.
Yeah, no, it's visible.
Okay. So I can use this only.
You are on the third slide actually. Cancer related problems, disease, pain.
Yeah.
Okay, continue.
This is visible or not?
This is visible.
Yeah,
This
previous
is
is
visible,
done.
but it's not in slide sharing mode, presentation mode. When you are putting the presentation mode, it disappears actually. So I think it's having device issue. You can present without in a presentation mode. Yeah, you can present
Okay,
as
fine.
visible and
As it is. Okay,
as
right.
it is readable as well.
Sure. So cancer-related problems can be because of the surgery, radiotherapy, and the chemotherapy. Surgery, as I already discussed, it leads to the medical debility or damage to the central or sometimes the peripheral nervous system. It may deficit because of the surgery. There will be a swallowing issue and other musculoskeletal disorders because new construction thing will not be as the natural thing is there. There will be a sensate issues and other motor issues with the flaps and all. Due to the radiotherapy itself, there may be a damage to the bone, ligaments, tendons, muscles, or lymphatic vessels. The damage may be acute or it may develop or progress many years after treatment also. Because of the chemotherapy, there are multiple issues of nausea, vomiting, fatigue, malaise, myalgia, neutropenia, anemia, neurotoxicity, and also sometimes the mucositis is there, and that is also a major cause for the dysphagia most of the time. So before starting the function rehabilitation, we need to understand what is rehabilitation. Rehabilitation basically refers to a process aimed at enabling persons with disabilities to achieve and maintain their optimal physical, sensory, intellectual, and psychiatric or social functional level, thus providing them with a tool to adapt their lives toward a higher level of independence. This is a definition given by the WHO. So what are the basic goals for any rehabilitation? It is, the first one is to improve the possible functional outcome, to achieve the best possible functional outcome, or to improve the quality of life of the patient, and also to identify and carry out whichever intervention we are going to do, whether it's a surgery, chemotherapy, or radiotherapy. We need to understand which is the most effective treatment for the individual or the patient in the optimal time. As you already know, that the thing is we need to complete the all the treatment right from the surgery till chemotherapy. The completion of the treatment will be in 70 to 100 days for the best possible outcome for the cancer treatment itself. So we need to identify which one is the better for the patient. And also for the rehabilitation, we need to understand not only the patient need, but also the caregiver's need is very important while providing rehabilitation to any patient. So there are 4 areas of cancer rehabilitation. First is preventive rehabilitation therapy. It is to maintain a healthy lifestyle. Then there is a restorative rehabilitation therapy, which is expected to return to the patient to the normal lifestyle. Then there will be a supportive thing, which is basically to enhance the independent functioning of the patient so that he will not be dependent on the others, and which most of the cancer patient actually wants. Then there is a palliative rehabilitative therapy in which we have to provide the comfort to the patient. So for a rehabilitation team, it's not a single man job. It's a multidisciplinary approach. So a cancer rehabilitation team consists of oncologists, physician, rehabilitation nurses, physical therapist, occupational therapist, prosthodontist, orthotist, nutritionist, speech therapist, swallowing therapist, psychologist, vocational counselors, social workers, and many more. So what are the most common problems which a head and neck cancer patient actually faces is mostly the dysphagia. Whatever your treatment you are given to the patient came to you after the curative intent of treatment. He is disease free. He came with the complaint. He is not able to swallow or eat anything स्पेसिफिकली इन द पब्लिक. मेरे पास आते हैं, कंप्लेंट ये करते हैं कि सर मैं जाता हूं पार्टी में, मैं खाना नहीं खाता. दिस इज द मोस्ट कॉमन प्रॉब्लम अ हेड नेक कैंसर पेशेंट यूज्ड टू. There are multiple other problems also. There is a dysphonia, pain may be there, fatigue. Because of the injury or neck dissection we are doing, spinal accessory nerve paresis will be there, palsy there will be there, cervical contracture because of the radiation thing, trismus because of the disease or because of the treatment per se. Temporomandibular joint dysfunction is also there. Sometimes the chemotherapy induced neuropathy is there, and some because of the neck dissections or radical chemotherapy or radiation therapy, the lymphedema also can occur in these patients. So I'm elaborating something which is very close to my heart, the topic of dysphagia. So to understand what is dysphagia, it is a basically a term come from the Greek word dys and phasia, means a difficulty to eat. It arises when the transport of the liquid or the bolus of the food along the pharyngoesophageal conduit is impaired by either the mechanical obstruction or because of the neuromuscular failure that disrupt the peristalsis. To better understand the dysphagia, we need to understand the normal swallowing process, which is also called as a deglutition. It is an act of swallowing through which a food or liquid bolus is transported from the mouth through the pharynx and the esophagus till into the stomach. So what are the phases of swallowing? There are 3 phases. First is the oral phase, which includes the oral preparatory phase. The oral preparatory phase is basically when the bolus is formed. Whenever you take the any meal, whether it's a liquid, whether it's a semi-solid, whether it's a solid food, then there is a oral propulsion is there. So with this diagram, I want to explain this oral phase. This is the bolus. Whenever the oral preparatory phase is there, if a teeth is there, then there is a closure of lip closure, lip seal is there, the teeth are closed and the bolus is formed. And then this tongue is elevated and touches the palate. So during this phase, this bolus is transported back into the pharynx. In cases of tongue cancer, the bulk of the tongue is reduced. So the bolus, the oral transit time, the transit time of intaking the food till the food is get into the pharyngeal portion is the oral transit time. It's hampered because of the bulk of the disease, or after the resection, or even if we do a flap surgery also, we most commonly use radioforum free flap. The oral transit time sometimes is reduced, and patient is not able to properly swallow the food into the pharynx. Propulsion is hampered. So there are, in this oral phase, there will be a drooling is there, oral retention is there. Patient is not able to chew or inadequately chew the food. There will be a stranded phlegm, or there may be a pocketing, a squirreling, or food sticking into the, because of the disease, because of the resection ablative procedure, because of the reconstruction also. Whatever better reconstruction do, these are sometimes the problem which happen with most of the cancer patient. Then there is a pharyngeal phase. Pharyngeal phase, as it is written, there will be a nasopharyngeal closure. Again, so this is a nasopharynx, this is a oropharynx, this is a laryngopharynx. So the food is transit from the oral phase to pharyngeal phase. In this phase, in a normal scenario, this soft palate is going upward and block the nasal cavity, nasopharynx. In case of the soft palate cancer, or in case of this shortening of this uvula, there will be a vilopharyngeal incompetence. The bolus is regurgitated into the nasal cavity, or nasal regurgitation is there. Then there is the pharyngeal sphincter is, then there is this epiglottis is fall back. It give a protective mechanism to the larynx inlet. Also, the vocal cords are adducted, and it closes the larynx, so that there will be no aspiration, risk of aspiration is there. This tongue movement is going back. The base of tongue is pushing the bolus behind in this phase, and any surgery or any reconstruction or any disease in this area can hamper that, and the pharyngeal transit time will be increased comparatively. After the bolus came here, then both the superior constrictor muscles contract and propels the bolus through this upper esophageal sphincter into the esophagus. This is the esophageal phase. So why the in the esophageal phase, there is a closure of the upper esophageal sphincter, and the bolus is propels towards the esophagus from this side. And then there is the help of the peristaltic movement. But in case there is a tumor in this area, cervical esophagus, the propulsion will hamper, and the bolus will come out and directly can go in the laryngeal inlet also, and it may arise to give rise to aspiration pneumonia, cough reflex is there. So I already discussed the common symptoms of oral phase. So symptoms of pharyngeal disorders, there may be a foamy phlegm, nasal regurgitation, as I already discussed, coughing because the aspiration or arytenoid reflex is there, the coughing is there while eating or drinking. The coughing may be because before the swallow or after the swallow. There will be a wet, hoarse, breathy voice, weak cough, inappropriate breathing, maybe swallowing incoordination is there. If any of these complex will be deficit, so the incoordination there will be irritation, leads to pneumonia also. And sometimes the food, will be a feeling for the patient, the food is sticking inside the pharynx. In the esophageal phase, there may be a food sticking, pain, regurgitation, hiccups will be there, and sometimes because of the tumor in the esophagus, cervical esophagus, there will be a difficulty in swallowing the solids also. So any patient which came to you in the OPD, you need to assess. Pre-treatment assessment of swelling is must. Whenever the patient came to you, just give him or her a glass of water, 100 ml of water, and see whether he or she will be able to swallow that properly. There will be a cough reflex is there or not. This is the basic swallowing evaluation you can do in an OPD basis also. So in any head neck cancer patient, there will be these abnormality will be there. There will be a increased oral or pharyngeal transit time. The oral and pharyngeal residue might be there. Pharyngeal opening will be there. Oropharyngeal swelling efficiency is reduced in most of the cases, especially in a cancer. In the oropharyngeal cancers, laryngeal cancers, these as it is written here, the pre-treatment risk stratification is increase in the increased tumor size. Hypopharyngeal tumors have a greater risk of aspiration than the laryngeal tumors, than the oropharyngeal tumors. But the problem is high proportion of patient will detect the difference in their swelling and eating, but the dysphasic complaint do not correlate with the actual dysfunction. Patient is not able to explain you the problem he is facing. And sometimes the patient underestimate the degree of swelling dysfunction. Sometimes patient came, sir cough तो होता है but manageable है. So then it's a red flag for you, because that patient in any point of time when he is not in a good coordination because of his weakness or fatigue is not able to provide that reflex, and he will land up in an ICU with the aspiration pneumonitis. So you better not ignore these kind of symptoms. The conundrum is oncological treatment sometimes aggravate pre-existing or introduce a new deficit which may complicate safe or efficient oral intake. Acute toxicities may impact desire and ability to tolerate oral intake, because sometimes the mucositis is there, patient is not able to swallow, and you will not able to assess whether he is having a swelling issue or because of the mucositis is not able to ingest. So the solution is we need to assess swallowing prior to the treatment. Early identification of any dysfunction, you can implement you can uphand पेशेंट को आप सिखा सकते हैं swelling therapy, dietary modifications, and it's a basic good opportunity for you also to provide education to the patient or caregiver that this can happen later on. You have to be prepared for this, and these are the therapies you might require afterwards, so that you can have a normal or have a good quality of life in case of this. Sometimes the findings may impact your oncological treatment decisions. Like nowadays, robotic surgeries are very common in oropharyngeal cancers. But if a patient is aspirated, showing the signs of aspiration and while having the food, so you have to modify your treatment. You might go with the conventional chemo-RT therapy, radiation, concurrent chemo-RT radiation therapy for these oropharyngeal cancers rather than going into the robotic thing. Let me explain with this diagram. the oropharyngeal cancer is there. With the robotic surgery, we need to excise this portion. As you see, this is a pharyngeal closure by the epiglottis. Retroflexion of epiglottis is there to prevent the larynx. But while doing a robotic surgery, for better survival rate, we resect this portion. So whenever you take the food or something, liquid or semi-solid, this will cause a free fall of any food into the larynx and it may severely hamper your result. जो लाइफ आप देना चाहते थे पेशेंट को, उससे आपने उसको हो सकता है कि एक प्रॉब्लम और क्रिएट कर दी है जिससे उसको एस्पिरेशन न्यूमोनाइटिस रहेगा. To prevent that, you do a tracheostomy and patient will not be able to decannulate. And it's a very challenging thing. I have seen some cases. I tried to give swelling maneuver to them. They started having the swelling maneuvers, but whenever the compliance issue is there, because this structure is not there, there will be a risk of aspiration many folds in these kind of patients. So your treatment modality, as it is written, it will impact the oncological treatment decisions. So there are many assessment tools, clinical examination or bedside examination. As I told you, a simple glass of water, you can assess them. Modified barium swallow, it's a gold standard. But nowadays the fiber optic and hello.
Yeah, your slides disappear, sir. Could you please
I'm doing
share it again?
Now it's visible. Hello.
Yeah, it's visible now. Assessment tools. 25th slide. Yeah.
Yes. So the assessment tools, as I said, clinical examination is the best thing you can do on an OPD basis or bedside. Then there will be a modified barium swallow. Then the fiber optic endoscopic evaluation of swelling, which is most commonly used these days for the assessment of swelling and the penetration thing. Fiber optic endoscopic evaluation of swelling is with sensory testing is a modification of fees. In this, the jet of air is given is pressure in the laryngeal inlet to see the reflex, cuff reflex is there or the reflex of the laryngeal inlet is adequately present or not. This transnasal esophagoscopy is a minimally invasive esophagoscopy procedure which can be done in a daycare basis to evaluate any cervical esophageal obstruction is there. The manometry is because of the muscles involved in the swallowing, it to measure the effectivity of the muscles which is effective as previously. The scintigraphy is to evaluate the amount of aspiration which occurs, which is not identified with this modified barium swallow and the fees. Electromyography is sometimes used nowadays. Ultrasonography is also some used, but we generally use fiber optic endoscopic evaluation of fees. So radiological evaluation during the video fluoroscopy, we need to see the oral phase, whether the lip closure is there, the tongue movement is proper, soft palate elevation is there, jaw movement is there. oral pocketing is there or not. Then there is a pharyngeal phase. We need to evaluate the whether is a swallowing delay or swallowing absence is there, peristalsis is present or not, laryngeal function. We need to assess in that whether the larynx is elevated, if there is a penetration in the laryngeal vestibule or not, aspiration there or not, cuff is present or not, it's delayed or it's effective to cuff out the aspirated thing, or the vocal cord is basically functional or not. And we also need to examine the sometimes the aspiration is going into the lungs. We need to do a chest x-ray to evaluate whether there's any residue in the tracheobronchial tree or lungs. So rationale for fees examination is basically sometimes the silent aspiration is there or the silent dysfunction larynx is there, which is commonly found in the head neck cancer patient, especially when the chemoradiation therapy is given. The sensation of that arytenoid reflex is lost. Sometimes the vocal cord is not mobile, so there is a phonatory gap is there. So, and also sometimes the visualization of tumor impact, to see the visualization of tumor impact on swelling function. And also sometimes we have to evaluate the deficit and their impact on safety and efficiency. And it's also provide you the opportunity to give what kind of diet modification the patient needs. Sometimes the patient aspirated with the liquid diet, but is able to swallow semi-solid or solid diet. So we need to modify that accordingly. So pre-treatment is must, as I said, to evaluate the firstly the velopharyngeal closure is there, whether the pooling of secretion is there or not, to observe the anatomy and basic judgment about the symmetry abnormality is there, vocal cord fold mobility is there, glottic adequate is there, is present or during the phonation, and also need to assess the dry swallow and cough, and also to evaluate the pharyngeal and clearance is there or risk of aspiration is there. So this is a basic view which normally fiber optic endoscopy we done, which is seen in this thing. Whenever the aspirated, whenever we do a fees, then there is a, we need to assess the this is the colored portion. It shows that this green one shows that no aspiration is there. If this is basically a laryngeal inlet, if the any food particle came in this area, then there will be a penetration issues. If the food particle came in this red area, then there will be a aspiration issue. So after doing this and we assess this, sometimes we have to go inside the larynx to identify whether the aspiration is food is there or not. So there are multiple scales for penetration aspiration scale. So FEAS is basically more reliable in assessing the penetration than the video fluoroscopy. And video fluoroscopy is more as reliable in detecting the severity and depth. So both the technique go in hand in hand. So we need to, if the armamentarium is there, then we need to assess both the thing for better outcome of for the patient. The most commonly identified swelling abnormality is basically the decreased tongue base retraction, decreased laryngeal elevation, decreased epiglottic inversion, decreased pharyngeal wall motion, and the aspiration. So in that case, we need to put a rise tube, or better to go for a PEG tube, as we can train the patient with the swallowing maneuvers with the PEG tube better than the rise tube. But with the Ryle's tube and the PEG tube, it is seen that the muscles of deglutition is going to atrophied with if the patient is on PEG tube or Ryle's tube for more than 2 weeks. So better to start a swelling maneuver as early as possible to train that muscle, and so that the muscle will not got atrophied. So the compensatory treatment modalities can be compensatory strategies, postural changes, diet modification, directly treatment, indirect treatment, most importantly, education of the patient, family, and staff. Swelling maneuvers can be checked down and tuck, which was indicated in pharyngeal swallow delay and laryngeal dysfunction. Rationale is it widens the valvula and narrows the airway and pushes the epiglottis posteriorly. Then there is a chin up head back indication. It reduces the anterior posterior bolus transit. Rationale is it uses the gravity to move the bolus. Then there is a head rotation, a turn. Then there will be a head tilt, lying down, and the lying down sometimes is done in a reduced pharyngeal contraction or reduced laryngeal elevation. It basically keeps the residue on pharyngeal. So most commonly used is supraglottic swallow. In this, you have to hold your breath before the swelling. Then after the swelling, you have to cup immediately so that any bolus or any food particle which is going inside can be cuffed out. It is indicated in reduced vocal fold closures and delayed pharyngeal swallows. Rationale will be it closes the vocal fold during and before and during the swallow. Supraglottic swallow is basically you have to cough down twice in this. Efforts food swallow. In this, you have to squeeze your throat muscles and swallow as if you have a piece of food stuck in your throat. It basically indicated in reduced tongue-based retraction, especially in a T3 tongue, which is not adequately rehabilitated with the flaps. So basically, it increases the tongue-based retraction. Then there will be a Mendelssohn maneuver, which you have to press this apple so that it maneuver and elevate the larynx and open the esophagus, which is indicated in reduced laryngeal elevation or uncoordinated swallows, which may cause the delay in the cricopharyngeal relaxation. So basically, it causes the upper esophageal sphincter to open up, and the opening is prolonged, and the patient will be able to swallow better. Masako maneuver is stick your tongue out, bite down gently, and swallow, and then release your tongue. This maneuver strengthens the base of tongue. Shaker maneuver is basically lying on your back, lifting your head, look up towards your toes, and aiming to strengthen the muscles that help in the opening up of the upper esophageal sphincter. It is usually seen no swallowing maneuver is properly used in every patient because sometimes the resection is so much that despite the flaps and all, you have to modify all, or you have to incorporate sometimes all the maneuvers to teach the patient to so that he will be able to swallow. So you need to understand the normal anatomy, and better you have to taught them according to the normal anatomical portion which is remained in the patient. Then only he will be able to understand better. And most importantly, the compliance is a very important in this understanding the swelling maneuver. Next is pain. Pain can be treated with the analgesic step, WHO's analgesic step ladder approach. I'm just quickly, because of the time, I'm just quickly going through. Otherwise, then my presentation will be not completed. Then next most important thing is voice rehabilitation. There may be a disordered speech, like if there is a cancer of the lip, tongue, or alveolus is involved, and or hard palate is involved, then the patient has a disordered speech. He will not able to articulate better because of the limited tongue movement, or if the palate is not there, he's not able to say some words. And then there are also a disordered resonance. In case of soft palate cancers, there may be a velopharyngeal insufficiency, or sometimes the tumor, because of the tumor, sometimes the nerves is resected. A hypoglossal nerve damage is not and resected in the with the tumor, then it causes the disorder. Like in the larynx, you have to completely remove the voice box. So voice disorders can be a challenge in head neck cancer patients. Deficit following surgical treatment for, as I already, oral cavity depend on the mobility of the resultant more than its volume. Despite the reconstructed flap or adynamic, but the flap remained adynamic, is not able to give you the better result. If there is a disease in the oral pharynx, then there is an alteration in resonance is there, and the degree of difficulty is related to the amount of tissue resected, and pliability is and flexibility of both remaining and reconstructed area. Like I said, involvement of nasal result in a velopharyngeal insufficiency and voice perceived as a hypergel voice. In larynx and hypopharynx cancer, if the surgery is done, laryngectomy is done, then the complete dysphonia occur. So technological aids for voice recovery, especially in the laryngectomies, my patient. In the normal oral cavity or oropharyngeal cancer, a speech therapist will able to teach them how we can communicate. The patient can communicate with anyone. But in a laryngectomized patient, it's a different thing. There are three types of voice rehabilitation. First is the artificial larynx or electrolarynx. Electrolarynx is a device which is put here, and with the help of the masticatory muscles, and the patient is able to talk. But the voice is like a robotic voice. Then there is a esophageal speech which uses the burping effect of the esophagus to convert the burp into the speech. Then there is a prosthetic speech. There is a transesophageal prosthesis. In this is the laryngeal inlet. Basically, we have to inhale the air, close the larynx, and that the valve their mechanism is there to produce the speech. Spinal accessory nerve, because of the neck dissections, there will be a painful shoulders, or the trapezius muscle paralysis resulted in rotated scapula and loss of range of shoulders. Symptoms can be trapezius atrophy, shoulder girdle depression, limited active shoulder abduction to less than 90 degree, shoulder pain or weakness is there. Nerve rehabilitation, prevention of frozen shoulder through active range of motion, active assisted or active assisted range of motion. Prevention of anterior chest wall flexibility deficit through trunk mobility exercises, strengthening of alternate scapular elevators and retractor. Neuromuscular retraining of shoulder girdle can be done. Preservation of trapezius muscles with the electrical stimulation. If reinnervation is there, you know the spinal accessory nerve is not transected during the surgery. And sometimes you have to provide the shoulder support to allow recovery of the levator scapulae. Or in case of complete palsy, you need to use this orthosis for the shoulder stability. Cervical contracture, as I said, in the cases of radiation, then because of the radiation, the edema is there, then which is followed by the fibrosis, scarring, and atrophy. Rehabilitation can be done with a proactive range of motion. Patient should include stretching during the end stage, bending and rotation by exerting additional pressure, isometric strengthening exercises of the neck, and manual fibrous release can be done. Christmas, because of the scarring, so because of the surgery, because of the disease, it can occur. TMD can be occur again because of the scarring or atrophy of the muscle or intra-articular damage due to the radiotherapy and surgery. Symptoms: difficulty in mouth opening, sometimes the headache, radiation headache can be there, vague tooth soreness, which may lead to a neuralgic type of pain. There may be a pain or fatigue. Sometimes clicking or popping sound is there, and the cervical neck tension and pain is there. About 50% of patient has a limited mouth opening, and patient with the oropharyngeal cancers has a significant high risk of trismus because the muscle of the mastication is more involved in that cases. Again, the rehabilitation can be done with the physical therapies, diet modification, moist heat can be applied to relax the muscles, joint neck stretches, exercises. There are multiple devices we can use: Therabyte, TMG exercisers, Easy Flex, Aura Stretch. These are the devices for trismus rehabilitation. Sometimes the jaw is locked. Then there is a manual repositioning of the jaw is done. Then sometimes the patient is self-mobilized the jaw. Lymphedema is another issue because of the surgery, radiation, and chemotherapy. There will be a disrupted lymphatic structure is there. Soft tissue damage lead to scar tissue, which form formation fibrosis, further affect the lymph function. Symptoms can be dull pain, facial disfigurement in extreme cases. Sometimes the lip and eyelid is also swollen, which impair the vision and eating. Conservative management of lymphedema, it is basically a two-stage program. First is the first phase, in which you have to do a skin care, manual lymphatic drainage as per the water technique, the remedial exercises. Then you have to do a compression bandage. Special mention is avoid the heat or cold over the affected area, as because of the radiation or the surgery, the sensation is hampered. Phase 2 is started immediately after the phase 1. Again, compression by low stretch elastic bandages can be done, skin care or exercises, or repeatedly manual drainage of the lymphatic channel can be done. Again, the compliance is a very essential for a conservative therapy. Sometimes a procedural stellate ganglion block, nerve block is sometimes given for the lymphedema also, but the result will be very to patient, and the compliance is very much important. So you need to provide a psychological support and to the patient to provide a good quality of life. These chemotherapy-induced neuropathy, sometimes some chemotherapy agent develop peripheral neuropathies, while some patient deficit will resolve quickly, but sometimes the neuropathy is not corrected. So you have to do exercises to restore the function and also to enhance the balance, strength, and safety to support the weak muscles. Fatigue, it is the most common symptoms. There will be a reduced energy level, mental capacities is reduced, functional status is hampered, and psychological resilience of the patient sometimes hampered. Most commonly, the fatigue is caused by the anemia, especially in the cancer patient. So mild to moderate exercises can be done to boost the quality of life or to improve the muscle thing. But the important thing is avoid too much rest or over exercise so that it may further not cause any fatigue to the patient. So finally, for any rehabilitation, especially in a head and neck cancer patient, we need to set a realistic expectation to establish achievable goals, develop a personalized rehabilitation plan for every patient, understand the recovery. You need to understand or make them understand that the recovery is a gradual process and which can help reduce the frustration and keep motivation high. And you have to enjoy the small achievements. You have to celebrate small victories, and better you encourage the patient to maintain a positive attitude. Thank you.
Thanks, Dr. Vibhu, for sparing your time and joining us and give your comprehensive. You have covered almost all the topics.
Thank you.
Yeah. So, from audience, anybody who want to ask any question, they can ask the question right away. We have spoken on, rehabilitation and palliation. He's a palliation expert, actually. So anybody want to ask any question, they can ask right away, or they can type in a chat box and they can ask question. So Dr. Vivu, they might be asking question. There are some hesitation, so they would be asking question at chat box. So as we move on the next speaker, and they would be writing on a chat box, so you can stay here for a while, and question arises, then you can answer on the question. Nice presentation covering all the aspects actually for rehabilitation. So it's a very comprehensive, and you have summarized all the aspects. So it is very important for all the dentists who are handling with the advanced cases, and also they have a better understanding. Though they are not managing those, but they have the idea that how it is being managed and all. Okay. Thanks. With your permission, Dr. Vivu, we are
Sure, sir.
Next
Sure.
presentation. So I would like to introduce Dr. Irfanul Haq. He is associate professor in Department of Orthodontics in Hazaribagh Dental College, Jharkhand, India. And he would be moderating now onwards. Over to you, Dr. Irfan. Are you there in the meeting room? Yes, Dr. Irfanul Haq, I have already introduced you to panel and all audience. We are waiting for you to take the presentation from here.
Thank you so much, Dr. Nurul.
You are visible, yeah.
Yeah, thank you so much for letting me in. And it was nice presentation. I was going through it, the previous presentation. But unfortunately, when you introduced me, I was offline because of some connection issues. Anyways, thank you so much, Dr. Nurul. So our next speaker is Professor Dr. Abhishek Kandwal. Is it so, Dr. Nurul?
Yes, of course. He is the next presenter, yeah.
Yeah. So let me introduce our next speaker, Dr. Abhishek Kandwal. Sir is a professor and head, Department of Dental Surgery at Himalayan Institute of Medical Sciences, Cancer Research Institute, Swami Rama Himalayan University, Uttarakhand. He has done PhD in Oncological Sciences and gold medalist in Master of Dental Surgery in Periodontology and Oral Implantology. He has fellowship from National Cancer Center, Tokyo, Japan, with specific focus on head and neck cancer patients, supportive oral care, and rehabilitation. He is co-investigator in ICMR-led project for strengthening palliative care services in cancer in North India. It's a still ongoing research project which was started in 2022, I think. He has certification in Essential of Palliative Care by Indian Association of Palliative Care. Apart from that, he is the core panel member in development of revised international guidelines on oral care and mucositis management in cancer patients in Multinational Association of Supportive Care in Cancer. He is specialized in supportive care, oral care, and oral dental rehabilitation in cancer patients with specific interest in head and neck cancer patients for the past 11 years. He is actively involved in research in oral toxicities of cancer therapies and part of various research groups for mucositis under international collaboration of the Multinational Association of Supportive Care in Cancer. He is he has multiple, rather numerous publication in national and international journals on tools of supportive care, supportive oral cancer care and oral toxicology management in Index Journal. So let's welcome our next speaker, Dr. Abhishek Kandwal. Sir, please, it's all yours. So please share your screen and start your presentation, sir.
Thank you so much, Dr. Irfan Haq, for your so kind introduction. I think, is my voice audible?
Yeah, it's audible, sir.
So I'm going to share my slide if you make me a co-host, so I could do that.
Dr. Nurul, please see into it.
Is it sharing?
It's not visible, sir, yet.
Okay, from my side, it is showing you are sharing.
It's visible.
Okay, sir.
No.
So let me just put it into.
Yeah, it's visible.
I think I'm audible also. So I'll just start and I'll just take a moment to really appreciate my previous speaker, Dr. Vibhu and Dr. Manjula. They have very nicely spoken and very concisely spoken upon the various aspects of oral cancer, head and neck cancer, the role of as most of our participants are from dental fraternity, how we are going to implement our knowledge and help these patients when they come to us. I have been working with cancer patients for now nearly 13, 14 years, and exclusively we work for a rehabilitation process of these patients, and specifically in head and neck cancer patient. So I was asked to share my views on palliative care in oral oncology, and I'll just go through it. So let us just first see what is the current scenario of the modern medicine and where we are right now. In any point of time, if you feel I am not audible, please do let me know, because it would be difficult like this. So I'll just go. At this advanced stages of research and innovation, we have a multitude of armories in our pocket to treat cancer diseases, and it include immunological advantages, molecular biology, use of nanotechnology, use of robotics for very precise surgery. There are chemotherapeutic agents which are targeted therapies, immunotherapies, and because of advancement in these fields, because advancement of radiation therapies, like we have now proton therapy, image guided radiation therapy, and because of all of this, the change which has happened, it has got most of the positive side effects. It has improved the cancer outcome. It has increased the expectancy of life in patients who are probably was not much in before. So the cancer now has become more curable aspect. We have less invasive surgery. As I was talking, there are certain surgeries which could be done with robotics, or there are minimal invasive surgeries which have increased the life expectancy of the patients. The pain management modalities have drastically improved. There are various methods, including from the WHO ladder of pain control, including from various nerve blocks, which could be given to these patients, and diversion therapies, mirror therapies. A lot of things have evolved, and because of these positive side effects, we have now more number of patients who are undergoing cancer treatment, or who have recovered for cancer treatment, or who are in the phase of spending their last time of cancer. So their time after treatment is more, and hence, because of this, we have certain negative aspects also. Now, because we have improved so much in the technology, the life expectancies increase. Now, because the cancer patient now is living more after they have been treated, so there are more complications, there are more recurrence rates. We see patients who have been treated for cancer, say 5 years ago, again has a recurrence in other side of the reason. It may be they had a buccal mucosa carcinoma, now they have a carcinoma of tongue. So, or they have a secondary carcinoma, or if they have two primaries in the different sides of the body. So, because of this, we have bigger load of another problems which creeps in with these kinds of outcomes. Now, emerging complications, like we have patients now putting on ventilator, they do come out of it also. They have a lot of infections like pneumonias. They have a lot of resistant infections. We have a lot of patients with hematological malignancies, which because of advancement of targeted therapies now have better outcomes. So we have more complications, and to address these complications, we require additional help. We have a lot of drugs coming in, which is increasing the cost of treatment. And because of this, we have, because we are extending the life, gradually the quality of life deteriorates. And here come the role of how palliative care is going to help all these patients in these conditions. Now, when the patients are having these kinds of problem because of advances in treatment, or because of recurrence of cancer, or because of some kind of failure, they lose their confidence. There is increased cost leading to financial toxicity, and then there is a loss in healthcare system also. So they have lot of problems going on, which is just not physical. So they are having psychological issues, they have having emotional issues, they having social adaptation issues, they have financial issues, and then on the top of it, obviously there is physical pain and symptom issues which they are following. To answer all this, we have this concept, which is not a new concept. It has been with us, especially India, for many, many, many years. Centuries old. It is in philosophy of being an Indian, is palliative care. So now we need to discuss what do we understand by palliative care. Now this palliative care got into this into discussions, or they came into front light by one of the emeralds, Dame Cecil Mary Saunders. She was initially a nurse who went back, did her MBBS, became a doctor, physician. She was a social worker, a writer. She did a lot of work, and because of her, a thought process started in the West. And we could trace back this palliative care, the concept of it, from Madam Cecil. Then we should also know about other pioneers, contributors in palliative care. Dr. Robert Twycross, he's known for hospice development. And initially, it was just to just as a protest against a lot of cost which was associated. So he started a hospice where people could spend the last days of their life without being financially drained, in a group with good social contribution, a good social connect, psychological connect. And he was one of the major contributor to development of palliative care, hospice care in the West. Again, palliative care term was specifically coined and documented by Professor Balfour Mott in 1975. So we have an idea how these have contributed. Now, when we go and reflect and introspect as if how we as Indian subcontinent has contributed this concept of palliative care, it is very, very deep rooted. It is in the ages of King Ashoka, 273 to 232 BC, that we had a big institutions near River Ganga near Varanasi, where they would develop areas where people could come in their last days of life. They could live there without any cause. They would do all their puja and everything, spirituality. They will have food. They will have medications for their pain. They will have a lot of sessions. So this kind of concept was coming from India many, many, many generations back. and still we are it is our in our upbringing, and this is how our concept is now integrated with the modern concept of palliative care. So it is nothing new, but this is something which has already been done from ages and ages in India. So when we're talking about palliative care is not only for cancer patients, it is for anyone with any kind of life debilitating chronic illness which has contributed a lot for physical symptoms, psychological, social, spiritual, financial toxicities. Any kind of disease can be included in this palliative care area of treatment and all contribution. So let us just now focus on only on oral cancer. So when we're talking about oral cancer, we keep the patient at center, and we have these three points which will converge together and will make this whole care as patient-centric care. So we talk about the primary cancer treatment. That means the patient is getting this, their surgery, their radiation therapy, their chemotherapy. Then we have supportive therapies, like we have supportive oral rehabilitative prosthetic therapy, as we are a set of dental colleagues listening to these lectures. There are other supportive therapies, what we could include into that, like nutrition. We have a supportive therapy which include psychologists, nutritionists, dietitians, speech therapists, nurses. All of this would help in supportive care, making the patient more prepared to receive this treatment, making the patient more prepared to absorb all the toxicities which come with this treatment. Again, with this, we also have to include a very important part of patient. Patient is always just not body and heart, it is also mind and heart connection. So we have to inculcate various aspects of this also, which include mind body medicine, psychological aspect, and spiritual aspect, depending upon what is the the thought process of the patient. If the patient is very spiritual, they could benefit from spiritual gurus, spiritual philosophies. If the patient is very religious, they could benefit from religious practices. If the patient has the concept of knowing self, they can get benefited from mind body medicine. This is a very a different area of work which a lot of research has been done, and they have proved that this helps a lot in improvement of quality of life for patients who have undergone any kind of cancer treatment or are undergoing cancer treatment, to have good quality of life. So as I already told, supportive care has a lot of things. When we're talking about head and neck cancer or oral cancer, it gets relieved from the head and neck cancer related symptoms like mucositis, xerostomia, candidiasis, trismus. We have a lot of pain related associated functions. We have a lot of physical disabilities which comes with it, neck flexions with it. There are a lot of surgery which limits a lot of movements in head and neck cancer patient. This kind of supportive care will also get better compliance to the treatment. It will relieve them from treatment related symptoms. It will give better delivery of treatment. So even the care provider, they find it very easy when the patient is in a supportive palliative care therapy, that whenever they're providing this treatment, it is more they are more compliant to it. They receive it much better, and then they get benefited from it. So coming to the next one, I think it's not moving. Okay. So coming to the definitions, there are a lot of definitions which went around, and initially they all, I think I'm getting this waiting room. So I think can somebody look into that? I'm getting this notification for waiting rooms. Okay. So way back in 1990, it only focused on total care with the patients who are very progressive in their disease and where the life expectancy is not much. So now we are not focusing on the curative intent. We are just controlling the pain and symptom. That was back in 1990. But again, after nearly a decade now, in 2002, it was redefined as patients and their families with life-threatening illness, focusing on relief of suffering, early identification, assessment, and treatment. So still they were focusing on life-threatening disease, but they were focusing for both patient and their attendants, and which was focusing on relief of suffering, early identification, and treatment. Again, International Association of Hospice and Palliative Care in 2018, they updated the definition, and now it is in the crux, that is the active holistic care of individual across all ages with serious health related suffering. Now, it is not terminal illness, but it is serious health related. Even patients who are chronically kidney disease patients, cardiovascular patients, they will also come under this definitions of palliative care. So it is just not end of life care or terminally ill patients. It is also patients who are chronically ill. So it aims to improve the quality of life of the patients, their family, and caregiver. So the whole concept of palliative care is just not addressing the patient. It is addressing his support system, his family, and caregiver also. This is one of the very beautiful pictures which sum up the whole concept of palliative care, that the base of it supports family, it treats the person, it promotes quality of life, and it affirms life. That is what the crux of palliative care is. So positive aspect of palliative care, family meetings, understanding, we are giving them informed choices. Because of all this, there is better patient to physician relationship. So palliative care would focus on patient to physician relationship outside just clinical examination. So once they have this relationship, it is better when there is some breaking bad news or there is something which is not going according to plan. These things are received in much better aspect if you have a better relationship with the patient. So the traditional model was diagnosis, then your cancer treatment, and at the end of life, we'll used to give palliative treatment, and the patient would die, and then we'll leave it like that only. Now this thing has whole change. Palliative care will not start only at when your treatment has failed and now you are just controlling pain or the symptom of the patient. It starts on the day one of the diagnosis. Even screening is being included into it. So the day the patient is diagnosed with the cancer, at that day the palliative care starts. It can be basic counseling, it could be diet modification, it could be preparing the patient for surgery. So if you prepare the patient for surgery with good nutrition, the outcome of the surgery is better. There's certain thing which is known as ERAS protocol, enhanced recovery after surgery. So if the pre-nutrition is better, the surgery outcome is better. So this palliative care starts on the day one of the diagnosis. It is there during the course of illness. When the cancer is in the treatative, curative aspect, it focuses on the curative part. When the cancer is not in the curative aspect, it focuses on pain and symptom. It also helps the patient to achieve good death. That is what we're going to discuss in few moments in the end of life care. So at screening, diagnosis, during the curation process, during the pain and palliative symptom care process, facilitating the patient for good death, and even after the death, the patient is gone, the bereavement process, the relatives who are left, those counselings are also done under this concept of palliative care. So palliative care philosophy is the task of medicine is to care even when it cannot cure. So we also focus on futility of treatment. Is the treatment going to be of any advantage to the patient? Ask this question to yourself. If the answer is yes, please go ahead with it. If the answer is no, then probably we would only give him some symptomatic relief and we will not increase his financial toxicity. We are going to provide him some kind of good death experience. So what is good death? So on the one side, there is a man's in the ICU with a lot of tubes in every orifice of his body. On the other side, there is a lady who is surrounded by their loved ones. And they have come to this concept of accepting this outcome. So when they have accepted the outcome, the patient is also content when they go, when they leave their body. The loved ones which are left behind, they don't have any guilt. They have done whatever they could do, and this is what we call a good death. We don't want patient to die alone in ICU with a lot of tubes. We want patient to die in an environment where they could go with their mind and their heart fulfilled that they have done whatever they could, and their relatives, their attendants, their spouses, with this idea that they have done best for their patient, and after that is done, they could move on with their life because they understand it. They don't have any guilt of it. So there is a small poem which we generally see, and this is something which I always tell in most of my presentation. There is a small baby which was born prematurely, and a doctor has just penned it down. I was born premature 4 months early. You intubated me, put me on a ventilator because you could. It went on for days, and my parents said stop, the last straw. They finally could. If you had known what my future held, would you listen to me on day one? Would you stop? So we need to ask ourselves this question: what we are going to achieve if we are going to take any drastic medical intervention for our patient. This baby was born at 4 months early. That means the baby was born at the 9 month of pregnancy. 4 months are gone. They are just 5 months. So 5 months of fetus doesn't survive much, and the kind of trauma it had on the parents, was it justifiable? So we need to ask our question again and again. What we are doing has to have some kind of relevance. It should not be medically futile. There is a very beautiful PDF I would like all of you to go through. It is National Program for Palliative Care. It is there in the Government of India website, freely available. Please go through it. It is beautifully explained what is palliative care, how we can do it, how we can integrate it from the basic Anganwadis, Ashas to the tertiary cancer center. And I would like to focus on Advanced Health Care Directive. Recently in 2023, Supreme Court has now given a green signal that now patients who are terminally ill, who doesn't have any chance to get recovered, they can sign a living will that they can write. If I'm admitted in emergency, I do not want ventilator. I do not want to be intubated. I don't want to be resuscitated. So they have this right which legally protects doctors, and it gives a legal right for the patient to pass and have a good death, and doesn't get him stuck because of this all legalities we could do. So this is a recent development in 2023, and this happened because of Aruna Shahbag. So Aruna Shahbag, I think few of you must know that she was a 25 years girl, a nurse, and she was working in Mumbai, and she was sexually assaulted, and for 41 years she was in coma. So nearly 2/3 of her life she was in coma. She lived for 25 years. She was in coma for 41 years after that. So because of that, a lot of things happened. 2011, a landmark judgment came, and there was a bill which gained right for dignified death. Though she couldn't get this because the people who were caring for her didn't allow to take her out from this coma, but because of her in 2018, a 5 bench judges they sat, and a common revision was done into 2023, which has now simplified the advanced directive. Now you don't have to go for a district magistrate or a collector. Any register medical practitioner from a government can sign it, as we are signing the character certificate. We can sign, a patient can write all of these things and then get it signed by a gazetted officer, and that will serve as a medical directive. So that is one of the achievement which had. So these principles we have to follow when we are talking about palliative care for the patients who are nearing death. It is autonomy, beneficence, always injustice, dignity, honesty. So I'll just go through a small example for you to understand. We have Mr. X, who is 54-year-old man with advanced cancer of stomach. He was a manual laborer and worked very hard to support his wife and rear 4 children. Now his children are grown up and they've started to earn. They're earning very nicely now. When he has become ill, he is now refusing to eat food and fluids. His wife and children are now upset because they're thinking that now he was working so hard, we can earn now, but he's not wanting to have an NG tube done. So they are now forcing the doctor to put an NG tube on it. So when we are analyzing this on the principle, we need to think about what the patient want. We can't go with what the spouse want, what the child want. What is the patient thinking, what they want? So autonomy, if you're talking about, respecting, not to force feed him, is ideal. But we need to psychologically assess it, whether it is because of depression. If it is because of depression, we need to treat that. But if the patient is very, very clear, he doesn't want to drink or eat, and he has valid reasons for it, we should not force him, because if it is nearing his death, taking fluids make him more sick, taking more food make him more painful. We don't want to give him pain. Beneficence. Now we have to understand whether going for any kind of terminal hydration or nutrition, is it going to improve the quality of life? Now this patient is end of life care. So giving him additional terminal hydration or nutrition is not going to improve his quality of life. So there is no beneficence for this treatment also. Now coming to the non-maleficence thing, if we are talking about it, we have to see whether giving this nutrition, can it result to pulmonary edema? Will it be causing a lot of secretions needing for urination? So if whether our intervention is going to doing any harm or not. If it is going to do any harm to the patient, we will not do that intervention. Just as. Now, using nutrition doesn't take out much of our resources, but still, if it would be a resource of, let's say, like ventilator. If a patient is nearing his death and we are putting it into ventilator, will this prevent his death? No. But if this ventilator is given to some person who is young, who has a better chance of recovery coming out of it, we are taking out the right for uh, allocation of resources. So the justice principle should also be checked upon. So all of this needs to be taken in consideration, and we need to have a good skill communications. So we were saying palliative care should not be misunderstood with only end of life care. It starts on the very first day of diagnosis, even at the time of screening. It goes through the treatment of the cancer, at the end of life of the patient. Even after the death, we have bereavement services for the relatives who are left. And this is the concept of palliative care. Now, WHO has given this beautiful model in which the foundation below the ground is empowerment people and communities. We have to empower these people and communities, build communities. Based upon that, health policies would come, and this health policies will become the foundation of our palliative care. Based upon this, people who are sitting in positions where they could do research, they have to do solid research, create good clinical evidences. That makes the foundation. On this foundation, we have the use of essential medicines like morphine and other drugs. We have to make certain education training programs to strengthen our ASHA workers, our supportive care workers, our doctors, our nurses. And with this essential medicine and education training, the provision of palliative care becomes the roof of it. Now, under this house, we have people who have been addressed with palliative care needs. What extra we need to know? All of the people who are involved in palliative care, they already know their technical things. If you are a nurse, you know how to do nurse work. If you're a doctor, you know what a doctor needs to do. What we need to understand and learn to be a palliative care healthcare professional is to understand, give, respect what is realistic hope. You need to have an honest information system. You need to have the concept of maintaining quality of life as much as possible till the last breath of the patient. So this is not much. It is only on the psychological and emotional domain of our skill set which we have to work. The other skill set which we get as to what technique we're using in surgeries, what technique we're using in radiation, what technique we're using for nursing of the patient is what we learn in our courses. What we need to work upon is bringing up of a human side, bringing up upon other faculties of our character, and this becomes the foundation of palliative care. So when we're talking about pain, so I'll just take a small example of it. When we talk about the pain, we only address the physical part. So pain can be caused because of cancer, treatment, and the side effects. But what about the psychological aspect? Anxiety, fear of suffering, depression, past experience with the illness. If it is a recurrence case, they have a very fearful experience of their previous cancer. You need to address the psychological aspect also. What about the patient if they are angry at God or fate, or they have lost their faith? They are finding meaning of life. They are not. They're lost. They have a fear of unknown. So you need to address the spiritual aspect also. What happens if the patient has lost the role of whatever they were playing, their social status? They were a teacher, now they are not going out of the house. They were a banker, they are not going to the bank now. They've lost their job, their financial considerations, they worry about the future, they worry about their children to getting married, they worry about their spouses. Now, because of all of this, there is total pain. Now, we have to address the total pain. We just need not to address only the physical aspect of pain. Maybe you give morphine and you will give WHO ladder, and the patient might get rid of the physical pain. Unless and until you address psychological aspect, social aspect, and spiritual aspect of pain, it will not go. So we need to understand that also and keep that into consideration also. So this is a beautiful graph. I'll not bore you onto this, but just see this dotted line. It shows palliative care, and solid line shows curative care, and you have a point of death. Now this graph is for the patient with an ICU admission. You see the curative intent goes up and up and up. When the death is nearing, the curative intent will drop to the bare minimal. And at that point of time, the palliative intent will go up. So the palliative care focuses on whether the treatment you're giving is going to improve the quality of life or outcome of the patient. If the patient is nearing death, there is no point in putting patient into ventilators. There is no point in giving patients intensive artificial nutrition, because we cannot reverse death. If the death is approaching, there is sign of death. You'll get documents which I was sharing about in that national palliative care portal. You will get this document. The signs of death. Patient will tell you when they're going to die. At that point of time, we have to minimize the curative intervention, and we have to enhance. We can't abandon our patient at that time. We have to enhance our care. And in that palliative care, we have to take care of the total pain. We have to take care of the total symptom. We have to take care of the patient support. We have to make sure that the patient knows about their right for dignified death. We need to make sure that the patient has been spoken about in the advance directive, and this advance directive has to be talked about when the patient has a diagnosis terminal illness. You should not wait till the patient is in the last days of their deathbed and then you discuss about advance directive. Advance directives or the living wills should be discussed with the patient when you have broken bad news, when they have come to the diagnosis, they've accepted the diagnosis, they are still conscious oriented, and at that point of time is the ideal time where you tell the patient about advance directive and they can plan their good death and you could facilitate them. When the patient are dead, this palliative care will not uh, disappear. You could see this dotted line going gradually down, and it goes gradually down because we're going to address their relatives. We're going to start their spouse, their child, their caregiver, because they need support. Their mission during this treatment was to fight with the patient. Now the patient is gone, they are lost. You need to bring them to bring them back into the society. You need to give them more comfort, give them care, give them purpose. So this is what palliative care would encompass. So transition of care we all talked about. We need to ask the question. I was telling, we need to find out whether this patient, just ask this question to yourself. Maybe if we are a dental expert, these questions would not come to us, but people who are taking care of patients who are terminally ill, they need to ask themselves whether this patient is going to survive for the next few months, weeks, or days. And that gives you answer. That gives you answer how you're going to plan for this patient. If the patient death is imminent, it is going to come. You need to give them closure. You need to give them supportive care, palliative care. You need to reduce the curative intent. You need to address for pain and symptoms. That is what we need to give this patient. We have to identify, we have to assess, and then we have to plan for these conditions. So there are various barriers for the physician label, that is end-of-life discussions. We don't do it. Perception of need of palliative care is varies. Nobody who is giving active cancer intervention is part of palliative care. Now things have been changing, but we need more. There is no formal training of communications for the patients happening. We don't train our physicians or healthcare professionals as to how to talk to the patient. How do we communicate this? There are various complex diseases, and this is different thing. At the patient level, patients, they don't know about it. They are in denial. There is conflict of interest. They have poor understanding, ignorance, poverty. There are a lot of things that needs to be addressed. So I think I'm just running out of time. I'll just finish it up. These are few cases. I'll say, see, this is one of the soft palate defect after cancer surgery. There was a small lesion. The patient wasn't able to speak properly, and there was a lot of regurgitation. A small plate obturator is palliative care. The reason I put this picture, do not consider palliative care only for end-of-life care. Even if you improve the quality of the patient at initial level of a totally curable disease, that is also palliative care. The patient, which is hemimectomy, how do you rehabilitate this patient becomes palliative care. The patients would have a lot of radiation decay. How do you rehabilitate this patient becomes palliative care. The patient with mucositis, this is chemotherapy-induced, platinum salt-induced mucositis. How do you rehabilitate this patient? This patient was has to be stopped mid-cycle because of very severe mucositis reaction. There was grade 4 reaction. The patient has to be admitted. He was given into, he was put into nutrition, parenteral nutrition, and there we have to give him break for 2 to 3 weeks because he had a lot of infection and mucositis in his oral cavity. So this kind of taking care of this patient is also palliative care. This is a classical example of this one of this patient. We had a home visit for this patient, has maggots, advanced stage of buccal mucosa. Now, for this patient, if you put this patient in hospital, in an ICU, probably later in ventilator, what are you going to achieve for this patient? So, in these kind of situation, we need to ask, what is the future? Is our treatment is going to help it, or is it is futile? If it is futile, please abandon that. We need to give him symptomatic care. We need to give him care. We need to take care of his wound. We need to take care of his nutrition. And we need to make sure he gets a good death. We need to make sure his caregivers get adequate bereavement support after the patient is dead. That is what palliative care is. This patient has osteonecrosis. Now, caring for this wound, recovered the patient, and this is what palliative care will entitle. This is a patient with stage 4 CA buccal mucosa. So the patient was given neoadjuvant chemotherapy and then put on supportive palliative care. And the patient he's going to live for a longer period of time, but he'll have a lot of disabilities, a lot of issues. So taking care of those issues would be palliative care. So the crux of the presentation is palliative care. Please do not confuse it with end-of-life care. Palliative care starts at the screening part. It continues after death till the bereavement, support to the caregivers, and in everything in between also. So even if you do a small mucositis management, that is palliative care. If you're going to give end-of-life care, that is palliative care. So please go and have a broader understanding of how it is. Ask before any intervention whether this intervention is going to improve the quality of life of my patient. If yes, then please go ahead with it. If it is not, it is probably a futile intervention. It is just going to, maybe it can extend few days to the patient, but it will not be good for the patient physically, psychologically, financially also. So I'll just get with this slide. Best treatment is available 100% of the time. It causes relief, but humanity is the drug which you need to give. The power of healing does not lie in just prescribing drugs. What it essentially requires is caring for the patient. I'd like to give my credit and to Dr. Sushma Bhatnagar. She is one of my mentors and a very leading figure in palliative care. And with her in along with her in IAPH, Indian Association Palliative Care, we have learned a lot of how we could contribute. So most of the people who are from dental fraternity, you have a very big role as how you can contribute in supportive and palliative care, and specifically head and neck cancer patient. There's a lot of things which could be done. There are a lot of requirement. We require a lot of people who could help us in palliative care. So if anyone wants any information or they would like to contribute in this mission of supportive and palliative care, do contact us. They were wonderful speakers before me, and they're going to be wonderful speaker coming after me. Please connect with all the speakers you could and answer about yourself. If you are interested in providing relief to these patients, in relief, it is not limited to cancer, it can be of any disease. So if you are interested in it, reach out to the any speaker you could, and there are a lot of opportunities which could be taken by the dental surgeons across India in shaping the palliative care in India. Thank you so much. I hope I have not taken much time, and thank you so much.
Dr. Irfanul Haq, can you take on the questions to Dr. Abhishek, and then you hand over to Dr. Smurdi.
Oh, well, a very nice presentation, Dr. Abhishek. It was really very, lots of things to learn, and it's really a good thing if a dental surgeon can give this palliative care to the cancer patients. Lots of cancer patients around us, and most of the times we lack the experience, we lack the expertise to give them the palliative care. Hopefully, this will help all the dental surgeons who are hearing to you. It was very nice presentation, and I would like to ask if the people present in this platform, do they have any question to Dr. Abhishek? They can ask, otherwise it will be in the chat box. Anybody want to ask any questions regarding this presentation to Dr. Abhishek? You are welcome. Otherwise, if you can't ask now, you can ask in the chat box as well.
They are asking mobile number, contact number of Dr. Abhishek. So Dr. Abhishek, could you, if you're comfortable, you can pass the contact number.
With the people wanting that.
Yes, so I would be more than happy if anybody, I'll just type it here. So 7500600066. So we do run this supportive, this palliative care courses in association with the Indian Association of Palliative Care. And this is the basic requirement to get this courses done is MBBS or BDS. And this is a part A and part B course. It's a CCEPC, earlier it was known as. Now it's a foundation course in palliative care. And after this course, which this is a nationally recognized course, and after this course, anybody who has done this is a license for morphine distribution and prescription. So there are around 53 centers across India. And one of the centers is with our cancer center. This is Cancer Center Dehradun. So you would find a lot of centers around in your state also, near your area also. You could just search that, and you could do this in Indian Association Palliative Care Certified Palliative course, which is specifically made for MBBS and BDS students. And there are a lot of things which a dental surgeon can do in this aspect. And we are now working with I just give update for government of Uttarakhand. We are working with 13 districts in Uttarakhand, and we are developing a palliative care network. And out of this participants, we have around 50 participants from various district hospital of Uttarakhand, from 13 districts. And out of them, I am very proud to say that around 30% are dental surgeons. So they have taken up lead, and they are part of Government of India Uttarakhand initiative, and our initiative along with AIMS Rishikesh and AIMS Delhi, that they are now part of treating a chain of referral of these patients from hilly area to the tertiary care centers. So anyone who has a BDS degree is more than qualified to do palliative care, and they could do more in head and neck oncology, but they could do general palliative care also. And I would be more than happy. I've shared my number. You could just WhatsApp me, or any. I think any of the speakers here are already involved in these kinds of activities. You could contact any speaker. They would be more than happy to share.
One of the audience is asking that are there diploma online courses available, sir?
Yes, yes, that is what I was telling about. Indian Association of Palliative Care is a very old association. I recently was part of a panel discussion in Jammu. We had a 32nd conference, international conference of IAPC, and that was what I was telling, that there are around 53 centers across India. You could just type that, and you will find a center near your hospital or near your area, and you could log into that. And it happens in two parts, part A and part B. Part A is online, and then you have to give an exam, and part B you have to do 10 days of observership in a cancer center. So you'll find out fee structure is 10,000 rupees, and it is 3 to 4 weeks online, Saturday, Sunday. I think you just type IAPSC, IAPC, Indian is, I'll just write there the message, maybe you'll get it. IAPC.
So, Dr. Abhishek, our next speaker is
Yes,
there
okay.
actually.
Thank you so much, Dr.
You can
Nurul.
continue,
Very nice to you.
answering your these queries on chat. Actually, they are very keen. There are many chats. I am just seeing that they are asking the queries. So it's a better you can ask a question, answer the question there, because our next speaker is there in the meeting room. So can I request Dr. Sumriddhi, can you introduce formally Dr. Himanshu Aran, and so that he can start presenting his topic.
Yes, sir.
Um, Very good evening, Dr. Himanshu sir. So we have a very distinguished academician and clinician with over 35 years of exemplary services in academics and as a clinician also. He has some really impressive credentials. So Dr. Simriddhi, I would want you to share those credentials so that everybody knows that what kind of speaker we have today with our gathering.
Yes, ma'am, definitely. Dr. Himanshu Eran with BDS and MDS prosthodontics from prestigious King George Medical College, Lucknow, along with Masters in Hospital Administration and Business Administration, advanced training in aesthetics, implantology, and CAD/CAM technology from Germany. Dr. Eran's academic contributions are unparalleled with 225 plus publications in national and international journals. Editor in 14 journals, 80 plus keynote and guest lectures at prestigious conferences, and 30 plus workshops conducted globally. A respected leader in dentistry, Dr. Eran has held various leadership roles like National President, Indian Prosthodontic Society 2015 to 16, and Member Dental Council of India 2013 to 2019. Dr. Eran's dedication to advancing education, clinical excellence, and community services has earned him a distinguished reputation nationally and internationally, and he has number of appreciation awards to his credit. As we strive for excellence at Ras Bihari Bose Subharti University, Dr. Iran emphasizes the importance of holistic development in academics and beyond. His mission is to nurture well rounded individuals equipped to succeed in their chosen paths. He strives for academic excellence by rigorous curriculum, innovative teaching methods, interdisciplinary research, and collaborative projects. He further emphasizes on faculty mentorship and guidance, personality development, extracurricular activities, leadership opportunities, and soft skills training. Dr. Aaron focus extend beyond academics to foster critical thinking and problem solving skills, effective communication and teamwork, emotional intelligence and empathy, social responsibility and ethical values, and all of the above patriotism and nationalism. Together, let us shape the future of education and empower our students to excel. Indian, so sir, over to you, please.
Thank you, Dr. Smriti and Dr. Punita Bora. It's my proud privilege to be part of International Oral Cancer Conference. Can you can allow me to share my screen?
Yes, sir, please share your screen.
Just a minute. So presently I am at Devbhoomi, Uttarakhand, Dehradun, working as a Pro Vice Chancellor at Raj Bihari Bose Subharti University, Dehradun. And basically I'm a prosthodontist. And my previous speaker, Dr. Abhishek, was telling about palliative care. And I will like to share I am working with palliative care since 2016 as a dental surgeon, and there is a lot of scope for maxillofacial prosthodontist to restore the function and look of the patient. That is my main concern of the topic today, as we are dealing with the oral cancer and cancer of the maxillofacial region. So it is a multidisciplinary approach which include oncosurgeon, anesthesiologist, plastic surgeon, ENT surgeon, psychotherapist, diet counselor, radiotherapist, and palliative care, and prosthodontist, of course. So I will concentrate on the role of prosthodontist, what a prosthodontist can do for oral cancer patient. But and when we are suffering from any kind of oral cancer or maxillofacial cancer, and sometimes or most of the times we have to perform surgery and we have to remove substantial part of the oral cavity and sometimes maxillofacial structure of stomatogenetic system, and which is leading to a defect in the facial region, maybe extraoral and intraoral. And our society is very crucial. He don't like anybody sitting next to him with a missing eye, a cut nose, or a half of the face is gone off. So this is the basic trauma, not only physical but psychological trauma to the patient. How he can be restored to the society. The role of prosthodontist is basically to give back the patient the little bit normal look so that he can go back to the society. That is in my screen visible presentation.
Yes, sir, your screen is visible.
Okay, maxillofacial prosthodontic rehabilitation by definition is the art and science of anatomic, functional, or cosmetic reconstruction by means of non-living substitute of those regions in the maxilla, mandible, and face that are missing or defective because of surgical intervention like oral cancer surgery or cancer surgery, trauma, or development of congenital malformation. As per GPT-9, Glossary of Prosthodontics, any prosthesis used to replace part or all or any magnetic system and or craniofacial structure. It may be eye, it may be nose, it may be ear, it may be part of the face, or it may be the palate, it may be the mandible. And what are the objective and indication of maxillofacial prosthodontics? For congenital anomalies, alteration in growth and development, severe traumatic injuries. But here we are talking about acquired ablative surgical or oncological management. When a patient has lost some part of the oral cavity or facial structure, then we have to restore it. What are the aims? Restoration of aesthetics, restoration of function, and protection of tissues. But most importantly, as I told you, psychological upliftment of the patient. When you have lost some part of your face, then you are very depressed. You don't want to go to the society, and you are become introvert. You are planning to stay in house only. So in that case, we all need to restore that lost structure of the face so that patient may look better, have some function, and protection of underlying tissues, the tissues which have been exposed to the environment, which are not supposed to be exposed to the environment, that can be protected by our these kind of prosthesis, and by all this psychological upliftment of the patient. This is the aims of the maxillofacial prosthodontics. What are the maxillary defects? It may be traumatic. We are talking of acquired defects basically. It may be traumatic, pathological, mucormycosis, post-surgical, like excision of tumor and cyst. If we see the maxilloectomy defects, you know, most of you are the dental surgeons, and you know Applegate classification of
Dr.
partial
Himanshi,
bacillus
sorry to
patient.
interrupt you. I think your slides are not moving. You are leading and your slide is lagging. We are just seeing that third slide, multidisciplinary approach.
Oh my God! So what to do?
No, whatever you have spoken, just go to the slide, the current slide which you are considering.
Their slide is not moving.
Yes, not moving actually.
Let me check.
No,
Because
no, it's
I have
moved.
got to 11 slide.
Yeah. Maxillofacial prosthetics.
Yeah, after this,
6 number slide was visible, but it was not in slide share mode actually.
okay, let me check it.
सर स्लाइड शेयर कीजिए.
Slide share.
I'm sharing my screen.
Yeah, we can see your screen, but it's in a very, I mean, एक तो छोटा दिख रहा है, उसको शेयर कीजिए. वहां पे ये बटन होगा साइड पे. हाँ, इसे दबाइए. हाँ,
No, it's okay.
नहीं, आप इसको क्लिक कीजिए. Yes, no.
I put it on slideshow, right?
Yeah, put it on slideshow.
Yeah,
and then you can keep on pressing click and
Just a minute.
Can you see the slideshow now?
No, it's
yeah, absolutely.
No, it's
fine.
again.
Yeah. I'll start from slide 11.
What slide I discussed? Three. Okay. You come to 6 direct.
6, yeah, come to 6. Maxillofacial prosthetics, yes.
Yeah. Now it is visible?
Yeah, it's visible.
Yes.
Yeah, I told you about the maxillofacial prosthesis is the art and science of anatomic, functional, and cosmetic reconstruction by means of non-living substitute of those regions in the maxilla, mandible, and face that are missing or defective because of surgical intervention, trauma, pathology, or development of congenital inflammation. Now it's moving. Next slide.
Hanji sir, it's moving.
Yeah, as per GPT-9, the definition of maxillofacial prosthesis is any prosthesis used to replace part or all of any stomatogenic system or craniofacial structure. It may be nose, it may be eye, it may be part of the face, it may be maxilla, mandible. What are the aims and objective of maxillofacial prosthodontics? It for congenital anomalies, alteration in growth, severe traumatic injury, but here we will consider about the acute ablative surgical or oncological management. What is the aims and objective of the maxillofacial prosthodontics? Restoration of aesthetics, restoration of function, protection of tissues, and psychological upliftment of the patient. as I told you just now, when patient is suffering with this kind of loss, then he is very depressed psychologically. He is not ready to come out to the society. So we have to restore to those lost tissues in terms of aesthetics, so that he may be acceptable to the society, or he or she may do some function. We can restore some functions. We will discuss in later part of the presentation. And as I told you, the tissues which are earlier were protected by the skin and other tissues, they are open now, and they are not very susceptible. They are not very strong enough to face the open environment. So this our prosthesis can give the protection of tissues also, and by all this patient is getting psychologically uplift. What are the acquired defects? Traumatic, pathological, mucormycosis or tertiary syphilis, and post surgical like excision of tumor and cyst. When we are talking of intraoral defects, all of you are most of you are dental surgeons, and you know the Applegate classification of partial edentulous patient. So the classification for maxillectomy defects also based on the that classification. Class 1, when defect is unilateral and not crossing the midline. Class 2, when defect is the unilateral and some anterior teeth are missing. Class 3, it is bilateral but all teeth are intact. Class 4, when it is crossing midline and on one side some posterior teeth are present. Class 5, when all anterior teeth are present and posterior part of the maxilla is missing. You can see the clinical pictures also. And class 6 is when anterior teeth are missing. This is just to understand how we have to plan this. What are the patient problems when we are suffering from the maxillofacial defects? He or she may be having sucking difficulty, sometime or most of the time nasal regurgitation of the food. There may be dental anomalies or missing teeth. There may be problem of airway because continuity of the oral cavity and nasal cavity has been broken. Aesthetic and speech will be affected definitely, because most of the sounds are being produced by the palate, teeth, and tongue. And once it is maxillofacial defect, the teeth are missing, palate is missing, the patient is not able to speak properly, and psychological trauma is always there. So these are the problems which we have to solve out. Now coming to the role of prosthodontist, what we think the role of prosthodontist begins once surgery is over and surgeon has done his job and defect is there. Now prosthodontist has to play a role to make a maxillofacial prosthesis to achieve the aims as I told you. But this is the misconcept, because role of prosthodontist start since very beginning. He can be involved for making pre-surgical appliances. He should be involved in surgical treatment plannings, and post-surgical appliance is of course is the part of only prosthodontist. The surgical treatment planning consists of oncology, ENT, plastic and oral maxillofacial surgeons, orthodontists, prosthodontists, speech therapists, and psychotherapists. Preoperative consideration, psychological support to the patient. We have to consider dental management. We have to take preoperative impressions, which will be very helpful for making prosthesis in later stage, and suggestions for the surgeon. Now you will surprise what a prosthodontist will suggest to a surgeon. Yes, prosthodontists have so many modification in his mind, keeping in the mind for the future prosthesis, he can suggest to the surgeon. Surgical enhancement of the defect, I will cover. Preservation of hard palate and preservation of ipsilateral premaxilla. This we can suggest to the surgeon if first aim of the surgeon is to remove the entire tissue, not leaving any tissue which is having the malignancy. But sometimes surgeon do little more removal of the tissues. So we can ask if preserve maximum hard palate you can and ipsilateral premaxilla. This will improve the saving the teeth and surgical side because of the functional proximal line shift to the more favorable position, and always suggest to the surgeon to save as many teeth as possible. You see here surgical enhancement of the defect. Prosthesis, when you are making a prosthesis, it rotates along the cut edge of the bony surface. If you see the upper slide and if you see the lower slide, so if you, this is the class 1 situation, upper slide, and second become the class 2 situation. If surgeon is just removing entire maxilla of one side, then it will be class 1 defect and prosthesis will rotate more easily. But if we are able to save few teeth on the another side, so we can shift the fulcrum line to the favorable position by saving the teeth on defect side. You got it? Just clasping the third molar on non-defect side. You see here, we are just saving the posterior part of the maxilla and saving the third molar or second molar in the posterior region. And this can give a good retention in future by clasping a central incisor and third molar defect side, and this will rotate, check the rotation due to weight of the valve. Anterior and the floor of the nose, there will be less collapse of facial form and less post-operative contracture. Attachment of muscles of facial expression will also be preserved. Transalveolar plus intraproximal cut. Here, when we are removing a tooth, like in this picture, you can see we are removing a premolar. So instead of removing entire socket, we can preserve half of the socket, and this will, we can preserve the root of the adjacent teeth. Skin grafting of the cheek flap. Surgery leave a denuded surface of entire cheek flap, remnant of the pterygoid muscles, bad and short palate musculature. And if we do the skin grafting, this area will be more helpful for retention of the prosthesis because we can derive retention from the defect, and our skin graft is making it more resistant to the forces and more pressure bearing area. Development of lateral scar band. This will again help. If you see the dotted line here, so there is again help for the retention of the prosthesis. This scar band will give a coverage for the like undercut. These are the advantages of skin grafting. The graft will be prosthesis bearing in 10-14 days, that will not easily abraded. If it is not grafted, respiratory epithelium from nasal mucosa will grow and secrete mucus. You know, I told you the tissues which are not meant for the having the pressure environment exposure, then they will be exposed and we have to protect them. And if there is a respiratory epithelium, then we can have more secretion, which will be not good for the patient. Along the lateral, check the junction of the skin graft with the remaining buccal mucosa and in the pterygoid muscle area. As I explained in the last slide, scar band will aid in the retention. This is skin graft, the maxillary sinus veil. Remaining sinus walls should prepare during surgery to create bony undercut. Grafting sinus wall stops formation of polypoid tissue. Control mucus generation within the sinus, which reduces secretion and allows the wall to become load-bearing area. Now coming to the prosthodontic management. Indications for prosthesis: wide cleft with deficient soft palate, neuromuscular deficiency of soft palate and pharynx, interim prosthesis in delayed surgery, incompetent palatopharyngeal mechanism, and surgical failure because of heavy scarred palate or large multiple perforations. When we are talking of maxillary defects, intraoral defects, then obturator is a very helpful and very easily approachable prosthesis. There are different kind of prosthesis. extraoral, intraoral, but in this presentation we are concentrating only intraoral defects mainly. Obturator is a maxillofacial prosthesis used to close a congenital or acquired tissue opening, primarily of the hard palate and or contagious alveolar soft tissue structure as per GPT-9. Function is closure of defects, enhance the healing of traumatic or post-surgical defects, improve speech and aesthetics. If you remember the objective of the maxillofacial prosthodontics, so it is the functions of the obturator which we are getting. Prevention of regurgitation of food from mouth, improve deglutition and mastication, and prevents flow of exudates in the mouth. These are the advantages: comfortable life, reduce cosmetic deformity, supports upper lip and cheek, restore adequate speech and deglutition of magnetic. These are the different type of obturator: interim immediate surgical obturator, transitional or interim obturator, and permanent and definitive obturator. It depends on the what time we are delivering the obturator after the surgery. As per material use, it may be a metal obturator, resin obturator, silicone obturator, and as per the areas of restoration, it may be palatal obturator or metal obturator. Metal obturator means when it is restoring the soft palate also, and it's helpful in the speech also. Immediate temporary obturator. As I told you, the role of prosthodontist start before the surgery. So it is very simple prosthesis which will play important role in treatment by protecting defect from the mechanical trauma, correcting the speech defect, helping to eat and drink. The immediate temporary obturator is being worn for 7 days to 6 weeks depending on the individual healing of wounds. Retention of surgical obturator may be done with the help of RPD clasps, dental ligature wire, sutures, and palatal screws. Next is interim obturator. Is usually constructed after 7 to 10 days, constructed from post-surgical impression cast, having false palate and false ridge. Frequent recall visits are required to reduce or add the material as per the requirement. Relining we call it. Then coming to the definitive obturator, a prosthesis that artificially replace part or all of the maxilla and associated teeth lost due to surgery or trauma. Timing depends on size of the defects, progress of healing, effectiveness of present obturator, and prognosis of tumor control. This depends how we made the interim obturator and what is the how is the healing of the tissue is occurring. So accordingly, we modify it, and once healing is complete and everything is stable, then we go for the definitive obturator. What are the treatment concept for definitive obturator? Extension of the defect. It will provide effective sealing, engage the scar band, as I discussed earlier, engaging the nasal spine, and we have to achieve lateral stability. For lateral stability, we are most of the time doing the intra-defect extension. And we have to reduce the weight. And for doing the weight reduction, we can make hollow valve obturator and open top. You can see in the picture there is a obturator which is having hollow bulb and top is open. What is the advantage of open top? As you know, their secretions are coming. So that secretion keep on going to the patient mouth and giving him irritation. So those secretions can be accumulated in this open top, and once it is filled, then patient can take it out and remove the secretions. Design objectives: design and leverage were to be anticipated functional forces and preservation of the remaining teeth, which is critical for support, stabilization, and retention of prosthesis. A primary goal in all classes. As I told you in the beginning, the surgeon should be asked to have the maximum teeth safe so we can have better support, stabilization, and retention of the prosthesis. I explained it also. Retention we can achieve by the remaining teeth, number and position of periodontal status of the teeth, retentive class, We can use alveolar ridge, utilization of physical properties of adhesion, cohesion, and atmospheric pressure. All of you know it. We are doing it complete denture also. Large ridges with the broad arch palate are better choice, and square arch form is better than V-shape arch. Retention within the defect. This is also very important and crucial. As I told you in the beginning, we can do the skin grafting to make the defect is more resistant towards the displacement and pressure bearing area. The residual hard palate, we can use besial wall, residual short palate, nasopharyngeal extension, lateral scar band can be used, and height of the lateral wall will be more, then we are getting the more retention, because more the area, more the retention. That is the basic principle of the designing. Stability is another important aspect, and we have to develop residual maxillary stability, bracing the components in partially dentate patients, and maximal extension to the mucobuccal fold in edentulous cases, and stability within the defects, optimal extension of lateral walls. Support we can achieve from the teeth, alveolar ridge, and residual hard palate, and within the defect, contact of prosthesis with firm base. Occlusion, we have to consider maximum distribution of occlusal forces, eliminate premature contacts, wide distribution of stabilizing components, and non-anatomic posterior teeth. This is very important because they are less support and less stabilization, so we should not generate the disrupting forces. For that, we should use 0-degree teeth in posterior regions. These are the forces acting on the obturator. Vertical downward forces are gravity and stiffness of the food, and vertical upward forces are occlusal forces. So we have to keep in mind when we are planning in the term of retention, support, and stability about these forces which are acting on the obturator. Occlusal prematurity should be avoided during anterior posterior forces, and rotational forces, multi-directional, multiple fulcrum lines should be avoided. And as I told you in the beginning, if we change the fulcrum line from class 1 to class 2, that will be more helpful. We can also use craniofacial implants to supplement encourage increase in retention, stability, and support edentulous patient and anterior maxillary segments. These are the few different types of intraoral implants. So these are the basic which we have to keep in mind. Now I will try to discuss few cases so that you can understand it better. Case 1, extraoral examination has to be done. This is the squamous cell carcinoma of right maxilla. Treatment plan, oral prophylaxis before surgery, fabrication of surgical obturator, which we have to take the impression first before surgery, and during surgery we will put the surgical obturator. As I told you, this will be very helpful for protection of tissues, for deglutition and speech, and then finally fabrication of hollow bulb obturator. This is the intraoral examination before the surgery. You can see this is the early status of the patient. Oral prophylaxis should be done, has been done. Then this is the pre-surgical impressions has been taken. These are the models, pre-surgical models. This surgical obturator has been fabricated before the surgery. And this is intraoperative view when the entire maxilla is being removed to remove the carcinoma. And then you can see when we are fixing the surgical obturator during the surgery only. As I told you, it will be very helpful for the better healing and protection of tissues. This was retained with the help of wires with the premaxilla and maxilla of the other side. You can see this is the post-operative view after the surgery. The tissue has been removed, cancerous tissue has been removed, and obturator was fixed in the patient mouth. Now this is the for making the interim obturator. we have to make the custom tray, and this hole is just to hold the impression material, and alginate impression has been made. The defect area was blocked with the cotton, and a thread always has been attached to the cotton, because if some part of the cotton remain inside, that is very difficult to remove from the tissue. So we can always have a thread so that it properly engaged with the impression. This is beading and boxing of the impression has been done. Then this is the working cast. Undercut was blocked. This is the fabrication of bulb. We have fabricated the bulb. Then occlusal rim form was formed. This is the interim obturator. Is ready to be inserted. This is obturator in the patient mouth, interim obturator. This is preoperative, this is postoperative. In later stage, we have to go for eye prosthesis also, but that is not possible to discuss every aspect of maxillofacial prosthodontic because it is a very big and wide topic. Second case, intraoral examination, you can see the defect here. A case of Armani class 1 type 1 of maxillectomy defect, left side. Treatment plan is the fabrication of hollow valve obturator with the replacement of missing teeth. That is another important aspect. Most of the time, if teeth are missing, then we are making denture also with obturator. This is block out the defect, as I told you, with the cotton and thread, so that cotton should not remain inside. Then impression was made with alginate, irreversible hydrocolloids. Then beading and boxing of the impression has been done. Then this is the working cast. Then retentive wires, as we are doing for the orthodontic plates, we have made the retentive appliances, pinheads and 3/4. Then waxing was completed. This is again hollow obturator we are making. Then outer lid was fabricated to cover the defect area. This is lid in the position. We are covering the lid with the plaster because we have to two-stage flasking. This is the flasking, you can see. Then record base in patient mouth. Acrylic record base has been made with the heat cure, and this has been placed in the patient mouth. You can see hollow obturator is there. Then fabrication of occlusal rims on that obturator. Then record base with the occlusal rim in the place in the patient mouth. Jaw record has been made with the help of zinc oxide gel and patient paste. Then transferring the record to the articulator. Then teeth setting was done. Then trial in of the backstop of the denture in the patient mouth. Then lab remount of the cured denture and adjustment has been done, as we are doing for complete denture also. This is the prosthesis is ready, and this is the insertion of prosthesis with teeth in the patient mouth. Pre-operative, post-operative. Case 3 is the patient complaint of difficulty in chewing food, swallowing, and difficulty in speech. History of present illness, tumor involving right maxillary quadrant involving maxillary sinus. The surgery was done, partially maxillectomy involving palatine process of the maxilla, premaxilla, extending posteriorly up to palatine bone around 3 years back. You can see the involvement of the removal of the tissues is too much, and the entire side of one side has been removed. Because of this, patient is having facial asymmetry, and he is having very difficulty in speaking and deglutition all, and mouth opening is also reduced. This is a challenge, how to make a prosthesis, how to take the impressions. Intro examination, partially maxillary with Armani class 2 type of defect, and unilateral defect involving one side arch not crossing the midline. This is class 1, not class 2. And treatment options are surgical reconstruction, implant and implant retained prosthesis, and maxillofacial prosthesis. What are the advantage and disadvantage of prosthetic versus surgical reconstruction? Individual decision between doctor and patients. Removable process allow for cancer surveillance. Destruction amount is less, and malignancy recurrence chances are more. The treatment plan include definitive prosthesis, obturator closed bulb, material use polymethyl L-acrylic resins, denture resins we call, retentive components, hard palate, teeth on contralateral side, and scar tissue in the defect. Impression procedures with the reversal hydrocolloids, and patients are advised to rinse the chlorhexidine mouthwash prior to the impression procedure. Local anesthetic spray was used for palatal and post-palatal region before making impression to control the gagging. The maxillofacial defect was packed with the gauze piece, as we are showing earlier also. Irreversible hydrocolloid fast setting was manipulated as per manufacturer instructions, and tray was loaded. This is the impression process. This is the primary casts, primary impression and primary cast. Impression. This is custom tray was fabricated for the bulb extending into the defect. Then border molding is performed for better retention. Then final impression was made with the addition silicone light body. You can see in the blue color light body is there. Then lab procedures, undercut was blocked using modeling wax and denture base was fabricated. Bite restoration was done and transferred to the articulator. Then, as I showed you in the last slide, last page, and then teeth arrangement has been done, and it was done in the centralization. Then trial in done, check for aesthetics, phonetics, occlusion, retention, and stability. After trial in, processing of Twitter was done. This is the final processes. Here we have used the circumferential clasp to get the bracing effect more. And this is the scar tissue undercut which we are using for the retention and stability, as I told you in the beginning. This is the semi-surface and interrogo surface. This is the final processes in the patient mouth. Case 4, fabrication of intermaxillary obturator. Now I will show you the last steps. Primary impression. This you can see the defect, then primary impression. This is the fabrication of custom tray, border molding as we have done earlier. Then this is the final impression with the again addition silicone. Fabrication of interim maxillary obturator, and this is final processes. Again, we have used the circumferential class one side and simple class on other side. This is intraoral placement of the prosthesis. Another case, fabrication of interim maxillary obturator. Pre or intraoperative view, you can see the defect. This is the, if you remember the classification, this is the class 3 type of condition. All teeth are present, only defect is there. Then we have taken the secondary impression. This is master cast, frontal view. Then you can see the prosthesis is ready, and this is the post-op intraoral view. Fabrication of interim maxillary obturator, pre and OP intraoral view, secondary impression. This here we are using the open roof top, as I told you. In this we are collecting the secretion on the open roof, and they are which are being transferred to the nasopharynx through a channel in the posterior region. Then mandibular reconstructions. What happens when we are removing the half of the mandible during removal of cancer? So what happens? The mandible tends to deflect on other side because of the muscle pull, because there is no teeth to close to check the movement. So in this contracted effect, the mandibular guiding therapy can be given to restrain the patient neuromuscular system to provide an acceptable maxillomandibular relationship of the residual portion of the mandible, which permits the occlusion of remaining HOT. So we have to train the muscles so that mandible can come back to the original position. So this is the mandibular guiding planes prosthesis. Indication, surgical resection involving the mandible, floor of the mouth, tongue and palate. Mandibular discontinuity effects, loss of the proprioceptive sense of the occlusion leads to the uncoordinated, less precise movement of the mandible, facial asymmetry, malocclusion, and deviation of the mandible, muscular dystrophy, support to bear the muscular forces. It is used in the patients who can achieve mediolateral position but cannot hold position for adequate mastication. The guide flange is extended on the maxillary mucobuccal fold superiorly and diagonally on non-defect side. This is another type of mandibular guide flange prosthesis. In this, we are using the metal framework, and you can see that we are getting the clasp to hold the supporting tissues and to hold it. And if you see the buccally, we are giving a transparent pad type thing, which will give the filling of the remaining tissues, give the support to chi. That is the aesthetic purpose of this kind of designing. Another kind of flange processes. In this side, we are not using the contralateral side. Only one side we are using. This is the mandibular reconstruction with bony graft and implant. You can see the case. Number of parts has been put in to give the support to the prosthesis, and bony graft has been put for the loss of the part, and we have restored the mandible again. You can see here. Intraocclusal record has been recorded, then prosthesis has been made. Rehabilitation of total avulsion of the maxilla. When entire maxilla has been removed, skin graft root with the bilateral opening. I told you what is the significance of skin grafting. Then base plate lined with the functional impression material. Then trial arrangement of the teeth, and this is the final prosthesis. You can see this is extraoral also there. Lip prosthesis retained with the resin bonded retentive elements. Mandibular lip defects was there, and tissue defect, entire tissue is lost because of the surgery. Then custom cast retentive element with the resin bound retainers was used, and the wax pattern was made. The tissue surface with the attachments, cementation of retentive elements, and this is processes in the place. Resin bonded attachment for obturator retention. This is another class 1 type of maxillary defects, and this is the final wax up. Then resin bonded metal casting was done, and framework covering the pellet. Here metallic framework was made, and obturator with resilient attachment was fabricated, and this is the final process you can see in the patient mouth. This is the kind of cast partial thing, and these are you can see the half of the cast crowns which are resin bonded with the teeth, and this become a fixed type of prosthesis. Hybrid gate design framework. This is the framework of definitive cast and between hinge and abutment. Another definitive operator, hollow bulb, open root top, and this is the processes in the mouth with metal framework. So these are the different kind of obturators which we can make as per the requirement. So this is by the home take message. The quality of life is equally important to life itself. If you have any query, can note down my number and mobile, and you are always welcome for any type of queries. Thank you.
Thank you so much, sir. It was a very, very comprehensive and detailed information that you gave to all of us regarding the prosthetic rehabilitation, especially about the obturators. So I'm sure some budding prosthodontists must have gained a lot of knowledge that how they have to do the rehabilitation. Your lecture was really very insightful. Thank you to have you here.
Thank you.
Anybody has any questions from sir, they can please ask sir.
Yeah. You can ask me now, or you can ask me through mail or my number also.
Okay, sir. Okay. Sir, you can just share your email ID in the chat box, so
Yeah,
they can
it is.
just, yeah.
I will show you last slide.
Okay, sir. Okay.
Chat में डाल देता हूँ DRHIMANU4@gmail.com.
Okay, sir. Thank you, sir.
Just a minute, I'm typing. And my mobile number is 98370 63005. Got it?
Yes, sir. Thank you so much, sir. Thank you.
Thank you.
It was
Thank
lovely to have you here. Thank you.
you. My pleasure too. Thank you.
Dr. Nurul, we can go ahead with the next speaker.
Thanks, Smriti. Thanks, Dr. Himanshu, for sparing your time and joining us in our International Oral Cancer Congress 2025.
Thank you for giving me chance. This is good for me also.
With your permission, we are moving to the next speaker. He is joining from US.
Sure.
Yeah. So over to Dr. Irfanul Haq. Are you there in the meeting room?
Yeah, I'm here, Dr. Nur.
Yeah, please.
Well, I think this is our last speaker for the day, Dr. Nur. Yeah. So please welcome Dr. Snehalji Patel. He is an attending surgeon in the head and neck services at Memorial Sloan Kettering Cancer Center and professor of otolaryngology at the Weill Medical College of Cornell University, New York. He is an internationally renowned expert in the multidisciplinary treatment of complex tumors of the head and neck area and is especially interested in minimally invasive image-guided treatment approaches. Dr. Patel has a special interest in developing new technology and approaches for the treatment of patients with head and neck cancer. The overall goal of his research is to improve outcome of treatment, patient satisfaction, and post-therapy quality of life. His multi-pronged research program includes development of new technology for in vivo imaging and minimally invasive treatment of tumors, evaluation of patient expectations, and development of novel patient education techniques, development of statistical methods for predicting individualized outcomes, and assessment of quality of care, post-therapy patient satisfaction and quality of life. He holds several US patents for novel technology and methods for imaging and surgical applications of his research efforts. His research has been funded by competitive peer-reviewed intra and extramural grants. He is a member of the several national and international societies and scientific committees. And he is the co-chair of the American Joint Committee on Cancer of Head and Neck Staging Task Force for developing the 9th version of the staging system of the head and neck cancers. His clinical research has resulted in over 400 peer-reviewed scientific publications, in addition to numerous books and chapters. And he holds the 3 textbooks on head and neck cancer. It's a long introduction for him. He is such a known figure in the head and neck surgery. So please welcome him. He is our last speaker, and he hope his presentation will help all the people who are there in the hall. Thank you so much.
Well, thank you very much, Dr. Huck. That was very generous introduction. And I'd like to begin by thanking you all on behalf of IFNOS, the International Federation of Head and Neck Oncologic Societies, for reaching out to us and fostering this collaboration. So thank you, Dr. Anwar and Dr. Somay and the organizing committee for the invitation. As was just mentioned, I have a special interest in developing new technology for in vivo imaging. And the topic that I've picked here for today is for early diagnosis of oral cancer. I have several patents. These are my disclosures. And one of them is a molecular imaging probe that we will be talking about today. So that's the disclosure for today. Now, when you talk about oral cancer, I don't need to remind you you see these kind of numbers on most introductory slides. The important thing to understand is that in your part of the world, oral cancer is very common. In fact, it's about a quarter of the global burden of oral cancer. And even within a place like India, the most affected people often live in resource-poor areas where they can't really access healthcare. So that's an important dynamic that's often lost in these kind of statistics. Important to understand when you're trying to develop any strategy for early diagnosis or screening. In the US, it's not as big a problem. And these are the numbers that were estimated for 2024. As you can see, it's not a huge problem. But the issue here is in the US, although the oral cancer incidence is declining, except for tongue cancer, and that's consistent with less prevalence of cigarette smoking over the past few decades. But the big problem is that the stage at diagnosis, if you look at how patients are diagnosed, the stage at diagnosis has not changed. And that is very, very important to understand because most patients, even in the US, are diagnosed at a later stage. And the obvious impact of that is the later the stage at diagnosis, the worse the prognosis. Early cancers do well. Cancers that have spread to the lymph nodes or distantly do not do as well. So that's the importance of early diagnosis. And this is really why, if you look at the population-based statistics in the US even, the survival outcomes have not really improved over the past few decades. So as most diseases, prevention is better than cure. There's been a whole lot of effort on strategies such as chemo prevention. And tobacco use has declined in the developed world, which is a good thing. But there are no really effective chemo prevention strategies. So we do not have any reliable means of preventing oral cancer. Education has also helped, but even with good educational material for the public and for healthcare providers, this has had limited impact. And that leaves us with the strategy of screening. And there's a very fundamental principle of screening, which is that you're examining people who are apparently free from oral cancer in order to figure out who has the cancer probably versus those who do not. So you're just trying to pick out people who may have cancer and treat them early or even prevent a pre-malignant lesion from progressing to cancer. And there's very well-defined criteria for implementation of screening program. I won't go into the details here, other than to say that when you're developing a screening test, it has to be simple, it has to be safe, and it has to be acceptable to the population that you're screening. Scientifically, it has to be sensitive, it has to be accurate, and practically, it has to be reproducible and it has to be cost effective. So this is what we will talk about as I take you through the rest of the talk. How do we develop a test that can fulfill some of or all of these criteria? Now, for oral cancer, all of you are aware, the easiest screening test, which is just visual examination, is completely unreliable. Even in experienced hands, it's hard to tell sometimes what's a premalignant lesion. Is it transforming to cancer? If there's a large field defect, where do you biopsy? Do you just take out the whole lesion? So there are lots of conundrums when it comes to early diagnosis of oral cancer. And you may well be aware that there are many in vivo diagnostic adjuncts, simple things such as Lugol's iodine or toluidine blue are often used. Sometimes they're combined with other light sources such as Visilight or Wellscope. And you probably are also aware that you can do a brush cytology of a suspicious lesion. The trouble with all of these technologies is that none of these are reliable. And they're often very non-specific. So there is a real need to develop technology or means for early diagnosis, not just for improving survival, but also improving functional outcomes. Because if you have a tumor that's an early stage tumor, you can very often treat it with just surgery alone. And the higher the stage, the more the chance that you will need post-operative radiation, or often even post-operative radiation combined with chemotherapy. The more treatment you add, the more side effects you get, especially in the head and neck area. There's many vital functions that are impacted, and specifically to the oral cavity, there's many aspects of the patient's quality of life that immediately get impacted when you do any sort of treatment, including chemoradiation therapy. And this is a classic example of an anti-gump deformity, probably the most drastic form of morbidity that you can inflict on a patient. So it's very important to develop strategies for early diagnosis. And there's a lot of strategies. There's saliva-based strategies. There are screening strategies. And there's a whole list of optical technologies that are also being researched. What I will share with you today is the effort that we have here at Memorial Sloan Kettering in developing technology for in vivo imaging for oral cancer. And I'll restrict my comments to two modalities that we've developed here. The first one is a technology called PARP-IFL, which stands for PARP inhibitor fluorescence imaging, that was developed in conjunction or collaboration with a chemist, Thomas Reiner, who used to be at Memorial. He's left since. But this is technology that was developed as a collaborative effort. And just to very quickly give you some basic idea of how it works is the PARP family of enzymes are very important in repairing single-strand DNA breaks. Wherever there's DNA damage, these enzymes are recruited so that PARP1 expression or overexpression occurs pretty much universally in all tumors due to proliferation and accumulation of genomic defects. And basically, these genomic breaks are leveraged, and people have used PARP1 inhibitors for about a decade now, just over a decade. And they're FDA approved for treatment of many cancers, including breast cancer, ovarian cancer, lung cancer, pancreatic cancer, and such. So this is a drug that's already in clinical trials and clinical use for many years. And what we are doing is we are leveraging the widespread expression of PARP1 as an ideal tumor imaging target because we are not trying to cure the cancer. We're just trying to use PARP1 as an imaging agent because the sensitivity of tumors to PARP inhibition is very variable. So important to understand, we're not trying to treat the oral cancer. We're just trying to use PARP1 as an imaging target. The challenge is that PARP1 resides within the nucleus. So it's a nuclear target, and most fluorescent agents and probes do not transgress the nuclear membrane very easily. But with some very fancy and clever biochemistry, Thomas Reiner and his group have developed these two molecules. One, which is a PARP inhibitor agent, that's the olaparib drug that I just mentioned, which is linked to a fluorophore. It's a fluorescent agent that this molecule's linked to, so that when you shine an infrared light on the compound, it fluoresces green. The other technology that they've developed uses radioactivity, but I will not talk about that today. So this is one of the initial experiments that led us to believe that fluorescence imaging might be useful in early diagnosis or in vivo imaging of cancer. This is a mouse model with a tumor on the flank, and there's a dorsal chamber here through which you can image the tumor in situ on the animal. So what happens is we're going to inject the compound PARP-IFL, which is the fluorescent compound, which is specific for cancer, into the tail vein of the mouse. And then we're going to image this area overlying the tumor with near infrared light. And you can immediately see the tumor vasculature lighting up green because the dye extravasates through the intravenous, intratumoral arterial system into the extravascular matrix, and then it's retained by the tumor nuclei for a period of about 2 hours. So it's a very effective strategy if you're trying to differentiate tumor versus normal. And here's an actual human oral cancer specimen where we've done PARP1 immunohistochemistry. So the brown dots are the tumor cells, the nuclei that are stained with PARP1 inhibitor versus the normal, which does not stain brown. And there's a very clear-cut line between tumor and normal, as you can see here. So with these kind of background data, we reached out to our collaborators in India. This is from Dr. Moni Kuriakose he was in Kochi, or actually Bangalore at the time. And we stained oral premalignant lesions, benign mucosa, oral premalignant lesions, and tumors with the PARP1 immunohistochemistry. And as you can see here, there's a nice gradation with benign and low-grade PMNs not really staining much. And as you progress along the spectrum with moderate and severe dysplasia, there is some more staining, but there is a big differential between cancer and premalignant versus benign lesions. So this is the property that we want to leverage when we're trying to differentiate tumor versus non-tumor in vivo in patients. I showed you the intravenous application, but that's not really very practical when you're trying to develop a screening test. You want something that's easier, more acceptable to patients, and even untrained volunteers can implement it in the field, which is why we thought about topical application of PARP-IFL. And these are animal experiments. This is a mouse experiment proving the proof of concept. There's a tumor in the tongue, and basically we wash the oral cavity with the compound and then image it with fluorescence imaging here. You can see the signal. And then when you do the immunohistochemistry, the tumor expresses PARP-IFL versus the normal, which does not. And based on these kind of preliminary data, we were able to approach the FDA and get a investigational new drug approval for clinical use. And the important attributes of the drug, anything that you want to use for screening studies or early detection, is that it should be effective in very low doses, micromolar doses. Compared to the therapeutic dose, this is about 1,000 times less than the therapeutic dose. So you're worried about side effects. And that's why you want to use very, very low doses in potentially normal people that you're screening. Also, it has to be cost effective. If the price of the technology is prohibitive, it's not going to be used in populations where it matters the most. And certainly in places like India or Brazil, where you were worried about transportation, extremes of temperature, the compound has to be stable without the need for refrigeration or special handling during transport. So thankfully, we were able to manufacture or produce something, a compound that fulfills all of these criteria. And that led us to do the first in vivo imaging trial in humans. And the concept is just what I described to you for the animal experiments. So what you have is a topical imaging agent. This is the PARP-IFL agent, which the patient swishes and rinses the mouth and then spits it out. And then you have a clearing solution after a minute or so of the solution staying in the mouth, the topical imaging agent staying in the mouth, the patient rinses it out and cleans out the mouth so that in theory, only the tumor will pick up this imaging agent, while the residue that is not bound to tumor can be cleared out with the clearing solution. And then we use an infrared camera to image the oral cavity. And this is just one of the early patients to show you that we had to design it to find the optimal dose for imaging. And here's a tumor on the lateral aspect of the tongue. And this was with just the smallest dose possible. And you already see a signal. It's not very strong, but you see that the tumor, this part, fluoresces pretty strongly with just the smallest dose of fluorescence. And as you go up the ladder and increase the dose, you see that there's a nice delineation between non-tumor and tumor which fluoresces in green. And you can see here on the bar chart that the differential is pretty significant, which is an important attribute when you're trying to develop a fluorescence agent or in vivo imaging. The other thing that's important is specificity. So this is a patient who had a biopsy of a tumor on the dorsum of the tongue, and the tumor was here on the dorsum, and there was a benign appearing granuloma on the back where the biopsy had been done. And basically, when you look at the fluorescence signal, the tumor does fluoresce, whereas the other area, which was benign granulation, did not fluoresce. So this phase 1 study was published a few years ago, and we are ongoing now with the phase 3 part of the trial. So this is the sort of technology that can help with macroscopic or gross identification of lesions in the oral cavity in an early diagnosis setting. The next technology that I'm going to talk to you about is called reflectance confocal microscopy. And this was developed in collaboration with an optical engineer, Milind Rajadhaksha, who is part of our Department of Dermatology here at Sloan Kettering. I won't go into the physics of it other than saying that the technology uses a point source of light. It's a laser that scans the surface of the tissue. So the way I kind of explain it to people is it's like making a photocopy of the tissue that you're interested in, scanning or making a photocopy. So basically you scan the surface of the tissue. The light that's reflected from the tissue is collected back into the system through a confocal pinhole. And basically it produces a very thin optical section of the surface of the tissue that you're analyzing. And then these sequential blocks of tissue can be scanned progressively deeper, either in vivo or ex vivo, and you create optical stacks. And the raw data is then processed, and you can zoom in and out to your desired magnification. And obviously, this was very easy to do ex vivo. I won't take you through all the details, but this is a big benchtop machine where we started imaging oral tissue ex vivo outside of the patient. So these are biopsy specimens or resection specimens that we're imaging to learn about the technology and its reliability. And then we went on to develop intraoral probes shaped like a toothbrush, essentially, or a long probe like an endoscope to use inside a patient in the oral cavity. And this is what it looks like. This is the handheld machine, and the probe looks like this. So what the trial was designed to do intraoperative mapping for margins. But basically, it's the same technology that you can use for imaging a suspicious lesion if you want to take what we call an optical biopsy of the patient. So if you have a suspicious lesion, you can put the probe on the lesion and do a histologic examination. I'll show you in a minute. So basically what you do is, this is the probe. I'm placing it on the tumor, and the machine reflects light, laser light, and it's collected. It goes through the probe into a laptop or a computer that you can see in real time. So this is real-time imaging. I'm seeing the images as I'm moving the probe on the surface of the patient's mouth. And basically, here's an example of a patient who came to me after an excisional biopsy of a lesion on the right lateral border of the tongue. And as you can see here, there's not really a tumor to see. There's some scar tissue on the lateral border of the tongue. And here's my projected excision plan. And the dots represent what I think is the tumor based on palpation. So the design of the study is to image an area within the excision that's quote unquote normal to the surgeon's eye, and then compare it to tissue that looks abnormal or tumor that's marked in this circle here. And as you will see, this area was picked as normal. And when you see it in real time, you're looking at microscopic images here. The white dots are nuclei of the cells, and you'll see the outline of the cells very clearly right there. And it's nice and orderly. There's very little disorganization of the architecture. And compare it to the tumor from here, immediately you see it's all white. There's hyperkeratinization. You'll even see this structure here. That's a keratin pearl, which is a hallmark of squamous cell carcinoma. And the blood vessels are haphazard. They're not orderly. So there are patterns that you can recognize and say that this looks normal, that does not look normal. And it's a very reliable technology for imaging the surface of the mucosa. The disadvantage is that you can't image beyond like 400 or 500 microns, because that's the limitation for any optical technology. You can't image beyond a certain depth without burning or damaging the tissue. So based on our initial experience, we just actually published the double-blinded comparison in Cancer Research just last year. And this is, again, technology that's ongoing. Tata Memorial is doing a trial now using the reflectance confocal microscopy for assessing margins. So we're excited about developing these kind of in vivo technology for tissue imaging. And the application that I showed you is basically to see if we can detect cancer early by doing these optical biopsies, as we call them. But there's many other applications specifically for mapping margins, in vivo identification of normal tissue, follow-up. There's a host of applications that are applicable for this kind of technology. You can even use the optical imaging technology for ex vivo applications. So for instance, if you've done a biopsy or cytology, brush cytology, you can rapidly assess them instead of sending the specimen to a lab. You can assess them in the field. And obviously, you can assess a surgical specimen for adequacy of resection. So this is the model that we hope to bring into the field. The PARP-IFL, or the molecular imaging-based technology, which is combined with a smartphone or a filter that's attached to a smartphone for use in the field. And then you can have the same kind of technology on a benchtop for assessing biopsy specimens or brush cytology specimens. So I hope I've showed you that in vivo imaging at the cellular level is feasible. It's not science fiction. You can do it today. I'm convinced that it will facilitate screening for early diagnosis of oral cancer. And certainly from my point of view, as a head and neck surgeon, I think it'll improve the accuracy of surgical resection by not removing too much normal tissue, at the same time ensuring that we remove all cancer. And in the end, all of this effort is designed to improve survival and functional outcomes for our patients. So I'll close by thanking my team. There's a lot of fellows who've worked on this. There are my colleagues from pathology and radiology who have been instrumental, and even my colleagues from dermatology, as I showed you, for the reflectance confocal microscopy technique. So I'll end by taking questions if you have any. And thank you again for involving IFNOS and giving me the opportunity to talk to you this evening.
It was a pleasure having you, sir, with us, and it was really nice presentation, and we really enjoyed your presentation, sir.
Thank you.
And the people present in the room can take questions from sir. If anybody has any question to sir, please take it.
The whole thing was self-explanatory.
Yeah, that is there. It is there. It was very well explained, sir. And I hope this technology really helps the people who are treating these cancer patients.
Yeah.
And
Yeah, I mean, that
will really help.
Yeah, the important thing, as you mentioned, is it has to reach the audience it's supposed to reach. You know, and this is why we are collaborating with some of the leaders in the field in India. At Tata Memorial, Moni Kuriakose is in Kochi. So there's a lot of folks, the Indian Institute of Science, that we're collaborating with. And that's how we hope to make a difference.
Yes, sir. That's such a noble approach from your end, sir. And hopefully it will reach the mass in India as well. And it will be helpful for the people who are suffering from this deadly disease.
Exactly, yeah.
It's need of the rural population rather in India, where we need to go for a screening actually. So,
I mean,
sir, I request you to have a contact with interior of Maharashtra, where the institutes are working for oral cancer screening and all those things. And that will be a very great help to the population of the rural population, and that will really add a value.
Precisely. I think that this is why we're collaborating with Tata Memorial. They have outreach in Maharashtra. And I mean, the technology is not there yet. It has to be cheap enough to, be dispersed to these rural areas. But it's very, very possible. So that is why we're collaborating with Tata Memorial, but also with the Indian Institute of Sciences. There's a whole program where I don't know if you guys know Praveen Birur. He is at the forefront of oral cancer screening in Bangalore. And
is there
Moni
any way that
Kuriakose.
we can approach you for the same? And
Yeah,
we can
absolutely. Email me. Yeah, email me and let me know, and I'll put you in touch with them.
Yeah. So
And
if you can put your email ID in the chat box.
yeah, I mean, just reach out to Dr. Anwar. I think he has my email, and
That is better, yeah.
I'm happy to direct you
Anybody
to
who
them.
have any query, they can write to us and we'll forward it to Dr. Patel.
Yeah.
Any more further question?
All right. Well, I hope you guys enjoy the rest of the evening. I think it's late, around 9:30 there.
No, it's quarter to 8 actually. It's
Okay, so not too bad then.
No, not at all. That's why yesterday Dr. Sonal was joined. Sonal is Shah. I think you.
I see.
Yeah. So she too joined around 7:30 at our time, and she
I
said,
see.
"I haven't slept actually. I just mid of my sleep and I'm presenting and I'm going to sleep." This is a
All right.
morning. We are. That's why we are taking the time of our program till 8 o'clock so that we can accommodate the speakers from states of India, United.
Yeah, no, I mean that's not a problem for me. I do these at odd times of the night. So thank you for accommodating, and once again, thank you for reaching out to IFNOS. I'm very privileged to, collaborate with you all.
Oh, great. So thanks, Dr. Snehal, for joining. And I'm also thankful to International Federation of Head and Neck Oncology Societies, IFHNOS. I will again take the name while I'm giving formal, vote of thanks. So with this closing note, we are, complete and concludes for the day for the speakers and all. Let me give the votes of thanks to those who has joined us and who made this program successful. There are many speakers across the globe. This time we have taken 2000 minutes actually. There is a marathon long say Congress. We started on Thursday, and on 2 days we have paper presentations for PG and faculties. So we are giving the opportunity to budding healthcare professionals so that they can present what they are the work they are doing in the field actually. So we are showcasing their field to global audience, and we have speakers across the world. We have the speakers from USA, UK. We have a speaker from Turkey, Italy. We have a speaker Cambodia, Singapore, Malaysia. So these are the speakers from different part of globe. That's why we are getting the insights of what the case of cancer and this oral cancer in general in different geographical places. As we know that say USA and India is the major place where we are getting the cases. In US, I think 60,000 cancer cases being reported yearly, and India it is 80,000 cancer cases. And as per some estimate, there is every 1 hour there is a one patient is dying in US for this cancer. And as you told that for world's the total oral cancer patients, 1/4 or say 1/3 is in India. And in India it's a major cancer case actually, because it's 1/3 or 30% of all the cancer, it is a oral cancer. And the problem basically is that we are not able to, as you said, means I just amazed that we thought that you are in a developed country where oral cancer is being diagnosed in the early stage, but a few of slides you shown, Dr. Patel, which shows that yes, oral cancer is being diagnosed a bit late actually in advanced stage, and this is the main problem actually. If you detect it early, and most of the focus of both the speakers who joined from USA. Yesterday, she has also spoken much about the early detection, and you are also taken the whole time for detect it early rather than focusing on management. And if we are detecting early, we are saving the there's a very huge economical loss in India. If we have estimate of 2022, we have say $6 billion is being lost due to oral cancer only. It is 0.18% of Indian GDP. So Indian government is working hard. They are working on tobacco cessation program. The public agency are working to making people aware and all. They want to. The problem basically is that we are not focusing much on a strategy. There are no strategy or policy in any part of the world for screening the patient in early stage. So this is the main issue. If we detect it early, there are 90% oral cancer or general oral cancer is preventable if we are detecting its early stage. So these are the, so that's why we are bringing all the experts across the world to discuss to what are the new trends in diagnosing the cases. And if we are not able to diagnose the case in early, then we ultimately go for its management. And that of different management regimens, we have say chemotherapy, we have radiation therapy, radiotherapy, and we have ultimately surgically we are removing the tumor. So these are the cases, and then ultimately we are also given the chance to post cancer care. Just before you, Dr. Himanshu is and Dr. Is talking much about rehabilitation through prosthetics, and then Dr. Vibhu and Dr. Abhishek, they are talking about much of rehabilitation and palliation of those patients suffering from cancer. We have also brought this time a dietitian from Mumbai. She is spoken much about how to take care of the diet. Actually, we need a protein-rich diet for a cancer patient. So these are the speakers. these are the gist which we get experience, and it's a very amazing and it's a good say experience that yesterday late evening Dr. Stefano, there is a one Cavalieri Stefano, he joined and he has spoken about some this genomic signatures to diagnosing the cases of early diseases, and talking about the prognosis, that how the cancer behaves in a coming time actually. So he has focused more about say genomics and all, and there are speakers who joined have shown that how AI is helpful to taking the decision and all. So these are the topics we have covered. We are trying to cover all the aspects of oral cancer, and we have a different specialties who joined us. We have say radiation oncologist, we have a chemotherapist, medical oncologist, oncosurgeon, head and neck surgeon, like you sir. And we have the dietitian who are there. Then we have the specialist in diagnosing the oral pathologist, and say oral and maxillofacial surgeon, and then oral radiologist, oral clinician, oral physician are there. They all are the whole infrastructure and the stakeholder who are into there to detect it as soon as possible. And it is for general dental surgeon. Most of the audience who join us, this is a fourth edition, and they are all dental surgeons, and it is the it is a burden of their on their neck and head that they should detect the case as soon as possible, so that we can save the country's money, we can save the time, we can save the manpower hour, and we can give the good quality of life for our citizens, whosoever from anywhere they belong, whether they are American, whether they are Indian, whether they are Turkish people, whosoever they are, we should detect it as early as possible. So with this note, let me, thanks our speaker one by one, my backend team, my advisory committee, the moderators, and those all have given their time to make this program successful. There are many things which is coming in front of people. The speakers are there, but there are people who are backing from back end, who are working literally very hard. They are putting their blood and sweat to make this a success, a good successful program. There is smooth, because it's all about technicality. Dr. Snehal is sitting far away from us, and we are just like we are sitting in the same room actually. So it is the technological advancement that we are making this thing possible. Otherwise, for making the physical program, it's a very uphill task, to make the air tickets and keeping the accommodation and all. Though we are switching to the physical as well, but we are first making bringing the people on a one platform, and when we are getting a good say IOCCON family, then definitely we'll go for a physical program, whether it's India or America or any place, common place where we can yeah, so we can join. So with this note, I'm just thankful to Dr. Ramya R. I'm just taking the name of our speaker who has brought value to our program. This is Dr. Ramya R. Dr. Efsun Some. She was organizing secretary, and she was from Baskent University, Turkey. Then Dr. Asim Mishra, Dr. B. Srinivasan, Dr. Vidhi Katira, Dr. Divya Raj, Professor Ruwan D. Jaisinghe. He was co-organizing chairman of this IOCCON 2023. Dr. Saidul Islam was proposed to join, but somehow he couldn't join. So we are also thankful that he has agreed to present, because he's known face in reconstruction surgery in India. Then we have Rasika Ekanaike from Sri Lanka, Dr. Gitanjali Ahuja Mengi, Dr. Vishal Rao, Professor Manjula Ategele, Dr. Vibhu Ranjan Shah, Professor Abhishek Kandwal, Dr. Himanshu Arel, Dr. Snehal Patel, who is with us right now, Professor Dr. Erkan Topkan, he is a radiation oncologist from Turkey, then Dr. Punita Vora, she is a co-organizing secretary, and I'm really thankful to Dr. Punita. I'll take your name again, and to making this program successful, because we have taken great pain to reaching out to speakers and many things we are doing from backend. Then Dr. Smith.
Thank you so much.
Dr. Ravi Kannan, then Dr. Aparna Dave. Dr. Aparna Dave is very handy. Whenever I am giving a call in any time, maybe it's 11 o'clock or 12 o'clock late evening, she would be responding. And I'm really thankful to Dr. Aparna for be available on a short notice. Then Dr. Shaili Mahajan, Dr. Vidhi Katira, Dr. Pulin Saluja from SGT University, Dr. Priti Jain, Dr. Gaurav Singh, Dr. Anand Ramanathan, he joined from Malaysia, Dr. Shakti Singh Deora, Dr. Natasha Lalwani, Dr. Kehinde K. Kanmodi joined from UK, Dr. Anjan Shah, Dr. Shahida Nasreen joined from Jammu and Kashmir as a radiation oncologist, Dr. Cavallari Stefano, he is also head and neck, rather ENT specialist. Then Dr. Anjan Shah, Dr. Shahida Nasreen, Professor Sonal Shah, she joined yesterday late evening and she has given, with latest trends in, early diagnosis of oral cancer. Then Dr. Cheena Singh, Dr. W.M. Tilaknatre joined from Malaysia. Dr. Pallavi Shukla, Dr. Avay Suresh Kulkarni. Dr. Kulkarni is making our program very interactive. He is a speaker as well as very keen, listener actually, and he is not leaving any speaker without any questions. So at least he is asking
Thank you, sir.
to everybody. Then we have Dr. Basavaraj T. Bhagwati. He was a speaker as well as honorable judge for the paper presentation competition for our faculties. Then Dr. Efsun Some, Dr. J.K. Singh. Dr. J.K. Singh has given a keynote speak. Then Dr. Kariba Sappa, Dr. Rakesh Gupta, Dr. Ugur Slek from Turkey, Dr. Nilantha Ratanaike, he joined from Sri Lanka, Dr. Davis Thomas, he joined from USA, Dr. Gitanjali, and Dr. Esha Noshin. These were the speakers. Let me be thankful to our organizing committee. I'm taking the name again. Professor Ruwandu Jaisinghe, he was a co-organizing chairman. Dr. Efsun Some, organizing secretary. Then Professor Arindam Sakar, he was a patron of us, and we are really thankful to Dr. Arindam for guiding us to making this event successful. Then we have again Dr. Punita Vora. Dr. Punita, we are again thankful to you to making coordinating with moderators, making speakers available, coordinating with your SGT University. You have handy in getting the CDE points. We are getting 18 CDE points because Haryana State Dental Council has given us that those who are attending this program, they will be getting 18 CDE points. Then we are thankful to Dr. Kajal Malhotra, Dr. Sonal Yarkude, Dr. Aparna Dave, Dr. Komal Sharma, Dr. A. Sri Vidya. Then we have advisory committee who help us in planning and strategizing this program, Dr. S.S. Ahmed, Dr. Davis Thomas, Dr. Madan Mohan, and Dr. Atul Kumar, here from SGT University. These are the partner of us. We have 3 partners. MedSkill is the organizing body, and the partner is National Health Academy, Delhi, Faculty of Dental Sciences, SGT University, Gurgaon, and then International Federation of Health and Neck Oncology Society from US. Then the people who help us from SGT Universities, Dr. Atul Kumar, Dr. Hardeep Singh, Dr. Purnima Baliga, Dr. Yogendra Yadav, Dr. Omkar Krishna Reddy, he is a dean over there, and under his leadership, we are doing this program. We are also thankful to Dr. Astha Chaudhary. Now, just I said earlier that these are the people who are not on screen. They are out of the screen, but they are really great help to making this program successful, making reaching out to the various stakeholders. Miss Zareen Sava is there, who is a telecalling team, and he is talking to the registrant for making registration. Dr. S. Rehan, Mr. Amir Rehan, Mr. Rehan Anwar, Mr. S. Anwar, Mr. Ayan, Mr. Syed Absar. Then we have Israfil Khan, who is heading our IT team. Then Mr. Khalid, who designed our brochures and all promotional materials. And then I have to thank to all my moderating team who is involved from Thursday onwards. These are the young dentist academicians from SGT University, Dr. Dia, Dr. Komal, Dr. Sri Vidya, Dr. Sumrudhi, Dr. Yashna, Dr. Shakshi, and ultimately Dr. Irfanul Haq, who is with us. So with this note, we are closing for today, and we would be coming with our learning and understanding a better program in 2026 around World Cancer Day. 4th of February is being celebrated as a World Cancer Day. There are a few of upcoming programs of MedSkill and National Health Academy. on various dental students. We are organizing International Pink Dental Congress, which is happening on March 7th and 8th. We have International Sleep Medicine Congress. We're doing it on 15th of 16th March. Then we have International AAA Congress, then International Oral Hygiene Congress, International Youth Dental Congress, and International Sports Medicine Congress. This will be happening in another 2 to 3 months. So with this note, we are closing our this 2022-25 edition of International Oral Cancer Congress. And I am tender my advance apology if I am missed anybody's name, because there's many people who helped us, who supported us, who guided us, who patroned us. So if I have missed anybody, I'm tendering my apology. And with this note, I am closing for this 2025 event. Anybody who want to have any suggestions, any question, they can ask right away. The second thing I would like to tell you about that the certificates of this program is available from tomorrow onwards. It is available on portal. You just have to log in and you will easily able to download the certificates from the portal. So with this note, I would request Dr. Punita if you want to add something as a co-organizing secretary, and then we'll close for the day. Over to Dr. Punita.
Thank you, Dr. Nurul. You were such a great organizer. I would like to express my heartful gratitude to you, each and every one of you, for organizing such a successful International Oral Cancer Congress. Your tireless efforts, your patience, your dedication, and your attention to all the details have made this event a truly unforgettable experience for all of us. I thank you once again and looking forward to more such programs so that all the people who are listening to it, they are more dedicated and more passionate towards their work. Thank you so much once again, Dr. Nurul. It was a great success, I'm sure.
Thanks.
We must congratulate you, sir, Nural sir, for
Yeah.
arranging such a wonderful program and giving us a knowledge. And the efforts you have taken is really appreciated. And this is the
Exactly.
first time I am working with you, and it will be my pleasure to work with you in future also. Any kind of help in organizing all those things also, I'll be very much happy, sir. And working with you itself is a learning experience. So congratulates and thank you very much.
Dr. Sanehal, you are there actually, and you are also a patron and a partner. So I request you, could you please say something? You have covered your academic part. Can you give us some motivation so that will work in future as well? So just a few words from you. Dr. Sanehal, I'm just requesting, yeah.
Oh, sorry, I didn't catch that. Well, I joined late, so I can see the enthusiasm and all the effort that you guys have put in. And from a distance, not knowing the intricate workings, I can still get the sense that you're a very tightly knit group. Keep up the good work. I think it's very, very difficult to organize these things, as you pointed out. But technology has thankfully, brought us closer. I'm sitting here in New York. You're, spread out all around India and the world. So, keep up the good work. And like I said, IFNOS is an international organization, and we are very, very happy to provide you any support that we can. So please reach out to us if we can be of any help, not just with organizing meetings, but also collaborations. I'm always looking for people to collaborate on research projects. So reach out to us. Be my pleasure and privilege to help. But once again, congratulations. The work that you guys do is where it'll matter. India, is there's a plague of oral cancer. So hopefully you'll make a difference. Congratulations.
Thanks, Dr. Sanehal. Thanks. Dr. Irfan, if you'd like to add anything. Dr. Irfan, are you there? Okay, so most of the thing I have covered, and
Yeah, Dr. Nurul, first of all, congratulations to the whole organizing team, especially led by our very able Dr. Nurul Anwar. I know him since his college days. I was just senior to him in his college. And I know him, he is a very dedicated person. Whatever he thinks of doing, he will do it. I know him. And it was really pleasure being part of it, though I joined late, but I really missed something. Hopefully from the next edition, I'll.
Yeah, it's actually net connectivity is gone. So with this note, we would be connected with this multiple ways. We have the WhatsApp, email, call, everything. And as Dr. Kulkarni said, anybody who want to connect with Dr. Snehal, they can email to us and we'll forward it to Dr. Snehal and we'll wait for the response from him. With this note, with this note, we are just closing for the day and we'll join again with this 2026 International Oral Cancer Congress with more zeal and newer team members, newer speakers, and newer geographies and all. So with this note, I'm just signing off the day and your certificates are available tomorrow onwards. And those anybody have any issue, the email IDs are there on the brochure and the contact number are also there. So you can easily reach out to us and we'll definitely get back to you for any issue or post program for certificates and anything. Thanks all joining. There is a thing, speakers and lecturers were really good. Thank you so much. Thanks everybody. Thanks for motivating us and thanks Snehal again for staying so long with us. It's a morning there. So we hope that this is a morning for us healthcare as well, so that we have a new sunshine. We have a better world with free from oral cancer. Over. Thanks everybody. Thanks. I'm just signing
Good
off.
luck.
Okay.